that 12 is the same.
1 p.m.
Yes, and I told
Okay.
him that it's 1 p.m. Germany, European time.
Fine. Ok. Ok, c'était à 14 heures. Ah, tout de suite? Non.
Nelson, now what time is in Atlanta now? 6 hours between us now or 5?
It's almost 7 o'clock. I moved from Atlanta, Ab.
Oh,
I'm
yeah,
now in
sorry.
North
Yeah, you told me.
Carolina. Yes,
Yeah,
but
yeah.
the same time is the same time.
So it's 5 hours.
Yes, same time
Because
as
now
in
it's
East Coast.
12 and it's 7. Yes.
Yes.
5 hours.
Yes.
Yeah.
Yeah, I would.
Faut pas oublier de dire qu'on va partager la vidéo de. Voilà, comme ça, je partage.
Comment on dit en anglais
We share a video.
Comment ça se passe votre installation? How is your installation in North Carolina?
That's cool.
أنا كنسمعوا لكم كل شيء يا فهد.
Pardon.
Naja.
Yes, how are you?
I'm well. I'm well. You have my cell phone, I'm sure.
Have you changed it?
No, same cell phone. You have my cell phone.
Yeah.
Yes.
Because my talk is at 2 hours and 45 minutes from now.
Okay, we will change it. Don't worry.
It's okay. It's okay. I'm no problem.
Okay.
If you
good morning to everybody. Good afternoon.
Hi.
I
will sign back on after that time.
Hi, nice to see you. Welcome.
Yeah, good to see you, my friends. Hi, Nels.
Fine.
Hi, Moody. Hi, Andreas.
Hi, Hildo.
Yeah.
Nelson,
Nadia.
don't worry. We will be on time because I already talked to all the chairmen, the moderator, to be really very strict. So
Very
don't
good.
worry.
I will sign back on after the introduction.
Okay. I know that you are very busy with your in the New Carolina. How is it at the new hospital? It's
you have to
are
get
you
used to
familiar
everything.
now? Not yet.
No, yeah, I've done some cases. I've done since I started in the beginning of May. I've done 5 cases already, so I've started to operate. But just getting used to everything different, after so many years in one place, it's so difficult. You don't know how difficult it is. You get used to everything.
Yes.
Even finding the coffee shop is difficult.
Yes, I can imagine.
Nelson must be a very courageous man.
But we are sure that you will succeed in this task. You are,
Inshallah,
you are the
inshallah,
man
inshallah.
you are the man for the situation. I'm not.
You must be a very courageous man.
How are you, Azim?
Hi, Naja.
How are you, Hildo?
Yes, I'm all right. Thank you very much for the invitation.
Thank you so much for accepting our invitation.
Shall I share my slides now or by the start of my talk?
You want to share it?
If you wanna try them, hi, Professor.
Yeah. How can? Yeah.
Yes.
Dr. Delkawi is the coordinator.
Yeah. Hari. Abdi.
Delkawi.
Hi. Hey,
hi.
How are you?
Samad.
Hi, how are you?
Fine.
صباح الخير أستاذ.
صباح الخير سعد صمد.
Salut bien, بخير.
أنا عبد الصمد استخمليش.
أهلا وي les deux عبد الصمد وكاري.
Comment allez-vous, monsieur Khamlichi?
Ça va très bien et vous deux?
وحشناك.
الله يبارك فيك. Merci beaucoup.
Ça va Légia, ça va bien?
Ça va, très bien, alhamdoulilah, et toi?
Avec nous.
Again,
professeur.
Yes, Professor Azevedo, if you want to try your slides.
Yeah, I can. Okay. Okay. Can share my slides now?
Yes, please.
Yeah.
We do not see your slides yet.
I'm trying to put up.
Rushdie Khayat is there?
I hope not yet, but he received all the things, links and invitation. And he sent me what message this morning.
Okay.
It's okay. Yes. Yes, it's okay.
Right.
It's okay. Thank you.
Okay, fine.
Nice. So we will.
Please, can you check? Professor Khamlichi, can you check with Professor Majid Sami because we are waiting for him. We need to start in 2 minutes.
3 minutes.
Can I quickly
check?
share my screen and check?
I will
Yes,
try
please.
Okay.
Hi, Professor Ulish.
Hi, Fad.
Hi, Professor Qurashi.
How are you?
Fine.
Hello.
Nice to see you.
Morning.
Good to see you too.
Morning, Nadia.
Hello. Good morning, Professor Basso.
Oh,
Hello.
good morning, Armando. How are you?
Hello.
Hello, hello.
Hi, Armando.
Do you see my slide, Fad?
Not yet.
Okay.
Oh, finally. Professor Majid Sami is here. How are you,
Oh, good.
Professor?
Hi.
Nice to see you, really.
Professor Sami.
What about now?
So
Fad?
it's nice.
Good.
Very good. Very good.
Fad, you can
Okay.
see my slide?
Yes. Yes, Professor Qurashi.
Okay, great.
Yes,
Thank
it's
you.
good.
So we are on time. I think we will start in 1 minute. 1 or 2 minutes.
So
Okay. My collaborator and Professor Dr. Darqawi, he's actually he's the vice president for Moroccan Society, and he's collaborator in my department, and he's our master in webinars and symposium and etc. And of course, he is always working hard for this for the education to organizing with us all these nice and wonderful meetings. Thanks,
it's
Fed.
my honor and my pleasure.
Okay, so. Oh, hi, Ulrich. Ulrich, how are you? You are in
Hey, I'm fine.
Hi.
I'm fine.
Hi,
Thank
nice
you very
to
much
see you. How are
for your
you?
invitation.
Oh, it's really very nice to see you, and thank you again, and thank you so much to join us for this this masterclass course.
Yeah, thank you very much for your invitation.
Oh, it's my pleasure. It's our pleasure.
So we will open the webinar for participants, and 60 minutes seconds after, we will start the course with the message of Professor Labedi. So.
Hello, Majid. Good morning. Good afternoon.
Armando, pleasure to see you. Pleasure to see you.
Pleasure to see you.
Professor Majid Sami, you have a nice picture behind you.
Yes.
Is your Japanese garden?
Yes. My garden, yes, behind me.
Yes.
Yes.
No.
And I hope you will come soon to Hanover and can see. We can have a grill party in the garden.
Yes.
Thank you.
I remember.
Yeah, pleasure. And I think just to come together and see each other, this a little bit reduce this corona feeling, you know.
Yeah,
exactly. Yes.
Majid, Basu, nice to see you both.
Oh, Hildo.
Hello.
What a
Hello,
pleasure.
Hildo.
I'm sorry for my voice because I think I'm with COVID now.
Ah, you are perhaps in opera and singing, yeah?
No, yeah, I already had 2 jabs of the coronavac. I'm symptomatic. I did the test yesterday. I don't know yet whether it's positive or not, but I think that I got COVID.
Oh my God.
I'm all right now. Sorry for my voice.
It sounds like the Godfather, so it's all right.
Oh, Mahmoud Qureshi, how are you? How are you?
It's so nice to see you.
Pleasure.
Hi, Modi. Hi, Modi. How
Hi,
are you?
Professor Basso. How are you?
What a pleasure.
Very good.
Mahmoud, we need to talk together soon about about committee and Africa 100. We have to
revitalize it. It is
Yes.
going strong. It is going strong, but
Yes.
we want to push it more.
Yes, we need to really make the corona has a little bit suppressed everything, but now is the time to go on and extend that as much as possible. Yeah.
Fed, we have maybe to start, Fed.
Yes.
I think, yes. Are you ready, Professor Abadi?
Yes.
So we
morning,
start
Ab.
now. Good
Morning.
morning, everyone. And Professor Abadi, you have the floor.
Thank you, Fahd. Dear masters, dear colleagues, dear friends, welcome and welcome to this WFNS Rabat Reference Center master course for African neurosurgeons. We are really very delighted and honored to welcome you to this event, which is the lasting for 13 years ago. And it's a wonderful experience for us. And we want to defend this experience study. Human contact, as you said, Professor Majid Sami, is so important. We want to feel what the other says. We want to understand their emotions, their stupefactions, their silence. This is basically why humanity exists and why relationships are so important. But the presence of the giant neurosurgeon to this meeting this morning is important. But what can we do when a virus is bothering everything and changing everything? We have to adjust ourselves to a new situation. Even if we disagree, there is no other alternative. We have to move on, move on, and we have to continue to try to have academic exchanges in a good conditions, and that is the reason why we had decided to propose again to you this African master course that is going to be adapted to the situation. Everybody knows that it is Professor Al-Khamlishi who had the idea to create this course and this center. And of course, with the great help and the commitment of many pioneers of WFNS honorary president attending today with us this course and supporting the neurosurgical education provided by our WFNS center. All of us know that all the colleagues present today at this course have contributed to this its creation and the presidency under Professor Majid Sami at that time. Today's meeting is a tribute that we would like to pay to all our colleagues who have supported this project, which is currently a successful South cooperation program, as well as the 100 Africa program initiated and launched by Professor Majid Sami. And we hope with the different cooperation to increase the number of trained neurosurgeons across different continents, thanks again to our elders, almost all present today, to develop our wonderful specialty. The pillar is the dynamic and the exchanges between the international faculties and the African and worldwide attendees. Attendees are so important for this education, and because they can meet all the partners and the giant as we have today. And of course, I'm very thankful for all the speakers that also accept our invitation and share their experience with us. Please join us for this WFNS Rabat Reference Center Master Course for African Neurosurgeon, which for sure will keep the same spirit. We look forward to our enthusiastic participation, and we promise to be a great gourmet of our neurosurgical entries. Thank you so much for participation and accepting our invitation. And just after Professor Franco Servidei, he apologized couldn't be with us today for some commitment, but he sent us his message by video, and I ask Fed, please, can you give us the message of
Friends, dear colleagues, my name is Franco Servidei, and I am the president of the World Federation of Neurosurgical Societies. I am so sad that this year I cannot come and see you personally for the WFNS training course in Rabat. I have been to at least 2 previous courses, and I really appreciated the quality of the training that you have received on behalf of the World Federation. And I also had the opportunity to meet many of you who are now working in different African countries. The right way to increase the number of neurosurgery is a good education, and is an education in the same continent where you are going to work afterwards. So I am really thankful to Professor El Abadi, to Professor Halawabi, to Professor El Kamlichi, and to all my friends in Morocco who spend so much time and efforts to work and to teach you neurosurgery. So I wish this meeting all the best. I miss you, all of you, and I hope in the near future we will again be able to travel and see each other. Bye.
Bye. Thank you. I'm sure that we will miss you also, and I'm sure if you can do it, you do it. So thank you for your message, Professor Servidei. And then we move to our ambassador to Africa, Professor of WFNS, Professor Majid Sami, to give us some words. You have the floor, Professor Majid Sami.
My dear Nadia,
thank you again.
First of all, I would like to thank you for the invitation and congratulations to organize such a scientific program for education of African neurosurgeon. I take this opportunity to emphasize how it was some interruption. I emphasize that the history of these African activities goes back to 1900, I would say 97 and 98. I think Dr. Hamlichi is a witness of the meeting, AC meeting, as I was the president of the World Federation. And I asked at that time, as I took the office, and immediately I started to find out how I can help the neurosurgeon around the world, and asked all the second vice president, please give me a statistic about the condition of neurosurgery of your continent. Abdul Salam Hamlichi came 1998 with a fantastic evaluation and a statistic, and showed me. And I was really shocked at that time because he demonstrated that at that time, the inhabitants of Sub-Saharan Africa, also Middle Africa, was a little bit more than 500 billion population. And the number of neurosurgeons was 79. That is the statistic which is also published. And at that time, I saw that we had in Germany 80 million people, and we had 1,200 neurosurgeons. And that was really, and also the same relationship of neurosurgeon to the population I saw in the industrial countries. And that was really the main reason that I say I have to help. There is no other choice for me as president. I took this office, that is my obligation to do something. And then I have created the foundation by myself. I was really the founder of this foundation is existing. And Abdul Salam Hamdishi is witness that in this AC meeting, I said, my dear colleagues, officers, we need to help. I create foundation. I put some money in that. And I must say, I was happy. The first person who said, idea is great. May I also support this idea? That was Martin Rodriguez. We should not forget it. And this is the real history. Everything else is written is wrong on its manipulation, I must say. It's not correct. Whatever you read in any report is different than that. And later, I think Armando Paso is also witness. Later, and I become also responsible for this foundation. And then I say, okay, we collect money and we try to start education of African young people. But I said at that time in that meeting, I am not going to do the mistake what John F. Kennedy did in 1961. He brought 100 African people to America in different fields, and all of them went back to, didn't go back and remain in America. One of them was Obama's father, who went to Hawaii, and Obama is born and there then become president of America. And this is the real history and the background of my thinking at that time. I said no. And therefore I asked Dr. Hamdishi, are you so kind? Can you organize such a center? He said, of course, I will do it and I will try it. And I think he had to talk with the university, to government, to many people in order to get all the permission. This is the history of Rabat. And then in this situation, he came 1 year later, said, yes, I have organized. And then we decided at that time to give around $5,000 from our foundation to support each person who goes to Rabat to be educated. Also, therefore, I said this because, my dear Natia, you must know, we should not forget the history. And I advise to everybody, please don't manipulate the history in the World Federation. This is not acceptable if we try to. The work which Abdul Salam Hamdishi has started is something which I must say one of the most important commitments which also tried to fulfill also my desire for Africa. And in the meantime, we know how many people. I want to thank also later as I become ambassador for Africa, I want to thank Mahmoud Qureshi, who I had a long discussion with him. And I said, Mahmoud, I want to nominate you as General Secretary for a committee, which is very important. Believe me, Mahmoud, your position in that is more important to be president of Cannes. To be president of Cannes after 2-3 years, you are not anymore, or everybody will forget it. But that's what you are doing for the Africa 100. It is more important and is sustaining things that will go on. And all these people who are now educated in Rabat and later in other cities and also in Algiers, they will remain forever in the next generation, and this story will not. All the presidents of any society, the people forget it. This is, believe me, look at them all, even the American president, nobody is taking care of that, who was the president of America. But people who have done something sustaining for people on the other continent or in the world, they remain always alive and also present for everybody. Therefore, I thank you, my dear Najia, that you are continuing. You are taking your effort and your power to organize such a course in order to continue this tradition. I am very, very proud of all of you, and I hope that the continent Africa, which is now, Mahmoud, I am very proud of that, Continental African Association of Neurosurgical Society. 45 countries are member of this. I am also proud of our Continental African Association, and Mahmoud is now the president, and my congratulations. Africa, I said at that time, has to become one strong voice, and now has one strong voice, and is respected around the world, and all people are educated in Rabat. Later, they will be great professor and teacher in Africa and distribute the knowledge to all population in Africa. Thank you very much. And thank you. You gave me this opportunity to say about the history and about the future of Africa. Thank you very much.
The story of this creation of this center, I just starting in my beginning of speech to telling little bit, because I know that you are the master of this project. And of course, Professor Khamisi, as you said, judiciously he came with the dramatic statistic, and but he found an area to listen you. And thank you so much for this, and for all that you did for Africa, and you are continuing to doing, and also for your generosity with the Africa 100. We never forget it, and I think people we will not forget it. I'm sure in WFNS and other association, we are here, and there are many colleagues to recall them and to remind them that WFNS under your presidency create one of the great program, and is the success of this program and this cooperation South and South, and as you said in the beginning, what happened in America, for example. Now we are very proud, and thank you so much for your contribution. So we move to the next speaker. It's Professor Mahmoud Qureshi. You have the floor. Is the president of CANS, of course, but he's also, as Professor Majid Sami said, he's the secretary of one of the program, very important and very providing more and more young neurosurgeons. Moody, you have the floor. Thank you. Thank you to join us.
Thank you very much, Najia, for your kind invitation. You personally rang and asked me to be present at this meeting. I was only too pleased to say yes. Professor Khamlishi, always a pleasure to see you, and all my colleagues. And Professor Majid Sami, with due respect, I will start my message, if I may. I know Professor Servadae is not with us, but I will greet him because it is being recorded. The president of WFNS, Professor Franco Servadae, President-elect Nelson Oyeseku, my esteemed colleagues of the WFNS, AC, and its member societies globally. I bring you warm greetings from the leadership and members of all societies, and joined by our Continental Association, CANS. At this juncture, may I take the opportunity to pay tribute to two stalwarts whose dedication and support led to the unification of all national and regional societies of Africa into one strong continental society. As you have heard, Professor Majid Sami, we owe you a huge debt of gratitude for what you did personally for us during your visit to Nairobi on 28th January 2012. And you ensured the formation through your meticulous and long-standing respect and lobbying abilities to bring together all our neurosurgical colleagues, both national and regional, to form that society on the 28th of January, we decided. We also want to thank together our own neurosurgical stalwart, Professor Abdussalam Khamdishi, for this, because of them, the strength and direction of neurosurgery, as we have heard, has taken a huge step forward. On behalf of members of CANS and its hardworking and dedicated Administrative Council, I wish to thank and congratulate Professor Najia Al-Abadi, and who is also our nominee for President-elect of the WFNS, may I state at this point, and also her team, especially her superbly efficient coordinator of the course, my dear friend Fahad Hassani and Adil Marhoui, for organizing this superb masterclass conference at which our continent's neurosurgeons, both young and the not so young, are set to witness the masters in neurosurgery from across the globe come together to teach them and address them. To all participants, lecturers, facilitators, Africa and CANS conveys its gratitude to you and all of you for your presence today. I wish all of you successful deliberations. Thank you once again, Najia, for allowing me to share this platform. Thank you.
Thank you. Thank you very much, Moody, for your perpetual support for all the African neurosurgeons and what they are doing under your presidency as a CANS president. Thank you so much for being with us and supporting always all the activity that we are organizing. Thank you. So the last but not the least message from our director of WFNS Rabat Reference Center for Young Neurosurgeon, the creator of this center, the idea also, my master professor Abdussalam Khamdishi. You have the floor to give us the message and maybe give us more and more about our center. I voluntarily didn't spoke a lot about the center because it is your baby first, and we are just follow your step, and we hope that we can succeed in following you in this strategy. Thank you so much.
Thank you. Thank you so much, Najia, and thank you for all the colleagues, mainly those who said a lot about the history of this center, Professor Sami, Professor Mahmoud Qurashi. This opportunity is really a special one, of course, to remind to all of us this history, and I totally agree with Professor Sami, as I have the chance to attend this administrative council, WFNS Administrative Council. It was spoken on in 1998 regarding the real starting of the WFNS Foundation and the WFNS Rabat Training Center program. So thank you so much. I would like, of course, to welcome all of you and to thank you for attending and participating in this yearly WFNS Rabat Training Center course. Of course, it has already said, I would love to have all of you in Rabat and gather you in person to, of course, share and exchange science, but also to be together to taste the delicious Moroccan food, and also to share experience and talk during the coffee breaks, and to relax during dinners, as it was in all the other courses last years. But unfortunately, with the pandemic, it wasn't possible. And I hope that it will be possible for us to do that as soon as possible, maybe, I hope, next year. Anyway, the organizing committee and myself are proud and really delighted to have such outstanding faculty and coordinators of the sessions participating in this WFNS Rabat training course. Mainly, many of them are our well-respected WFNS honorary president, who were, and it was said by Professor Sami and Professor Qurashi, who were the initiators of this program and supported this program. I would like to mention that this WFNS Rabat training center and other regional training center which were created some 10 years later in Dakar, in Nairobi, in Recife, in Algiers, contributed a lot to the evolution and the development of neurosurgery in Africa. This, in addition to more than 150 young neurosurgeons already trained in these centers, I think that this originally a new way of training African neurosurgeons in their continent, as was initiated and stated by Professor Sami, was really very important and played a greater role in bringing a kind of a continental wave of enthusiasm among all young and senior African surgeons to encourage the training in all places and every time to help the young generations, because they understood, all of us, that this is the only way and the best way, of course, to improve neurosurgery in our continent. So as a result of this kind of mobilization, the number of neurosurgeons risen from just 500 in all the continent in late 1990 to more than 2,000 neurosurgeons today in Africa. And in the strategy we have already set up some years ago with the African colleagues, we are expecting to reach by 2030 a number of 3,000 to 3,500 African neurosurgeons. So this is really a great progress, and we can now understand the importance and the starting steps who were precised by Professor Sami. I would like just to add that the dream of all these African neurosurgeons today is to see African neurosurgery gaining the rightful place it deserves in the international institutions. And I would like to tell to all of you, the participants in this course, to be sure that your presence and your permanent support, of course, give either to me and to all African neurosurgeons the hope that this dream is on the way to be reached, I hope, in the near future. I have no time, I think, to say more. We'll discuss later on. Just I would like to add to congratulate the organizing committee for the effort and for the success of this course. Mainly my close colleagues Najia and Fahd. They have done a lot of effort to organize this WFNS Rabat training course this year, last year, on virtual gathering, but also they deserve our thanks, my thanks, and those of Moroccan neurosurgeons, especially for all the webinars, symposia, and courses they have organized, more than 20 or 25 during this year and a half of pandemic. So thank you so much, Najia and Fahd, because your work allowed the Moroccan Society of Neurosurgery to maintain its educational and training program, which was an engagement now since many years toward all our African colleagues. So again, welcome and thank you to all of you. Thank you very much.
Thank you, Professor Khamlichi, for this fantastic speech, and as always. And we will start the first session, which we will have some great speakers, as Professor Ikokato, Professor Yangtu, is here.
Yes, yes.
And Professor Spittler also.
Not yet.
And Professor, and my dear friend Armando, of course. So I will give the floor to my friend, Professor Abdsamad Wahabi, to moderate this session. Normally, he will moderate it with Professor Roshdi Al-Khayat from Egypt, but I think he has some problem with the connection, internet connection. And also with our great friend, Professor Maurice Schunks, who called us yesterday to join us for this master course. But I think I just called him. He has also some problem with the connection. So, Abdsamad, you have the floor to moderate this session. Thank you, and thank you so much for your help and for your engagement in this program.
Thank you, Najia. Dear colleagues and friends, good afternoon, maybe good morning. Thank you for all the speakers, for the faculty to be there here today to share with us their experience. And I am delighted to co-chair with my colleagues and friend, Dr. Roshdi Al-Khayat. I hope he will join us soon. This session on vascular and skull-base surgery, which is led by world-renowned expert neurosurgeon in this field. And really, we do not need to be introduced to the participants, but however, it's always pertinent to remind our young colleagues of the achievement and their contribution in the field of neurosurgery and mainly in education and training. So our first speaker is Professor Yoko Kato. She's here. Hi, Yoko. She is a pioneer woman neurosurgeon in Japan and has spent her entire lifetime in the service of neurosurgery and taken it to the remotest corners of the world, mainly in developing countries. Her contribution in education and training is outstanding, and mainly for young neurosurgeons. She has inspired and trained a non-child generation of neurosurgeons, and her contribution in global neurosurgery is outstanding. So we are very pleased to have you today, and please, Yoko, give your talk. Above all, I should say you are one of the best friend and great friend of Moroccan neurosurgeon. Thank you for accepting this invitation.
Well, thank you very much, the President Najia, and also the El Khamlichi, and also the honorary president of the World Federation of the Dr. Majid, and also Dr. Ahmad Basso, and also the CAN's president, Modi Kresh. He is one of my best teacher. Thank you very much for kind invitation this time. So I'm very honored to have this chance, and hope my lecture will some help for young doctors. So I want to share my screen.
Yes, please.
Sorry.
Take your time.
Sorry.
No problem.
Yeah. Okay. Sure. Okay.
I'm so sorry because just I finished my slides. So thank you very much for once again a kind invitation, Najia. I'm very proud of you because of one of the female, the neurosurgeon. So at the beginning, just I want to, can you hear? Can you hear? Thank you so much. At the beginning, just I want to say one word because May 15, the teacher, Potapov has passed away. So he dedicated so many the neurosurgery, especially the Asia, especially the Japan. So that's why I wrote this the memorial exercise. So he was so vivid all the time. And this is a slide which we visited Morocco. And we had a very nice hands-on workshop. We did the bypass and also the hands-on of the endovascular and also the bypass hands-on. And also this is the endovascular, the hands-on which we did. So, and also the live surgery we did in Morocco at the time. So 2 open surgery and also the 2 endovascular surgery. So we enjoyed all the whole course. Thank you so much at the time. So recently, due to the pandemic, the face-to-face education activity is very restricted. So the travel restriction and also so many new guidelines. So it's very severe to visit the other country face-to-face. So but now it's increasing of the vaccinated people. Then the more than 70-80%, maybe we can gather in person in closed space. No need to wear the mask. Where the in-person meeting will take place. I hope it's become very, very soon. So neurosurgical education during the COVID-19 pandemic. So the short introduction, I speed up. This is a concrete, the changes of the neurosurgical education and the training due to the pandemic. So the global efficacy by COVID-19 pandemic, the decrease in their hands-on surgical experience. So this is the most difficult time for especially the young doctors. Just consider developing the online learning modules and setting up the simulation laboratories to allow training to systematically acquire knowledge and develop the practical skills during these challenging times. Non-technical skill on online information, such as the neuroanatomy, radiology operative approaches, and neurosurgical atlas, the Roton collection, and the respective journals of the neurosurgical organization. On the other hand, is a technical skill providing So the virtual reality, so such as operating the rooms and also the hands-on workshop, the in cranial surgery and also the in spinal surgery, the tend to the minimally invasive procedures in neurovascular surgery. So the main three categories, virtual reality is increasing. So this is one of the bypass virtual reality. And the hands-on workshop online is such as the bypass, embolectomy, and intracranial stenting and image guidance and robotics and spinal surgery. So the virtual conference, telemedicine, and online educational resources allow the neurosurgical resident to continue a dedicated approach to their education. So even the pandemic time, so that we can provide awareness, so many the modality for education. So the simulation training, so ventriculotomy placement and brain tumor resection, pediatric screw replacement, and the endoscopic transsphenoidal surgery, autologic procedure, and endovascular surgery, and virtual reality simulator, and game-based simulation training, including scoring and time challenge. So this is virtual reality simulators. So many operative planning that we can make, and this is our operation theater. And what about the research for awareness or residents? So considering of the resident research experience, so collaboration very closely with the PhD laboratory scientists. The next one is artificial AI intelligence. So this is the future direction of not only the neurosurgery, but also the whole scientific area. I think generated machine learning algorithm to improve our capabilities for diagnosis, prognosis, and patient management. So these things come to identify the likelihood of the future outcomes. So such as robot-assisted surgery and automated the preoperative planning, diagnostic brain imaging classification, surgical candidate selection, and prediction of the post-operative patient outcomes, and the localization of the epileptic zone. So this is one example is preoperative MRI scan to intraoperative differentiation of the tumor and brain tissue. And also the prediction of the future intracranial pressure with this ML applicants. The future role of the simulation in training is developed and allowed to use this simulator training for more and more neurosurgical procedure. So the Ashpan training in the area of the weakness, the new technology and have a future role in the preoperative rehearsal to decrease the real errors in surgery. So this is everybody knows it. This is Da Vinci, this is telesurgery. And also the new modality of the modality provides us to avoid the removing the part of the skull and allows for more precise procedure and the shortness, the time surgery, and reduces the number of the stitches, which means the faster recovery and less scarring. There was the risk of the infection because the cuts are so small. There was the pain after surgery and eliminating the muscle fatigue and the physiological tremor during a long operation. So this is a bypass 3D exoscope. And also this is exoscope, the digital 3D, we can practice. And also preoperative planning for tumor surgery navigation. So this is, I'm sorry, because the reason we start the CFD overlapping of the surgical, preoperative surgical cartoon. So this is just a cartoon. So we can superimpose of such kind of CFD the aneurysm. Then we can preoperative planning how we can see the aneurysm, and also the aneurysm, which part can be expected to be seen or sick. So this is the intraoperative image, and this is a preoperative planning of the CFD superimposed of the preoperative cartoon. So this is a left ICPC aneurysm. So from the CFD, some part is very thin, some part is very thick. So this is one of the preoperative education. So this is a synchronize of the 4 parameter of the CFD. So this is just I want to show how we can apply this educational tool. So this is a patient, the Bajra SCA. Of course, the surgical steps is very, very important. And after removal of the angiocrinal process for manipulation, good manipulation of the internal carotid artery. Then after that, this is a anterior temporal approach. So most of the pain comes to the frontal lobe. So the patient has 2 aneurysms. One is MCA, and this is a SCA aneurysm. So the thinner aneurysm is MCA, and the thicker one is SCA. So just we can detach the perforating artery from the aneurysm neck. That is most important thing. Just we can compare the preoperative CFD, and this is a ICG intraoperatively. So this is endoscopic viewing. So this is vaginal trunk, SCA. This is a left SCA aneurysm. So this is the contralateral, the third nerve, and this is vaginal. There's so many perforators we can see with the endoscope. So some part, the vaginal trunk is very yellow. So we should be very careful when we choose of the placing the temporary clip on the vaginal trunk and the initial clip on the SCA and the remnant part of the aneurysm, we can put the second one. So then all the time, recently we apply this preoperative CFD image with all cases. And the second step that we can put MC aneurysm. So, sorry. So this the one more case just I want to share. So this is multiple aneurysm the patient has. So this is through the left stemmer approach that we deal with MCA and also the ACOM aneurysm. So again, so transsylvian approach. So just that this is a very peculiar shape of the MCA aneurysm, ICG. And this is the ACOM one. So initial clip is a little bit shortish, the length. So once again, we reapply on the aneurysm neck. So they repeated the ICG, they tell us, and also the Doppler, so we can confirm how completeness of the aneurysm, the occlusion from the circulation. So after the ACOM aneurysm, then we move to the MCA. The MCA is quite difficult sometimes because the neck is almost sometimes the more than 2/3 of the main trunk. So this is a very complicated clip procedure. So recently we need to educate about endovascular. Of course, the flow diverter is now, it's very, very popular now. So the recently, the indication extended the criteria small or medium, the wide-necked, circular or fusiform aneurysm from the petrous to the ICA terminus. So the mechanism is also decreased wall stress and stagnant flow, the result in aneurysm modeling that ultimately promotes the endothelialization. So this is the most important things for flow or diverter. So many types. The recently we use the FRET, and this is how we can put. I'm not the endovascular neurosurgeon, but in Japan is almost hybrid. The neurosurgeon is increasing now. So the spontaneous aneurysm rupture in just less than 0.7%. But when we treat with the combination of the flow diverter and the coil embolization is 0% of the rupture after procedure. So the finally, just I want to make summary the purpose. So how the education. So basic to advance of the neurosurgical knowledge and the techniques and the special tips and the tricks, the hands-on and educational course. The hands-on workshop that we can provide a neuroanatomy and the microsurgery such as the bypass and the endoscope and the spinal surgery and the neurosurgical life support and trauma and the endovascular intervention. The outcome expectation is a knowledge and the skill and the care, patient care and the outcome of the treatment. And also the another important thing is the connection in friendship, face-to-face. So this is one of the our hands-on workshop. So lectures, hands-on workshop, and the live demonstrative surgery. So these three components is very important. So the lecture, and this is hands-on surgery. Maybe the next year we can demonstrate such like this. And also this is the bypass. So which we did in Rabat. So just we can use some of the plastic tube that we can demonstrate. So the final live demonstration surgery, the most effective for the surgical learning, I think. So this is a kind of the live demonstration surgery which we did in our university. But the advantage is so many, of course. But sometimes disadvantage, we should know the ethics, the issue and infection risk. And this is just spot visiting. This is Tanzania. It was the first the clipping surgery which we did. Fortunately, the university has a Pentero microscope that we decided to do. And also we cannot forget about the student and the resident, those taking over the future of the neurosurgery. So this is just I visit to the Nepal. So they have a very nice such kind of the student gathering. And also, of course, still the gender gap we cannot forget. So, but with Nadia and we have so many nice gathering of the female doctors and encourage each other. So, and also not only the doctor fellowship, but also the nurse fellowship is very important. And also anesthesiologist, the fellow. The three important things: doctor, nurse, and anesthesiologist. So this is the future, the neurosurgery, and education. So robotic assisted micro and stereotactic surgery and virtual reality and the detailed 3D visualization for extreme. It's very popular now in Japan. So the preoperative planning is very important. So image-guided surgery, functional MRI, nuclear medicine imaging, and gene therapy, stem cell, and tissue transplants. The telemedicine applicants, teleconsultation, such kind of the web, the education is very important. And also in clinical endovascular, and also the bypass, and also the intraoperative image is another very important. So this is a normal time. So the West Foundation, I always thanks to the Professor Sami and Professor Amanda Basso and more Shooks. Thank you so much for your kind attention. Thank you very much.
Thank you very much, Professor. Thank you, Professor Kato, for this presentation. We will leave the question discussion at the end. And may I ask the next speaker, Professor Yong Kwang Tu. Have your slides ready? Professor Tu? While waiting for him, I would just to remind our young colleagues that Professor Yong Tu is a professor of neurosurgery, a world-renowned neurosurgeon with many contributions in the field of neurosurgery and education. During his career, he achieved numerous positions and distinctions. I will just cite a few. Chairman of Neurosurgical Department in National Taiwan University, Professor Emeritus of National Taiwan University Taipei, Chair Professor College of Medicine, of course, President of WFNS between 2013 and 2017, and after that, Honorary President of WFNS. He received many awards and distinction and published many scientific papers. His field of interest, cerebrovascular circulation, arteriovenous malformation, brain ischemia, myomia disease, and others. He is an outstanding neurosurgeon, a mentor, and a big friend. Thank you for accepting this invitation. Try to keep with time, 15 minutes, please. Thank you, Professor Tu.
Thank you very much. Can you hear me?
Yes, yes. Go ahead, please.
Oh, good,
yes.
good. It's really a great pleasure for me to be a part of this meeting. I would like to thank Professor Kamliji and Professor Labadi for organizing this very wonderful meeting. Today, I'm going to talk about surgical management of paracrinoidal aneurysm. Paracrinoidal aneurysm is the most proximal aneurysm of the intradural ICA. The neck of this aneurysm are obscured by the anterior crinoid process and in the proximity of dural rings. So it requires some special technique to create the aneurysm. After the advent of interventional therapy, nowadays most of these patients will be treated interventionally, but I still like to allow the young neurosurgeon to know the technique of microsurgery in treating this type of aneurysm. So there are 4 different types of aneurysm at this segment, which is a C2 segment of the internal carotid artery. And you need to pay special attention to the nomenclature of those segments of internal carotid artery. So I use the Fisher's classification. The C2 segment is referred to the segment between the posterior communicating artery and the distal dural ring. So at this location, there are 2 branches coming out from this segment of internal carotid artery, which is the ophthalmic artery and the superior hypophyseal artery. So aneurysm may form at the junction of at the beginning of the branches. Then there are 2 different types of flow-related aneurysm, which is carotid cave aneurysm and crinoid aneurysm, which I'm going to explain it to you later. So as I mentioned, this location is obscured by the anterior crinoid process. So there are 3 important steps: scalpel maneuver to treat this type of aneurysm surgically. In addition to pterional craniotomy, you need to remove the anterior crinoid process either extradurally or intradurally. And you need to mobilize the optic nerve by opening of the falciform ligament and the dural sheath covering the optic nerve. Without this mobilization, it will not be possible for you to visualize the neck of the aneurysm. And after that, you need to do circumferential dissection of the distal dural ring and sometimes even the proximal dural rings around the internal carotid artery and around the aneurysm. Otherwise, it will be not possible for you to cross the crib during the surgery. And certainly, you need to have a very good proximal control. So this cartoon illustrates what I just mentioned, 3 important steps. The step 1 is removal of the ACP and drill of the optic canal to visualize the optic nerve. The second step is to open the dural sheath of covering the optic nerve. And the third step is circumferential dissection of the distal dural ring. So I opened the dura in this patient after a linear curve incision. I make an additional vertical cut toward the optic nerve to open the dural sheath covering the optic nerve. And this is the area occupied by the anterior cranial process. Now it's gone because after the drilling, we obtain this space to manipulate, and then we have to perform a dural dissection around the carotid artery. So this is a tradural approach to the ACP. So usually we would like to cut this orbital meningeal band to widen this space, and then the whole piece of ACP is exposed here. Then we start drilling to make it paper thin, just leave a very thin cortical bone, and the center of the ACP was drilled off. The carotid canal is opened, and then we also open the foramen by Caisson punch. And then after that, the whole length of the optic nerve covering with dura has been exposed, and optic stroke is here. So this is the anterior medial triangle of the cavernous sinus. And if you open this there, you get into the cavernous sinus. So you can observe the contour of the internal carotid artery inside the cavernous sinus after removal of this piece of bone, which is anterior crinoid process. So the drilling is like this. So with the sufficient water irrigation, try not to induce heat to the optic nerve, which open the optic canal like this. The ACP was almost removed. Only a very thin layer remained here, so it will be easy to be fractured and to remove. So using the diamond drill to remove the remaining part of the ACP, and then more drilling on the optic stroke to detach it from the main body of sphenoid bone, and then further removal of the bone in the anterior portion of optic stroke. You may encounter some bleeding from the cavernous sinus, so just insert a small piece of gel foam. It will be very easy to stop the bleeding. So in this case, I insert 2 pieces of gel foam, then the bleeding stopped. Then for some difficult cases or rupture cases, you need to have a proximal control. The proximal control can be done at the neck. So you either use external compression, ask your anesthesiologist to compress it, or you open the cervical ICA to put a tourniquet around it, or you can use to inflate the balloon to occlude the artery temporarily. But what I would like to do is I would like to have a proximal control at the psoas carotid artery. I'm going to show you this. You can also open the cavernous sinus pack.
Professor Chu. Will you please turn on your mic, please?
We don't hear you now, Dr. Tu.
Okay. How about now?
Yes.
No, it's okay.
Oh, good. Okay, so with a progressive opening of different compartments of a cavern sinus, you can isolate this segment, which is C2 segment. You will be able to put a clip here for a good proximal control. But what I would like to mention here is, oh, I cannot move this.
Just go on the arrows, please. Arrows by
no, okay.
bottom of your slide. Yes, there's arrows. Or you can in share and share again your slides if you want.
How about now?
Not yet, no.
Not yet, but
yes.
You can hear me?
Yes, we can hear you, but if you want to go to the arrows in the bottom of your slides, bottom line.
Yeah, I'm trying. How about now?
No, not yet, yes, sir.
Not yet.
Not yet.
This like you were near. Are you okay with that?
I'm trying. How about now?
Yes, yes, we can see your slides.
You can see my slide, and can you hear
Yes.
me?
Yes,
Good,
yes,
good.
we hear you.
Okay, so what I usually do is try to have a good proximal control at the petrous carotid. So after I drill off the ACP, I swing my microscope to the middle fossa to identify foramen spinosum. So the middle meningeal artery coming out from there was coagulated and divided. Then with further dissection, you can identify the great superficial petrosal nerve. So the carotid artery is just underneath this GSPN. If you are not sure the location of the carotid artery, you can use Doppler to detect it because only a very thin layer of bone covering the carotid artery. Then you can drill the bone at here. My slide cannot be moved. Okay. Okay, so this is a video showing you how to do that. So the middle meningeal was divided, and then explore the GSPN to identify the location of the carotid canals. So drill up this piece of bone, you will be able to identify the carotid canal. So there are two different ways to have a proximal control. You either pass a thick string around the internal carotid artery, or you insert a balloon catheter to the internal carotid artery. Whenever you need to have a good proximal control, you pull this string or inflate the balloon to compress the carotid artery. It's not advisable to put a clip here because you're doing extradural procedure, and later on you're going to move to intradural procedure. It will be difficult to flap the dura back and forth. So these two methods can be used for the proximal control. So how about these four types of aneurysm? The most common type will be the ophthalmic aneurysm, which is at the level of the ophthalmic artery projecting superior medial, because of ophthalmic artery coming out from the superior medial aspect of the internal carotid artery. In many cases, an aneurysm will compress the optic nerve to make a visual field impairment. So, for instance, the following case is an aneurysm projecting upward, which is coming out from the ophthalmic artery. So the patient came with visual field problem. The nerve was compressed from below, but the upper portion of the nerve will be pushed against the bony part of the canal. So the upper fiber will be compromised and the patient will produce a lower field cut. So during the surgery, after the removal of the ACP, we also try to mobilize the optic nerve like this. And then dissection of the acromion membrane around the internal carotid artery. And then the nerve can be mobilized to identify the neck of the aneurysm here. So you can see how the nerve is compressed by this big aneurysm. So the clip was pressed at the neck, and then we try to decompress the aneurysm. After obliteration of the aneurysm, we puncture the aneurysm, and the nerve was compressed. So the patient has a good visual recovery afterward. Another case similar, I will not spend time to explain it. The next group of aneurysm is a hypophyseal artery aneurysm. It's different from the ophthalmic aneurysm because the projection is different. It always projects to the medial, but inferior. So this aneurysm is a little bit distal to the ophthalmic artery. And you need to use a penetration clip to clip this type of aneurysm, because when you came from lateral, you barely cannot see the neck of the aneurysm. You can only try to gauge where is the aneurysm neck and then use this penetration clip. You can use this type of penetration clip with asymmetric opening like this, or a curved blade penetration clip will be also useful in treating this type of aneurysm. Well, this is a case of hypophyseal artery aneurysm. The aneurysm is projection medially and inferiorly. So actually, this is a supercellular variant. There are two subtypes of this type of aneurysm. So inferior medial projection to this aneurysm will be above the diaphragm saline. So again, after the removal of the ACP, mobilize the optic nerve, then we use this type of penetration clip with curved blade to fit the contour of the carotid siphon, and then the aneurysm was clipped. So it's better to have a hybrid OR. After the clipping of aneurysm, you can perform angiography immediately to make sure that this aneurysm is properly clipped. Even the ICG sometimes will not be useful because you cannot see things below. And then this is another subtype, which is a paracrinoid variant or ventral variant. It projects inferiorly and ventrally, not to the lateral. So in this case, I try to remove the ACP through intradural approach. So after opening the dura, we cut the dura covering the anterior cranial process, and we start drilling the anterior cranial process from intradural space. So the principle is the same, to explore the carotid canal and remove the whole piece of ACP. So after the completion of the removal of the ACP, we were able to identify the aneurysm here and the internal carotid artery here. So a little bit circumferential dissection of the distal dural ring. We press a clip similar like the previous case, but this case the projection is more ventral, more ventrally. So the aneurysm was clipped. So another hypophyseal artery aneurysm. Then the next group of aneurysm will be the carotid cave aneurysm. Carotid cave is a small bony impression underneath the anterior cranial process, but this aneurysm is intradural. Many surgeons make a mistake. They saw that this aneurysm is extradural, but it's not true because the dura goes obliquely to the anterior portion of the sella like this way. So the location of the aneurysm is proximal to the optic nerve, ophthalmic artery, but the projection will be the same like the hypophyseal artery. inferior medial. So according to the location of the ophthalmic artery, you can differentiate these two types of aneurysm. And this is a flow-related aneurysm at the non-projection side. So this is the most difficult case to be clipped because it's very proximal. So you need to perform a lot of dural dissection to be able to identify the neck of this aneurysm. So this is one of the case. You can see the carotid cave here. The carotid artery is making a turn here at the siphon. So we identify the ophthalmic artery here. This is the ophthalmic artery, and the carotid cave is here. So the projection of the aneurysm is downward. So barely you cannot see the neck. It's here. Then try to use a fenestration clip to clip this type of aneurysm. And finally, the aneurysm was clipped. So again, you need to identify the ophthalmic artery, the carotid siphon, the anterior portion of carotid siphon, and the carotid cave is just here. Another case with two aneurysm, this one is distal to the ophthalmic artery, so should be a hypophyseal artery aneurysm. Small one, we didn't pay attention to this one. But the other one on the left side is a carotid cave aneurysm because it's the ophthalmic artery is here, it's proximal to the ophthalmic artery. So this one need to be treated because of the size. So we treat this one and use the same technique, mobilization of the optic nerve, removal of the ACP, then identify the neck of the carotid cave aneurysm.
لا 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 ما فرنسيش لا لا pas du tout لا pas du tout.
And the last group of the aneurysm will be the quinoidal aneurysm. Quinoidal aneurysm arising from the segment C3 segment, which is between the proximal and dural ring. Theoretically, is extradural. However, many of these type of aneurysm may extend into the subdural space. So, like in the following case, then in that situation, the aneurysm needs to be treated. It's a large aneurysm arising from the quinoid segment, and you see the indentation here, which is the dural ring. So it protrudes into the subdural space. So may cause subacromic hemorrhage. So we treat this case. And during the surgery, you can see the aneurysm is arising from the junction between the distal dural ring and proximal dural ring, but a small portion of the aneurysm protrudes into the subdural space. So usually this type of aneurysm will project laterally, so you do not need to use fenestration clip, just an angle clip can clip this type of aneurysm.
Professor Tu, can you please, for the time?
Yeah. Okay, I'm going to stop. So this is another case showing the protrusion of the aneurysm into the subdural space. So we clip it. So I'm going to skip all these. So this is our result. In the past 20 years, we treat 79 patients with 84 paracrinoidal aneurysms. About more than 2/3 of the patients, they are unruptured aneurysms, and about 1/3 has the rupture of the aneurysm. But for those unruptured aneurysms, 22% has the visual problems. That's why we treat it. And the rest, because of size, we treat it. So after the surgery, 77% of the patient has a visual improvement, but 8% of the patient has the postoperative worsening of the vision. Our mortality is 2.5%, and complication rate is about 7%. So the result is very similar like the other report. Nowadays, many surgeons use interventional means to treat this type of aneurysm, but the result is not as good as microsurgery. Coiling with stent assisting can only obliterate about 60% of the aneurysm. If you use flow diverter, only 80% of aneurysm will be obliterated. The mortality and morbidity is much higher than the surgical series. So in conclusion, with the sufficient removal of anterior cranial process and mobilization of the optic nerve and free of the ICA from the dural rings is the key to a successful clipping of paracranial aneurysm. A good proximal control is crucial, and the preservation of hypophyseal artery and ophthalmic artery is also crucial for good visual outcome. And preoperative analysis of subtypes of paracranial aneurysm helps for the decision of extension of dural dissection, and also will be helpful for clip type selection. Thank you for your attention.
Thank you very much, Professor Chu, for this very outstanding presentation. Thank you very much. And may I ask the next speaker, Professor Spitzler? Is
Yes.
here ready with the we are running out of time, and Professor Spitzel, you don't need to be introduced. I mean, everybody knows you, and thank you for accepting our invitation. And if you are ready, you can go to your presentation. Thank you very much, Professor Robert Spitzer. Thank you.
You're welcome. Can you see my screen?
Yeah.
Yes.
Okay, well, it's a pleasure to participate and to see so many friends. When we talk about brainstem cavernous malformations, I think the pathology that has such a unique educational input is the fact that they occur anywhere. And when they occur anywhere, it means that we have to develop new approaches into the deep portions of the brain. I'm not going to spend a lot of time on this because we've published this, others have published this. This is very common, but what I do want to do is sort of go through the approaches in a relatively rapid fashion since we're behind time. I've said it 1,000 times, exposure is everything, and anybody can clip or take out a lesion if you can see it. With the cavernous malformations, we have to worry about the venous anomaly. Image guidance is essential. Monitoring is important. Sharp dissection. I like burst suppression because it decreases blood volume and gives you better protection for temporary ischemia. Anatomy. And then I have operated for the last 20 years without rigid retraction. So when we talk about anatomy, it is obviously essential because lesions that are relatively close require totally different approaches. And if you look, for example, at the thalamus, something we published a few years ago, and you look at the various regions of the thalamus, there are really different approaches for each one of those designated regions. We couldn't operate for many of these lesions without image guidance. And I think this technology has made a huge difference. Additionally, when we operate in really, really deep spaces, it's nice to have instruments that have light at the tip of them so we can see. I'm going to start from the bottom up, the far lateral approach. This is a young woman from London. She's the editor of the London Times, and she has this cavernous malformation, which has bled 3 times. When we look at surgery with a small far lateral approach, we get beautiful visualization of the lesion. You see the evidence of the different times of hemorrhage from the different colors. And by this is the 11th cranial nerve. So you can easily remove this lesion because of the proper exposure. Take it out. Suboccipital, a point needs to be emphasized that a patient that has a cavernous malformation below the floor of the 4th ventricle that is asymptomatic or minimally symptomatic, that patient is not a surgical candidate because you're going to hurt him or her. But when you have one like this, where you already have all the symptoms from compression of the pons, that's easily taken out, and that's the post-op. More interesting are those that are farther off laterally. So here we have one with several hemorrhages. And here the telovelar approach is absolutely ideal. We could go do a typical suboccipital craniotomy, but go out laterally to the foramen of Luschke. And so here we are, the feet are up on top, head is down here, some gel foam into the fourth ventricle to prevent blood from going down deep. And then all we do is go to the foramen of Luschke, mobilize pica where it crosses here until we see the middle cerebellar peduncle. And then with image guidance, and here's the floor of the foramen of Luschke. Then we know exactly where to make our little opening, and with very small instruments, pituitary-like instrument, but very small, we identify the cavernous malformation and remove it. And here it is gone, and no deficit. This is the middle cerebellar peduncle is fortunately a very nice way to enter the brainstem or the pons, where it is very well tolerated. When we look at the workhorse of the retrosigmoid approach, there's a patient with multiple cavernous malformation, family history. This one is now symptomatic. What we really want to do is, with our image guides, we want to go down the center of the lesion, not where it comes closest to the surface, but the center. So we have equidistance from each side. And with image guidance, naturally, when we're done, it's a nice reassurance that we've gone through the whole lesion. So here we are, retrosigmoid approach, no retractor, no sitting position. And then we just follow out from the fifth cranial nerve until we are looking straight into the center profile of the cavernous malformation. And then we take out the lesion, and this is a very large lesion, so it takes a long time to take out. So we'll just move it along and keep going until it's really gone. And this patient remained intact hearing. And here's the cavity afterwards. And that's by going down the center. I include this case only because the patient with an acute hemorrhage, because it's opening the petrosal fissure. So here we are, petrosal vein or Dandy's vein, no retractor, fifth cranial nerve down below, lower cranial nerves to the right. We just keep going. Now we open up between the cerebellar hemispheres. And so just like opening the Sylvian fissure, although this is a little more fragile, we can go right down again to the middle cerebellar peduncle by just gently coming down. Notice this is not a sitting position. Patient has no retractor in place. I always like to keep this vein intact because I don't want any additional retraction. And then we go down until we see the typical white fibers of the middle cerebellar peduncle. And once we have that identified, we use image guidance to make our entry point right where we want to go. And then just take it out. And obviously, it's again, exposure is everything. Once we have that trajectory, we go right down through the middle cerebellar peduncle into the cavernous malformation, and it's there, and take it out. And here's some air left behind. When we go to the supracerebellar infratentorial, I love this approach because it gives you such an incredible radius to the deep portions of the midbrain. And so if you have a classic cavernous malformation like this, you can see the cerebellum here, temporal lobe here. This is naturally a perfect lateral supracerebellar tentorial approach to this lesion. Again, you notice how far lateral we are. Patient is in the supine position, turned, fourth cranial nerve, no retractor in place, no spinal drainage, right down, and we identify the cavernous malformation and we take it out. Then we spend a long time in the cavity to make sure we have it all. And just a small opening required to get it done. And here's the entry, and here's the empty cavity. How much of a lesion can we get through that approach? This is a young girl from Copenhagen, operated before shunt. You can see it occupying the entire third ventricle all the way up to the foramen of Monroe. So we used, again, supracerebellar approach. This time we have to cut the tentorium all the way because we need to go so far anterior and superior. We enter the lesion through the midbrain, lateral meniscus, very well tolerated. And then we just make it smaller and smaller, take it out piecemeal. I used a little CO2 laser here along until we're done. And we just keep taking it out. And you can see with image guidance, we are now all the way up to the foramen of Monroe, to the distal end of the lesion. And here's the post-op, the lesion is gone. And she goes home. OZ, critical approach to the more anterior brainstem lesions. So when we have this 28-year-old who's had multiple hemorrhages, 3 hemorrhages, you can see the lesion here, the cavernous malformation here. You can't really get it from an ipsilateral approach. So you have to go contralateral, interpeduncular space. So here we are. And we find that the best trajectory here is really to go between the optic nerve and the internal carotid artery into the interpeduncular space. So again, notice no rigid retraction. And then when you look in the interpeduncular space, you have this myriad of small vessels, which you have to separate, double check to make sure that image guidance is absolutely accurate. And then make your opening very small into the contralateral peduncle to get to the cavernous malformation and then remove it. And we're right on target. And there you can see the lesion coming out. And there's the cavernous malformation. And we get the rest of it out. And this is what it looks like. You can see our trajectory from the contralateral side and the empty cavity where the cavernous malformation was. When we look at transcallosal approaches, I just want to end up with 2 cases. You have this one in the third ventricle, hanging on the roof of the third ventricle. So we're going to go with the patient in the horizontal position. Your hands are horizontal, your eyes are horizontal, across the midline, pull over the sagittal sinus just a couple of millimeters through the corpus callosum. We see the foramen of Monroe, choroid plexus. I like to go lateral to the choroid plexus because that means you have one more layer between you and the fornix, protecting the fornix. So now we use the choroid plexus to cushion the fornix, then go into the third ventricle. We identify the cavernous malformation, and since it's attached to the roof of the third ventricle, we then use, here I've used the little CO2 laser, holding up the roof of the third ventricle and separating the cavernous malformation. And it really comes out very nicely. And again, very straightforward, as long as we have the appropriate exposure. And here it is gone. More difficult is this young man from another country. And here is a cavernous malformation that's sitting in the back end of the third ventricle and here in the aqueduct. Here you can see how far it extends into the aqueduct. So the same approach, again, horizontal, lighted instrument. We get to the back of the third ventricle. And here I'm using a retractor to hold over the corpus callosum. And here we're looking into the aqueduct, third ventricle. That's the cavernous malformation. And so with piecemeal Resection, we take the lesion out. Always this counter traction. And you can see that we're really in the posterior portion of the third ventricle, but have great visualization with the lighted instruments and utilizing these very, very small pituitary-like forceps. We extricate the lesion until it's completely out. And there, now it's open. We see CSF coming back. Here's pre-op, here's post-op, pre-op, post-op. So when we put all material together, I've had the opportunity and the privilege of operating a more than 500 brainstem cavernous malformation. We find a lot of roots that are available. We've learned from our mistakes, and I apologize to our patients that I've hurt, but we've benefited from every mistake we've made by identifying the areas that are safe and identifying the areas that are not safe. All of these approaches are in these 2 volumes, and all the videos are in them away as well. So in conclusion, I think resection of appropriate symptomatic lesions that are accessible is appropriate. Knowledge of approach is important. And with the appropriate exposure, you can really remove them all. Couldn't do it without image guidance. And I think minimal retraction is essential. Anatomy, anatomy, anatomy. I thank you very much for your attention.
Thank you very much, Professor Spitzler. It was always a pleasure to hear from you and to learn from you. And thank you also for respecting perfectly the time. And we will have the discussion at the end of the session. So may I ask the last speaker, Professor Armando Basso, to prepare his slides. Professor Armando Basso, you know him, he's a big friend. He's an outstanding Argentine neurosurgeon. And are you ready, Professor Basso?
You need to unmute yourself, Armando.
Micro.
Microscope, microphone.
Yes. Okay.
Thank you.
Okay, thank you. Can I share my screen with you? Okay. Oh. Excuse me.
Do you need help?
No,
Armando?
it's okay.
Oh, it's okay.
Can you see my slides?
Yes.
Okay, good. Okay, you hear me?
Yes.
Well, thank you very much, dear Professor Carmichi, dear Professor Nadia El Abadi, for this invitation. Really, it's a great pleasure to be with all of you. Well, I prepared for you a brief history and development of skull-base surgery in the 20th century. The first part is a history that all of you know very well. The second part is my personal experience from 1960 to date. So you know that 7 decades ago, many areas of skull base were considered a no man's land because neurosurgeons could not define a correct diagnosis or provide adequate treatment or considerable number of basal tumors, as you can see here. All those tumors considered that belong to the basal group are, carcinomas like these, esthesioneuroblastomas, chordomas, chemonectomas, of course, meningiomas of all kinds, and all the pathology of the cellular region. So coming back to the history, so that history starts at the end of the 19th century with this Giordano transglavular approach. And the very well-known, approach was the first one doing the transfacial approach of the cellular region that was in 1907. I remember in 2007, we celebrated in Vienna with Drew Hardy and other colleagues, the centennial, celebration of the Hermann-Schlöffer surgery. Of course, the result of this surgery was not so good. No antibiotic, no correct diagnosis, etc. And the patient survived, but 2 months after, the patient died, of course. But the classical and the most renowned approach for that region was the Cushing sublabial transrhinoseptal transphenoidal approach. This approach that, of course, has been utilized until today. But of course, this approach of Cushing have the same, even in my country, in Argentina, Professor Segura for BNT popularized that approach that I personally use until, in some cases, until today. But Dandy, the great master in the 20s, he said, the nasal root is impractical and can never be otherwise. And he convinced Cushing of the same thing. And finally, Cushing forbade absolutely all his assistant and colleague of that time to use his Cushing approach. But in Edinburgh, one of his former pupils, Norman Dodd from Edinburgh, he continued to use this Cushing approach. And my teacher, Professor Gerard Guillot from Paris, he went to Edinburgh, he learned with Dodd, and he started to do that kind of surgery in Paris. And he introduced the fluoroscopic intraoperative control of that approach. That was the way myself in 1960, when I start neurosurgery, the way we use, this is myself in Buenos Aires with a Cushing approach, without microscope, without enough illumination of the field, doing that approach. But in those years, this is my signature, this Vaso 1962, that book came to my hands and it changed completely my life. That book has been published by Gerard Guillot in 1958. And he demonstrated his experience, his good results, I cannot remember exactly, but 50 or 60 cases, no more than that. In those years, so I decided, of course, when I read that book, because the result in my country was not so good, even with the Cushing, with the transphenoidal approach. And I said, I have to go to Paris. And then I went there at the very beginning for only 1 year, but then I remained in Paris. I stayed there for 10 years. So you see, and then I was the witness, of that association of Gerard Guillot and Paul Tessier, two giants of the surgery. One neurosurgeon, the other a craniofacial surgeon. And I have the chance to be an assistant of those persons during many years. And Guillot and Tessier published the first papers in meningiomas of all types. In this case, meningioma and plaque of the phenoidal wing, but of course, they operate the meningiomas of the middle third, the inner third, and even the cavernous, the sphenoidal cavernous meningiomas. So, but in 65, a very well-known person appeared in the field of neurosurgery. In 65, Gassi Yashargil arrived in Zurich, coming from Vermont, and he introduced the microscope in neurosurgery. It has been used before by the EMT colleagues, but Yasargi introduced in neurosurgery, and he changed the history of our specialty. And I was very lucky because in '97 I went to Zurich, starting to learn with him the first, temporosylvial microanastomosis in the lab, etc., etc. Remember that Gassi, he was in '67. He performed the first temporosylvial microanastomosis in men, and fortunately, our dear Gassi Yashargil is alive and in good health. Give that good webinar in July last year. But in '66, Jules Hardy, my dear friend, because Hardy was also a trainee of Bio, and I met him in Paris, he introduced a surgical microscope in pituitary adenoma surgery and began, in my opinion, a new era because he discovered the microadenoma. And the microadenoma was responsible of some clinical symptoms of hyperfunction. So it was possible to cure patients with acromegaly disease or with Cushing disease. It was a great contribution, not only technically, but also in medicine in general. And that was the way I did. In the '70s, I came back to Buenos Aires, and this is myself operating with microscope and with, of course, intraoperative control of the surgery. On those years, I published some papers on pituitary, on sphenoorbital tumor, meningiomas, lesion of the orbit, sphenoidal orbit meningiomas, etc., etc., etc. But one thing is very important. Are you seeing this thing, or you can see correctly my slides? Well, of course, the cornerstone of the concept of a skull-based surgery, in my opinion, was when in the '90s, Majid Sami organized in Hanover the skull-based study group. And this group, it was really very important, as you can see, not myself, but their own, Janetta, Malice, Watson, Sami himself, Sherman, Takakura, many other people in neuroradiology, and of course, this great, enormous EMT surgeon, my dear friend, he passed away, and working with Majid Sami for many years, Wilhelm Traft Fulda from Fulda. So in those years, Sami and Traft in the '80s, they published The Surgery of a Skull Base. Was a book, fantastic book that really was the principle of the modern era of the skull-based surgery. But in '83, in Ljubljana, a young neurosurgeon appeared on the field of neurosurgery, interesting in the microsurgical repair of cavernous vascular lesion. And Vinko Dolen from Ljubljana, good friend of mine also, he organized in '88 this fantastic cavernous sinus symposium. In this photo you can see Vinko, you can see Felix Umansky, who made a fantastic description of the lateral wall of the cavernous sinus, Dry Parkinson, who described all the triangles that we use to go into the cavernous sinus, and this enormous neurosurgeon of the Mayo Clinic, one of my dear friends, also Donald Sam. And this is myself, a young person in this outstanding group. In the 90s, it started the period of controversials, and the controversial was, this publication from my dear friend Lalinga Shekhar. He called this presentation aggressive treatment with arterial replacement involving the cavernous, aggressive treatment in the cavernous sinus pathology. And I published in the same book conservative treatment of sphenoidal women meningiomas involving the cavernous sinus. I'm going to explain you why this was my position. And my position, another discussion, also with Osama Almetti, is radical meningioma management or carotid preservation, cavernous sinus meningioma, subradical resection again. And when I talking on subradical resection, I never said that it was impossible to go into the cavernous sinus. This is possible. You can remove all kind of tumor into the cavernous sinus, no problem. The problem is the meningioma that invade what I would like to call the internal wind meningioma, cavernous sinus meningiomas on that, because you can of course produce a problem in the nerve, in the lateral wall of the cavernous sinus, and in this case I showed you before, it was possible to remove completely that tumor, and the result is this. That was the only discussion. In other kind of tumor, you can go without any problem into the cavernous sinus. For instance, chordomas, for instance, urinomas, whatever. But the problem is, now I know that many people endoscopically are trying to go there and are preserving all the nerves, etc. But at that time, that was my personal position. So the skull-based surgical approach in the 20th century, we have to pay tribute to this person. This person, Albert Loren Rotten, a very good friend, a fantastic person, passed away some years ago, but he was the father of microsurgical anatomy, because it's for the young people is important the anatomy. Now it's impossible to perform neurosurgery if not having made a laboratory training, in microsurgical anatomy. And Albert Al Rotten was, in my opinion, the father of this philosophy. Now, in Buenos Aires in '75, I organized the same thing that you have been organized in Paris in the '60s, because one of the trainees from Paul Tessier was my dear friend Cerisola, and skull-based EMT and craniofacial, and all together through this extended transsphenoidal transmaxillary approach, '75. We removed this tumor. It was a chordoma with a total remotion of the tumor. Another approach is this inferior transzygomatic approach in '75 with the remotion of the malar bone and at the same time temporal craniotomy, going to the pteromaxillary fossa, and you see here. This is a chordoma also, total remotion. I'm sorry for this old slide that I'm showing you. Of course, for skull-based tumors, we use the classical approach, retrosigmoidal approach, subportal dandy approach, and the perional Yasargil approach. And of course, in some cases, it's necessary to enlarge, the perional approach with this front-orbital zygomatic craniotomy, and you get access to the anterior part of the skull base. The transpetrosal approach we used, for instance, in this case of chordoma, I'm sorry also for this old slide, but here you can see the tumor. This is the trigeminal nerve. This is the total remotion through the transpetrosal approach, and this is a total remotion, as in this is the patient 2 or 3 days in the hospital with a total remotion of the tumor. The Kawase approach we use in not so many cases, but in some cases we use this subtemporal extradural approach of Kawase. And this approach, the presigmoidal approach, introduced by Sami and Amirati, 83 and 92, has been useful. It was included in the armamentarium of the approaches for the petrosal or petroclival meningiomas, for instance. But talking with Majid Sami, I don't know if he is here today. Yes, he is here, but I know he's here. This we discussed and discussing with Majid, he said, no, in so many cases, I continue to use for this kind of tumor the simple retrosigmoidal approach. And Majid convinced me, and of course, that's what I do normally, including through the retrosigmoidal approach, the remotion of the tip of the petrosal bone give you access to the anterior part of the tumor. And of course, the far lateral approach in the 90s started with this. In this case, for instance, the foramen magnum meningiomas, you know, the total removal, and this is a very good and very useful approach, the far lateral for this kind of places tumor. Of course, now, and I finished with this. The neuroendoscopy is now into our armamentarium, and of course, you know, I have to remember you that my master Vio, he in '62 he introduced he used for the first time the microscope for going into the cella turcica, and this is the Vio in '62. And of course, my assistant and my pupils now are using the approach completely endoscopically. And I think the combination in microsurgery and endoscopy would be certainly the solution of the last slide is just how skull-based surgery start, you know, to organize World Congress. Now we have hundreds of meetings of skull-based symposium, small courses, etc., etc. But the first World Congress was in Hanover, organized by Sami in '92. Then in San Diego was the second one in '96. Our dear passed away friend Hakuba organized in Osaka International Joint Meeting on Skull Base, and we have the honor to organize with Ricardo Ramina in the south of Brazil and in Argentina in the Iguazu Falls, the 2000 World Congress on Skull Base. And of course, in my opinion, as far as I know, in Dubai was the last World Congress on skull base. And of course, as I said before, many others, hundreds of meetings has been organized all over the world. So, Poor Body's skull-based surgery in 2021. Okay, what is the aim? Minimal invasion, correct and reliable approach to solve the pathology with the preservation of the quality of life of our patients should be our goal. Quality of life, of course, is, in my opinion, the most important goal of our work, as has been demonstrated just for my dear friend Bob Spessler with this fantastic presentation before my presentation. Hi, Bob, how are you? Nice to see you. So thank you very much, and I finish.
Thank you.
Thank you for the invitation.
Thank you, Professor Basso, for this excellent presentation. And now we are running out of time and we are almost 30 minutes late. So the discussion now is open, maybe for 5 minutes, no more, maybe. And if there is any question from the participants. Yeah.
Maybe I have a question if there is nobody. Abd-Samad?
Yes, please, of course. Go ahead.
I have a question of many questions, but because we have, as you said, time is running and we don't have any time. But my question is for Professor Spitzer. I always impressive and by your talk, especially when you are talking about skull-based surgery without retraction of the cerebrum. How can you do it, especially when you are in some cases, huge cases, as the schwannoma, EPC schwannoma, or some grade 4 or 5, and without retracting the cerebrum, I can't imagine it without retraction. Can you explain us what's your secret about this?
There's really no secret. It's a matter of utilizing, instead of using rigid retraction, we're all taught so that when we open, the first thing we do is we put a retractor on one side and a retractor on the other. If you do the same maneuver and exposure, but don't put the retractor out, you will find that you can go farther and farther each time without rigid retraction. And CSF comes out when you've opened the arachnoid, and just by being slow, I call it dynamic retraction. So that dynamic retraction really means you're using your suction or any other tool and moving the exposure with your instruments. That means the pressure on the brain is only where you are looking, not because you have a retractor on one side that holds the brain, and then you're working on this side, which puts more pressure on the retractions. And it's just naturally evolved. There's really no secret to it. Like Armando Basso said, when we did all the big skull-based surgery, it was Majid Samis that said, you know, you really don't need to do this. You'd be surprised what you can do through the retrosigmoid approach. I've utilized that approach and gotten back away from the petrosal approaches almost for every case. So we learn by just listening and doing, and I am so delighted to see so many of my colleagues here, and I say hello to you all and hope next time we meet in person. Abt, you are terrific.
Thank you. Thank you so much, Professor Spitzer.
Say some words.
Yeah.
I think
any comment we have among us?
I would like to emphasize what Robert said. Hi, my dear Robert. I think something which neurosurgeon cannot imagine is the fact that all pathology, what we have, they are located on certain area. And the beginning of neurosurgery started, we should go around this pathology. And it was what created enormous complication. This is a history of 100 years. And I found one day that, of course, as I started skull-based surgery in '66, and I tried to open everything in the beginning to come and see everything. And I remember once I said to my friend, Al Roton, I said, Al, your anatomy is fantastic. By the way, I wrote the preface for Al Roton's book. You should read it, what I said, what I written there. I said, Al, it is wonderful that we know all these, but we don't need to see all these structures during the surgery. This is the fact that the higher you go in neurosurgery, the more you understand that. And my philosophy was, and I am happy that one day I had with Dr. with Robert, we have a discussion together, in a meeting, and he told me, "You are right that we don't need to go there and there." And I am doing that. I was happy that I heard from him because he has so many experience and he knows what I was telling that. And to understand that for every kind of pathology, the clever thing, what he said in his lecture, you have to find the approach, the best approach. You come on some corner to the pathology, whatever. But during this approach, you are not hurting or disturbing any nerves, any vessels, and so that is the beauty and art of neurosurgery, where Robert has demonstrated very well in the case of cavernomas. And this is something that neurosurgeons have to learn. The most easiest approach without exposure of the pathology. I remove, for example, acoustic, you said, Nadia. Acoustic, we don't need to see all the 5 centimeter acoustic. We come just with few millimeters to the CB angle and start to enucleate, and the tumor slowly come. And this is exactly the same with cavernoma. Robert, we are not going to, for a large cavernoma, to open everything. You have an entry zone and try piece by piece, piecemeal remove the alter. This is probably the fact. And I think this is my philosophy. I say, reach the pathology in safe area. Don't go around the pathology. And when you enucleate, the capsule gives you the way how to come down around this pathology. The best neurosurgeon today is the neurosurgeon. He never sees the surrounding structures. He sees only the tumor and remove the tumor completely without touching. You leave even the arachnoid around over all the arteries and nerves. And I'm happy that today we can talk about that and discuss that. 2 lectures really stimulate me to say that. One was from Robert Spessler and one from, of course, Armando, my dear friend Armando, that 2 different important pathology and approaches and topics have been discussed. I hope this is a wonderful message for young neurosurgeons in future. I'm sorry I was taking your time, but this is probably very important.
No. It's very important. And thank you so much for your comment. Yes, please.
Question from
very quickly. Thank you.
Please.
Thank you for Robert and for Armando. You are right, Professor Majid Sami. What we expand and what we find is really all the times different. And I remember Professor Mefti said in the treatment of the meningioma of foramen, he said when you see the nerves, you will have palsy. So you are right, Professor Majid Sami. We have just need to see what we are working, the area where we are working, and not to find the old anatomy. Because when we see it, we will have a trouble. Thank you very much.
Is there any question or comment from?
Abdulsamad, just want to say, if possible, thank you so much for the speakers and for this session and all this and the discussion also, and this very important take-home message. We have, I think, all the young African colleagues and senior also have learned. Maybe another one important, I think, question and issue to my friend Yong Kwang too.
Yes.
About the paracrinoidal and intracavernous carotid artery cases of aneurysm you have shown us. What are the indications to select surgery? Because you have shown us some locations far below the ophthalmic pathways which were treated with surgery, why? I mean, how you decide for surgery or for endovascular in this location? Because it's very, very important. Have you made any comparison in the two techniques, endovascular and surgery, regarding those who are in contact and compressing the optic pathway, and what were the result after treatment?
Yes, usually we treat the patient with a younger age because nowadays we use a flow diverter to treat that type of aneurysm. As I mentioned in one of my last slides, the treatment result is not as good as microsurgery. The obliteration rate is only reaching 80%, and they have a much more higher complication rate. So usually, if the patient is younger than 65, I would recommend the patient to have a microsurgical treatment. If the patient is aged, the surgical risk will be higher, then we treat it with interventional means. I don't know whether I answer your question or not. But for the small lesion, of course, we do not treat it, we just observe it. For any lesion larger than 5 millimeters, I think the rate of rupture will be higher. Of course, some people say that aneurysm at this segment of internal carotid artery has a lower rupture rate. But still, we have about 1/3 of the patient, they came with SAH. So that's why we treat the patient. The other indication is the compression effect, like the compression to the optic nerve. If you put coil there, then the compression will remain the same. So we want to decompress the nerve immediately after the patient develops symptoms. So we send the patient for surgery.
Thank you.
Thank you.
Thank you very much. If there is any question or comment? No other question. I just make a short comment, reminding that most of the participants are young and from developing countries, and they are looking to improve their neurosurgery at home. And two fields of neurosurgery what need to be developed and promoted is, of course, vascular neurosurgery and skull-base surgery. So they are looking for you to help them developing this kind of subspecialties in their home countries. This is very important, and I think that the message that comes from this session are very clear. You have to know anatomy, to practice, to visit department with a big number of cases, and of course we can learn on patients, but with the presence of masters. So this is something that they are looking for, your support to develop their subspecialties in their home countries, because it's very important. And Africa is no more cases of myelomeningocele or trauma, but also vascular cases, skull-base tumors, and they are looking for your support. Thank you. This is just a comment.
Allow me, Professor Wahabi, there's a question for Professor Spezler.
Yes.
By Dr. Ulday Gupta from India. Does the approach to cavernomas or any other tumors change if we apply the knowledge of brain connectome?
Brain connectome, does that mean like the fiber tracks?
I think so, yes.
Yeah. Well, naturally, it really comes down to anatomy. It isn't just the big anatomy. It is also the structures within the brainstem. And very often, you have to get a different route in order to stay safe, avoid the large draining veins, etc.
Thank you, Professor. So, Professor Wahab, you have if you want to conclude the session to move to the next one. Thank you.
There is no other questions. Thank you very much for all the speakers for the excellence of the presentation, and for also the participants for the discussion. And we hope we can see you soon personally and not just online. And we will go to the next session. So thank you very much for this first session. Thank you.
Thank you, dear Samad, for this excellent moderation. And I know that it's not easy to manage the giant neurosurgeons in a small time. Thank you. So we will move to the second session, and I am asking Professor Adil Melhawi. He is here, of course. Yes. Yeah. And with Professor Ahmed Al-Khani from Arabia Saudia is here also to to co-chair the next session. And there is a little bit small change. Professor Luca Razilik, he will give his talk in the end of the session, or maybe in the third session. So you can start with the Professor Hildo Azevedo. Thank you.
Sure. Can you hear me well?
Yes.
Well, good afternoon, everyone. I'm glad to be with you, legends of neurosurgery, leaders of World Federation of Neurosurgery. I'd like also to thank my co-chairman, Dr. Adil Melhawi, for being with us as a chairman of this very fantastic session, the masterclass number 2. We have a diversity of topics on this session. The beauty is in diversity. I believe in that. So as Dr. Najir Abadi said, Dr. Luca is not going to be with us, but maybe he will join later. So it will give me my honor to introduce the first speaker, who's Professor Hildo Azevedo, and he's going to start to give us his first presentation. Professor Azevedo is an honorary president of the WFNS, full professor and chairman at the University of Pernambuco in Recife, Brazil. And he was the first vice president of the WFNS 2013 till 2017. I would love to hear the presentation of our first speaker, and please, the podium is yours, my close friend, to start your talk.
Can you see my slides?
Yes, we are
okay.
on.
Okay. Thank you. Good morning, good afternoon, good evening to everybody, dear friends. It's very good to be here with you and embrace you even virtually. And I would like to congratulate my friends, my Morocco friends, Professors El Kamilich, El Wahabi, and my dear friend Naji El Abadi. So this is my hospital. Let's go to talk about what we're doing on severe TBI over the next over the last 5 or 6 years. This is our surgical performance all over the years, and you can see that even in 2020, during the pandemic, we did not decrease so much our surgical performance, and so we could maintain our academic work, our world rounds, our conference. So as far as I can say, the residence training was not so much jeopardized by this tragic pandemic which affects the whole world today. So we all know that severe TBI comes along with high ICP, and that high ICP, raised intracranial pressure, is one of the main causes of death and disability in neurosurgery, and moreover in severe TBI. What do we do when we see a patient without an obvious surgical lesion and take this patient to the ICU? We do elevation of the bed, we sedate, we optimize the ventilation, we do CSF draining, we do hypoosmolar therapy. Some people do barbiturate coma. I don't like very much. We are going to discuss a bit over, and of course, hypothermia, which also I don't like. So we should prevent hyperthermia, but not providing hypothermia. So we actually know that in very severe raised intracranial pressure, DEC decompression, the most way to reduce elevated intracranial pressure, because apart from it decreasing the pressure, it can promote the normalization of a lot of abnormalities that we can see, improves the cerebrovascular reactivity, and might decrease some toxic levels of glutamate, lactate, and So DC is a very old senior surgery, which came at the beginning of the 20th century. As you know, Korscher in Switzerland and our pioneer Harvey Cushing also, they did mention, published that DC, it was very useful for lowering the intracranial pressure. So what we see when you go over the literature over the last 70 years or so, between the 50s and 70s, a lot of cases, but there was no standard technique. The craniectomy was not very good performance. They used to do small craniectomies that was very much worse rather than the raised intracranial pressure by itself. So it came into disuse. But in the 80s, with the advances of CT and better knowledge of the cerebrovascular alterations of the intracranial pressure, we had again the willingness of the surgeons to use DC to reduce the intracranial pressure, mainly in very severe trauma cases. But there was no randomized, no RCTs, there was no standard techniques, and there was really a call for you, for us to establish appropriate RCTs just to came out with the indication for this surgery. But in the 21st century, we understood that small craniectomies, they make no good. Bigger craniectomies could be standardized. So that's the surgical technique that we do. That's the skin incision, and we can do the either on two, either use the Kempe or use another opening of the flap. The craniectomy should be very, very big, very wide, and not less than 13 per 15 centimeters, drilling off the pterium, going down in the temporal fossa, reducing, making it flash, just to reduce the main cause of brainstem decompression, as you know, is the ankle herniation. So is there where is the problem? And so you need to go down and to perform at least a little bit of skull-based surgery. What we knew that we know that when in the 21st century, when they restarted with the thinking that DC could be helpful for TBI, so we could see that small craniectomy is not good. So if you compare small with the larger, you see that the surgical results were much better with the larger and appropriate craniectomy. Also, you understood that doing DC, it lowers the intracranial pressure. Yes, DC effectively reduces the ICP, but does it result in better clinical outcomes? That's the $1 million question. That we had two very good trials in the after 2010, the DECRA trial and the Rescue ICP, and we are going to comment a bit about the two of them. So the DECRA trial, they used 155. It was the best clinical treatment, best clinical treatment plus DC. The surgery was bifrontal craniectomy, but there was, that's for me a great flaw because there was no Fox or sagittal sinus division. So what we have the results, we had a greater risk of unfavorable outcome in the DECRA study. The death rates were similar, but one thing that I would like to point out, to ask you to keep in mind, that the mean time from injury to surgery was more than 37 hours. So the rescue ICP was expected with a great anxiety for the results. There is a lot of, I mean, some points that I would disagree in this study. I have no time to comment. But what we saw with the rescue ICP, that really the patient who had the operation, they have a better survival, but there was they had a better survival rate, but the rate of poor results, vegetated and severe disability was very high. Also, this lead most of the neurosurgeons to give up the DC. So we have a lot of points to comment. I have no time to do that, but the point that I'd like to stress, and please keep in mind that 70% were treated in the UK. The median time from injury to the randomization, more than 72 was in almost 50% of the patients. The median time from stage 1 to randomization of 43 hours. The median duration of the barbiturate therapy was 53 hours. For me, it's a nonsense giving barbiturate, poisoning the organism, the brain with barbiturate for 53 hours before you decide what you're going to do. And also a very important point that 63% were bifrontal craniectomy, only 37 were unilateral. I would like to stress that the patient who need a bifrontal craniectomy, they have a very complete kind of disease than the patient who need a unilateral craniectomy. So you cannot extrapolate the results for patients with unilateral craniectomy out of the rescue ICP when 2/3 of this patient had a bifrontal craniectomy. And as I said, a different pathology for me. The crossover, you remember that there was intention to treat, the crossover of 37%. And the results were, as I said, gauged on the intention to treat. But if you go to the protocol, you see that even though the good outcome was a little better, so it was significant. So with 45% versus 32 having a better outcome. So what we can say from this study, the DECRA study, time from injury, 37 hours. The rescue SCP, mean time from injury to surgery, 56. And the crossover was 37%, as I said. So I understand after these two trials, many departments, mainly in the Northern Hemisphere, do not recommend DC for severe TBI. However, when you see patients with a very, very severe grade 5 WFNS subarachnoid hemorrhage, you don't give up treating this patient. You do maximum treatment, and the result of this patient, so although good results was only achieved in 26%, the conclusion of this paper is that no department should be allowed to withhold treatment. So not giving the best treatment for these patients is unacceptable today. So for patients with the very severe subarachnoid, you should do the best. And for patients with very severe TBI, a lot of people say, just keep on in the ICU and try to decrease the intracranial pressure. So I would like to share in the next 5 or 6 slides our experience. So that's, I think, is a very important point because we work in a facility which not, sometimes we have our problems. So the impression that we're going to pass on is very important for the young residents in Africa, where they don't have ICUs or don't have many multimodal monitoring of these patients. So we had a surgical indication when you had patients in Glasgow Coma scale from 5 to 13. So, and also you had these radiological signs of intracranial hypertension to indicate the DC. So the patient who fulfilled this criteria, they were taken to the OR for DC, and so we could not monitor routinely before surgery ICP or any pre-op multimodality of decreasing the raised ICP. So I went over our files from this this year, 13, 14, and 15. So we had 350 procedures of DEC due to TBI. So we divide in two groups, the patients who had the operation less than 12 hours after arriving in our emergency room, and 138 patients who had the operation later on. And I must say that 95% of these patients were operated within the first 24 hours, and 9% of these surgeries of the DC was for a unilateral DC. It was not bifrontal DC, as I said, that the patient who needs a unilateral DC, they have a different disease than the patient who need a bifrontal DC. So that's what we had. We had the two groups, less than 12 hours and more than 12 days. They did match together. There was no difference. When we did compare patient less than 12 with patient more than 12, we will see that we did operate on more patients on Glasgow 8 or less than the, so we had in the last 12 hours, we did operate on more patients in more severe status, with, but the outcome was not different. I must say that these results were gauged by the charge of the hospital. So we went further, and we did operate on patients. We did compare our results less than 6 hours versus more than 6 hours. And again, it was significant from the statistical point of view. So the coma states did persuade us to the operation in a less time. The outcome was the same, and the infection rate was the same. So operating in a rush did not provide more. But again, I would stress that if you wouldn't have operated on this patient in a worse stage, perhaps the results could be different that we have now. So in some patients who are, you know that we did not perform duroplasty in patients. In most of the patients that we did the operation less than 6 hours, perhaps because we were in a rush. We wanted to finish the operation and send the patient back to the ITU. And so, if people ask you, if you don't duroplasty, you have more risk of CSF leak and infection. So you see that our results did not differ from a statistical point of view. So we have some questions. Until you spend so much time insisting on the clinical treatment of refractory intracranial pressure, remember, Decker study at 37, rescue ICP 57. To what extent the delay of the surgical indication might be responsible for unexpected functional results seen on Decker study? And unfortunately, for me at least, the rescue ICP did not seem to have clarified some very important issues as one would have expected. So my final remarks, I say that although patients operated early, they differ the same results. But again, I stress, if we did operate more patients on coma or Glasgow 8 or less, perhaps if you wouldn't have had this very aggressive approach, the patient might be left to die or to become vegetative. And so again, patient operated within the first 6 hours, the results again by the discharge were the same. But again, we took this patient to the OR when most of them were in a worse Glasgow situation. So I think that that's our idea. That's the policy of our department. That I think this message could be important for the young residents in Africa. That we think that there is an early, a relative benefit of early decompressed craniectomy. It should be emphasized that this data have been measured by the time of the hospital leaving of the patient, and certainly when you come to analyze our results of 6 months, like it was done in DECRA in the rights ICP, it's possible that our policy can demonstrate even better and statistically significant data. As I said, it's an ongoing study, and we continue to recommend early DC for severe TBI patients whose some lives with good quality results could be saved and achieved. Otherwise, should conservative treatment be maintained? Thank you very much. This was my message. Thank you.
Thank you, Professor Azevedo. I'm sure that this very nice talk will raise lots of questions from our young colleagues. It's a controversial subject, but we need to move to save some time, and we'll have the discussion by the end. So it's my pleasure to introduce Dr. Eiserberg from Germany, who is a specialist on history of neurosurgery, dedicating her works to this. And she will talk about Alice Rosenstein and the task force, Women in German Neurosurgery of German Society of Neurosurgery. You have the floor, Dr. Eisenberg. Thank you.
Just a minute.
And welcome again, Eric. We are very happy to have you among us today.
Yeah, thank you, dear Nadia, dear Professor Hamlici, dear Fahd Hassani. Thank you very much for your invitation to give a talk in this masterclass. Dear honorable members, dear chairs and colleagues, Ahlan wa sahlan, welcome to my talk as Vice Chair of the Historical Commission of the German Society of Neurosurgery. I will introduce to you the Commission's task force, Women in German Neurosurgery, and in connection with the task force, the first female neurosurgeon in Germany, Alice Rosenstein. 1 year ago, a group of about 20 neurosurgeons founded the Historical Commission of the German Society of Neurosurgery. The first meeting took place in September 2020 via Zoom. The task force, Women in German Neurosurgery, was one of the groups built during this meeting. Within a few months, the small group of 3 women grew up to now 11 members of 3 generations and all career levels. So far, we never met in person, but only via Zoom. In the beginning, one of the connective links between us was the interest in the biography of Alice Rosenstein. She had been the first woman in German neurosurgery and the only one for decades. How did we learn about her? 20 years ago, the German Society of Neurosurgery published a book on its history 50 years after its foundation. In that book, Alice Rosenstein is mentioned, but with almost no background information. We knew that she emigrated to the US in 1933, as many of her Jewish colleagues dismissed by the Nazi government. Since 2012, my colleague Hartmut Kollmann and I started our research on the expatriated early neurosurgeons, among them Alice Rosenstein. The 13 biographies were published in 2017, the English translation in 2019. Alice Rosenstein's grandniece in California provided us with several documents and photos, and we discovered a file in a German archive with a detailed report on her surgical activities between 1930 and 1933. But what was the situation of neurosurgery in Germany in the 1920s and early 30s like? The first pioneers of German neurosurgery were the surgeons Ernst von Lackmann and Fedor Krause and the neurologist Ottfried Förster, Rosenstein's teacher. But neurosurgery in Germany was far from being an independent and modern specialty as it already was in the US at that time, introduced by Harvey Cushing. One example, most of the early German surgeons peeled the meningiomas in toto with their finger out of the brain tissue. You can imagine that the mortality rate was high, as the majority of German surgeons didn't want to give up any of their fields, above all, the mighty Ferdinand Sauerbruch, the Berlin Charité's professor of surgery, the new field didn't have a real chance. More than that, after World War I, German scientists were excluded from international scientific exchange. Nevertheless, some young and ambitious surgeons and neurologists visited Harvey Cushing and his pupils in the US, and from around 1930 on, also the Swedish neurosurgeon Herbert Olivecrona. They came back not only with modern methods and tools, such as a suction device, silver clips, and electrocautery, but also with one message, that neurosurgery had to become independent from general surgery to have a chance to flourish. The yellow marked names indicate those young neurosurgeons who were trained by Cushing, Olivecrona, and Cushing's people Ojenik in Amsterdam. Most of these early modern neurosurgeons were expatriated by the Nazi government before they had the possibility to establish neurosurgery as an independent specialty. In 1937, the young neurosurgeon Wilhelm Tönnis, educated by Olivecrona in Stockholm, became the first associate professor for neurosurgery in Berlin against the will of the academic surgeons, as the Nazis him train neurosurgeons for their planned war. So far the background summarized very briefly. But what about Alice Rosenstein? After basic training in ophthalmology, Alice Rosenstein got a post at Förster's clinic in 1924. You can see her on the left photo, sitting at the patient's head to manage the narcosis in the mid-1920s, and on the right one, operating together with her teacher, Ottfried Förster in Breslau around 1928. The polyglot Förster was an internationally famous, outstanding neurologist with an extensive background in neuroanatomy and physiology, and had visitors from all over the world. His knowledge led him to look for surgical treatment options, and his operations, the other way around, helped him to better understand the theory of localization. He see him with Harvey Cushing in Boston, where he worked as surgeon-in-chief pro tempore in 1930, invited by Cushing himself. Thus, Alice Rosenstein received a broad education not only in neurology, neuroanatomy, neurosurgery, but also in neuroradiology, as you see here. She developed a method to show the foramina Monroy in encephalography, which she published in 1926. Her talent for drawing allowed her to make operation sketches and illustrate her publications. At the end of 1929, she moved from Breslau to Frankfurt to work under Karl Kleist, one of the most famous psychiatrists and neurologists, who was also versed in neuropathology, as you see at the left. She wanted to be trained in psychiatry, but her neurosurgical and neuroradiological skills were also required. In 1930, the most modern hospital for nervous diseases in Europe was opened under Kleist's leadership in Frankfurt. The building plans included an operating theater and an X-ray room. Alice Rosenstein inaugurated both and performed several interventions, most of them for diagnostic reasons like ventriculography, myelography, or ventricle puncture, but also some brain and spine tumor operations. How do we know such details? In April 1933, she was dismissed due to the Nazi laws. During the following months, she wrote a detailed report on all her interventions and gave instructions how to perform the diagnostic procedures. The file with her descriptions is kept in the State's Archive of Hessen. Kleist attested her excellent personal qualities, a strong sense of duty, conscientiousness, prudence, and drive. At the end of 1933, Rosenstein emigrated to the US. As her mother was an American, she had grown up with fluent English. In New York, she worked at the Mount Sinai Hospital in the outpatients clinic as a neurologist, and soon she got an appointment at the neurosurgical department of the Montefiore Hospital, being the first woman at all in the surgical clinic. Due to anti-Semitic trends in the US, she and her brother changed her name into Rost. In 1939, Elise Rost gave up her post. She continued working in an own private practice as psychiatrist and neurologist, but also worked as consultant neurosurgeon for several small hospitals. We don't know why she left operative neurosurgery. One reason might be that her training in Germany didn't come up with modern American standards, but it is also possible that it was too exhausting to assert herself as a woman in this male-dominated field. In 1943, she enlisted in the US Army Medical Corps as a consultant psychiatrist and neurologist, discharged in 46 with the rank of major. Subsequently, she was appointed chief psychiatrist and head of the Department of Neuropsychiatry at the Veterans Administration Clinic, where traumatized US soldiers were treated. She was the first woman to be appointed to such a high-level post in the US Veterans Administration. But she also continued to work as a consultant and in her private practice until the age of 85. She died in 1991, aged almost 93. After Elise Rosenstein, it took more than 30 years until the next few women in Germany were trained in neurosurgery. The specialist in neurosurgery had been introduced in the mid-1950s. The first female full professors of neurosurgery were appointed only since 1993. Although there are now around 30% women in the lower career levels of German neurosurgery, there are only 17% female consultants and 9% female heads of neurosurgical departments. The absolute amount of female members in our society and also of female professors is growing, but as the total number of neurosurgeons is increasing too, the percentage of female professors is decreasing, as shown in this graphic. Our task force approaches the topic women in the history of German neurosurgery using two methods, statistics and biographies. Our first results will be presented at the next Congress of our society now in June. We are developing several networks with the WFNS, thanks to you, Najia, with the Diversity Task Force of the EANS and the students of the Dandy Germany Neurosurgical Club. They want to establish a mentoring program named after Elise Rosenstein. We also plan several publications and try to get funding for a book on the first female neurosurgeons in Germany, those with and those without academic career. By showing these role models, we want to encourage young women to join us in this intriguing field. Here you see our task force. And I finish my talk with special thanks to my colleagues Silvia Hernandez Duran, Aruni Velalakan and Hartmut Kollmann, and to Linda Ross for providing these photos. We hope to intensify the connections to the WFNS, as the international exchange is so important for learning and understanding. Thank you for your attention.
Thank you, Dr. Eisenberg. Professor Khani is maybe not there. So as I said, thank you for this beautiful and nice presentation. Yes, Professor Khani.
I'm with you. If you would comment on the presentation and introduce the second speaker, please.
Yes, please.
Thank you, Ulrich, for this outstanding presentation. And we are very, very happy to have a connection with the women in the neurosurgeon in Germany. And of course, we are ready to continue our cooperation with all the women around the world, and especially with our colleagues from Germany. Thank you so much for your. Thank you.
Thank you very much.
Thank you. That was an excellent talk. Now we are going to shift now back to education under the title of Shifting the Paradigm in Resident Education and Training in Sub-Saharan Africa. May I introduce our guest speaker, Professor Mahmoud Qureshi, who has a talk initially in our sessions today. Just to remind everyone that he's the head of neurosurgery at the Aga Khan University, and he's the president of the CAANS, the Continental Association of African Neurosurgical Societies. It's my pleasure to introduce our second speaker, and I'm very eager to hear what he's going to talk about regarding resident education in Sub-Sahara.
Thank you very much once again, Najia. Adil, it's always nice to see you. We haven't met in a long time, and nice to see you, Ahmed, as well. A very nice talk, Ulrich. It was interesting to hear on the historical perspective and the challenges women faced in the neurosurgery, along with other challenges. So with that, I'll share my screen. I hope it will be with you in a moment. Am I with you?
Yep.
Okay. I felt that in a conference for education and training, and with what is happening around us with the pandemic, we have to think outside the box. And is there a role for shifting our paradigms in resident education and training in neurosurgery? I have no conflict of interest, and it's a pleasure to speak again in the Rabat meetings, as always. I have been there several times, and it's always been a pleasure. I shall miss the fantastic dinner that Professor Al-Khamdishi usually hosts in the evenings, but we shall remiss on that sometime. This is a slide to show how things have changed in Africa. These are the number of neurosurgeons in the East Central and Southern African region of Sub-Saharan Africa, which is shown in the map in the middle, which includes countries such as Somalia, Ethiopia, Kenya, Uganda, Tanzania, Zambia, Zimbabwe, and Rwanda and Malawi, Seychelles and Mauritius. So the situation, as has been outlined in Professor Kamlishi's book on neurosurgery in Africa, the situation in 1992 is outlined on the left side of the slide. And you see that Kenya at that time was the most progressive of the ones in the region. And we had 4 neurosurgeons with a ratio of 1 to 8.5 million. And if you go down the road, right down, the region had 1 neurosurgeon for 16 million people. In 1921, Kenya now has about 38 neurosurgeons, and some are in training. Uganda 15, and the list is given out there, which gives the region a neurosurgeon to population ratio of 1 to 2.4 million. By most standards, one would say that's a good improvement. So how did we get there before this unfortunate pandemic? We got there despite the challenges of developing neurosurgery in Sub-Saharan Africa because of initiatives that we started about 2 decades ago. This is an initiative started by a mission team that we put together that visited institutions and hospitals around the region, conducting missions and teaching and doing courses on a monthly basis, but that was on a volunteer basis. But the true essence came or has come because we, through those initiatives, managed to get in touch with like-minded people who wanted to develop neurosurgery in Sub-Saharan Africa, and we had the opportunity to develop global partnerships. This is in line with the global goals, number 17, which aims to revitalize global partnerships for sustainable development goals. And that global partnership really centers around what we have developed many friendships through, and this is the World Federations Foundation, which started supporting new sites. And these sites meant a lot of people coming and traveling and visiting and teaching residents in our region. Here is one that was very, very popular with the WFNS Foundation and our regional young neurosurgeons, where the WFNS Foundation came and presented and taught a huge number of our young neurosurgeons. But this was face-to-face meetings. We have had huge support from the Asian Congress and the WFNS, as is seen on this side. The first aneurysm, as Yoko mentioned was clipped at this particular course in 2013. We had to go to another hospital to get the angiogram done, and this was the Pentero that the Muhimbili Hospital in Tanzania had purchased but never used for microsurgery for aneurysms, and this was the first aneurysm being clipped. And you see members of the Asian Congress of Neurological Surgeons and members of the WFNS on the right teaching at the course in Mombasa. These collaborations promoted courses across the region, and this is one course, as we mentioned, in June when the first aneurysm was clipped. Microsurgery was being taught to young neurosurgeons, and there were lectures by eminent speakers, including Professor Ling Feng, Bob Dempsey, who are all part of that entourage that Professor Yoko Kato put together. These global partnerships have meant us getting a lot of collaboration and a lot of visits and personal face-to-face interactions with colleagues in the WFNS, in the Continental Association, the Asian Congress, the Yoko Kato Foundation, Foundation for International Education, and the College of Surgeons of East, Central, and Southern Africa. A true collaboration and friendship had developed and maintained to this day. Keki, who is seen on one of the pictures on the right with other colleagues, was with me, with us yesterday at his now very famous Complications Conference yesterday evening. But the key moment in African neurosurgery, as has been mentioned earlier, came in 1997 when Professor Kamlishi and Professor Majid Sami recognized that there was a dilemma and a tragedy going on in some of the lower middle income countries, and something needed to be done. And that has forged friendships and forged the need for the Africa 100 initiative, which Professor Majid Sami took upon his own shoulders. In 2012, with the WFNS, Professor Majid Sami spearheaded the Africa 100 program aimed at training 100 young neurosurgeons, which is an ambitious project focusing on quality assured neurosurgical training, because as we will remember in the past, people would go for periods of between 6 months to 12 months and be observers at centers and come back and be authorized or accredited as neurosurgeons. But those days have thankfully gone. And Professor Sami's project was to ensure quality, full neurosurgical training focused on world-class standards. Thus far, most of the residents that have benefited have been in the Rabat training program and in Algeria and Morocco, but Nairobi has recently been accredited as well. This is an image which really is a historical one. This is when CANS was born, and it was born because Majid Sami and others all came together, Professor Kamlishi, Professor Sam Ohegulam, and many others came in that meeting. Ling Feng was there, Kazadi is there, and neurosurgeons from across the region came, and those who couldn't come were online. And we all decided to unify and form the Continental Association, a dream child of Professor Sami, I must say, that convinced all of us that that was the way to go. So these are key moments in our history. And around that same time, we had formed the Consortium of Collaborative Neurosurgical Sites of Training in the East Central Southern African region, which the WFNS Foundation and the WFNS accredited as its reference site, as an Anglophone reference site in this region. And we have truly benefited from that, because as a result of that, many trainees have gone through the program and have been awarded the fellowship of the College of Surgeons of East Central Southern Africa. There have been 8 Kenyans, 7 Ugandan, Tanzanians, Ethiopians, all qualified from this program. And at the moment, there are 5 WFNS Foundation fellows who are receiving scholarships through the WFNS Foundation. And this has been the impact of the WFNS Foundation Reference Center in East Africa, where many neurosurgeons have been trained and have taken up positions across the region, some in Uganda, others in Ethiopia, some in the mountain region of Kenya, others in the Lake Victoria region in Tanzania. So really this friendship and collaboration has given us impetus in our endeavor to have neurosurgeons in our region. The Foundation for International Education is another close friend that has been with us since 1996, and they have been working with us in centers in Kenya, Uganda, Tanzania. Roger Hartle with the Will Cornell Tanzanian Neurosurgery Project has been a huge supporter and has trained and supported the training in Tanzania for since 2008. The Neurosurgical Education Development Foundation is another friend that developed collaborations with us and has helped us in the region and helped develop the construction of the NED Mnazi Moja Institute in Zanzibar, Tanzania, which was launched by the President of Tanzania in 2015. So from very modest beginnings, here is Shazuo Oi, a close friend of Professor Sami. He always speaks highly of his time in Hanover. And Professor Oi was there in one of the small hospitals in Bugando, Tanzania, for children with hydrocephalus. This produced the first dedicated neurosurgical hospital in sub-Saharan Africa, which does totally free surgeries in Zanzibar. The sites have been impacted through the WFNS Foundation, as outlined in this slide. I shan't dwell on to that. And then everything came to a screeching halt in 2020 because of COVID-19 and stopped us in our tracks and has forced us to all rethink. But thankfully, neurosurgeons, and because of the close friendships that we have made, we will find a way out of this. So a new reality has dawned, a shift of paradigm taking up the challenge of teaching globally. The Education Committee of the WFNS, led by Isabella Germano, along with many colleagues in the WFNS, have been holding regular teaching webinars. In fact, they've become so interesting and so many that it's hard to keep up with them. But really, that's the new reality. And that's, again, a shift of paradigm. How do we teach as we are doing at this course today? The WFNS, through its committees, has become impressively vibrant. On the left is seen the many neuroendoscopy committee webinars that we have held. Just last week, we had the WFNS Global Neurosurgery Committee, headed by Key Park and Professor Wahabi from Morocco. And Lucas is here. There was the hugely successful peripheral nerve surgery webinar. And the WFNS centers have also taken up the challenge, as we are seeing today. And the WFNS, again, has been hugely supportive of international collaborations, and these have been ongoing right through the pandemic. The CANS committees, again, CANS has become a very strong voice in Africa, and through its webinars has been involved in teaching of young neurosurgeons. Here is the webinar for pediatric neurosurgery, and this is through international collaborations, inviting world-class speakers to our webinars. Here is Jack Marcos talking with our own Professor Alan Taylor from South Africa on cerebrovascular surgery on one of the webinars. And again, Yoko Kato with a very vibrant Professor Nasser Al-Gandour of Egypt holding regular congresses. So webinars have become the way to teach. There is absence of physical training opportunities. So we have to find innovative ways to meet, learn, and train the next generation. And lest we lose the gains we have made in the low and middle income countries in sub-Saharan Africa, although the online webinar initiatives have been hugely successful and are invaluable, is there something else we can do? Yes, I think we can. We can use merge virtual reality, as has been shown by Yoko. So we've got to shift the paradigm of education and resident training. In light of the pandemic and for the foreseeable future, conventional meetings and collaborative partnerships through physical visits are not going to be possible. Help Lightning is one such way which allows surgeons to collaborate remotely. We can develop collaborative partnerships through these initiatives. Here is an example of the merged virtual reality. I have my application in the post. It should be arriving anytime this week. Help Lightning uses Merge Reality to merge two virtual reality video streams with one mentor, surgical expert, teaching a mentee on the other side of the globe. And we have surgeons from Europe, North America, South America, teaching, some in the low middle income countries in India, Malaysia. So this is already happening. This allows experts to reach out and directly teach surgical procedures in real time. This was what it was like before the pandemic, where our resident was in Alicante, Spain, but this is not going to be possible. But the Merge Reality can allow him to learn if they are careful. Using Help Lightning with smart surgical glasses, for example, this has been taken to the next level by pairing the application with smart glasses. This innovation allows the wearer to benefit from the assistance, a third party, while performing surgery. When used in conjunction with these, smart glasses mean that another surgeon somewhere else can see exactly what you are doing and what you are doing. I can envisage Professor Sami or Professor Robert Spetzler or Professor Armando Basso having the iPad in their center, monitoring, physically being with one of our surgeons in sub-Saharan Africa and exactly demonstrating how to operate while in real time. And they can also have their hands and tools superimposed in the field to show exactly where to dissect, for example. So this is really something that we need to perhaps take up for our next generation. This can use your existing devices, your own mobile phone. I have the application on my phone, for example. You just need to download it. It's called High Lightning, and very quickly we'll be able to work with any one of our residents. It can be employed on iPads, desktop computers, and you are then able to provide remote assistance as though you are working side by side. So we can teleshare, freeze images, use hand gestures in this Merge Reality environment. The advantage of remote expertise is that this allows us to use gestures and non-verbal clues, which substantially improves the speed of understanding. It's been shown that non-verbal cues are significantly more effective than verbal, just lectures alone. So this makes Help Lightning's combination of verbal and non-verbal communication up to 10 times more effective when teaching a resident. Here's one that is teaching someone in another part of the world. So what's been happening to residents in training in sub-Saharan Africa? Trainees in the East African program have been allowed back into training by their institutions. They had stopped them during the pandemic. The World Federation has sponsored trainees who have no formal remuneration and are required to source their own medical health insurance if they wish to continue training. About 50% have come back into training. Others, because they don't have the finances to take up those insurance covers, have not been able to do so, and they are missing out on training. So we need to overcome this challenge. Online webinars have been a godsend. They are able to learn from masters, as they are doing on this particular webinar, and have an opportunity to regularly attend lectures and seminars. But many would never have been able to attend international conferences such as the one we're having to learn from such masters. Yet it's an uphill struggle. Training cannot be done in a vacuum. We will need to develop virtual online clinical examination skill programs, which we can then teach. We are learning them ourselves because we are now examining patients sometimes online. A fresh approach to teaching hands-on surgical skills on cranial and spinal models, as was shown by Yoko, will need to be developed. We can use technology such as the High Lightning smart glasses, collaborate with willing mentors who would then teach, and this needs to be encouraged. A new avenue for the WFNS Foundation, is it that possible? Our visionary leaders, Professor Majid Sami, Martin Rodriguez, Armando Basso, established this foundation many years ago. WFNS Foundation Chairman Miguel Arias has been hugely supportive to LMIC countries. This foundation has developed an impressive track record of supporting young neurosurgeons by providing them with essential equipment in low and middle income countries. Should we now consider shifting the paradigm by supporting future education and training through such virtual reality approaches? This is where it was possible to travel and visit and work online. This is Professor Kitia in Barara, Uganda, beneficiary of WFNS equipment. This is the store of the equipment that he has received. This is the patient that would never have been clipped. These are aneurysm clips provided by Professor Yoko Kato. And we were able to travel there and work with David Kitia, who's part of the program of East Africa, to clip this posterior communicating artery aneurysm. But that is no longer going to be the regular way of doing business. So virtual reality, perhaps, webinars, definitely, and we need to shift the paradigm of training and education if we are going to not lose the gains we have had in sub-Saharan Africa. With that, I thank you very much.
Thank you, Professor Qureshi, for this very inspiring talk for the young to make them aware of all the efforts done by the pioneers and that need all the goals that need to be achieved yet. It's always a pleasure to hear you and see you. It's been a long time. And now, can I just remember the young colleagues that they can send them their questions for the discussion at the end. And the next speaker, it's my pleasure to introduce Professor Oyezeku, who all of you know as the President-elect for the WFNS, and who will speak and talk about a very important subject for the young, which is in Africa, preparation of a manuscript. And as editor-in-chief of Neurosurgery Journal, it will be very interesting to hear his talk. Professor Oyezeku, if you are there, the floor is yours.
Thank you very much. Can you hear me?
Yeah.
Wonderful.
Go ahead.
And the slides project?
Yes, perfect.
Fantastic. Good morning, good afternoon, good evening. It's a great pleasure to be with you, and kudos to Nadia and Abd and all the wonderful leadership of the WFNS Rabat Training Center, and acknowledge all the other esteemed and distinguished panelists and guests on the webinar. So I thought I would just spend a few minutes discussing the topic of manuscript preparations and give some tips and tricks to the residents and the fellows and the young faculty in the audience. So I would speak from the vantage of my position as editor-in-chief of the Neurosurgery publications. As you know, we produce three major publications: Neurosurgery, Operative Neurosurgery, and Neurosurgery Open. This is our main journal, sometimes called the Red Journal, is the official journal. And we publish both clinical as well as experimental articles in neurosurgery from across all the subspecialty areas. We get well over 2,500 submissions annually, and currently have the highest impact factor in the specialty. Operative Neurosurgery is the second journal we produce, which mostly focus on the technical and surgical operative aspects of neurosurgery. And it has its own independent impact factor, now about 1.886. And we receive a large number, well over 1,200 submissions annually. This one we launched last year, called Neurosurgery Open. It's our open access journal. and it's published as an online only. And then finally, there's clinical neurosurgery, which is, of course, the official register of the annual meeting. So let's discuss each individual journal and the different types of articles that you might want to write to submit to neurosurgery, or in fact, any other neurosurgical journal. Most studies are either clinical studies in nature, cohort studies, either prospective or retrospective. We also entertain a large amount of clinical trials, both on surgical procedures as well as medical therapies. And then clinical protocols about things that are results that are not yet out there, but are trials or studies that are ongoing. And then laboratory research, a small number of animal research papers, review articles, special articles. Review articles can be either qualitative or quantitative reviews. And then commentaries. If you see an article in the journal and you want to say something about it, maybe you have a different experience or a different vantage point, commentaries, very few case reports, and then letters to the editor. And then in operative neurosurgery, we entertain a wide variety of article types as well, videos, both 2D, 3D videos, articles on complications, instrumentation, operative techniques, surgical anatomy and techniques, a few numbers of technical case reports, and then surgeon and institutional case series, which are becoming increasingly popular. We also publish a great deal of guidelines that are produced by both the CNS, WNS guidelines, and you can see here some of the more recent ones that have been published in the journal. And then we also produce some supplements, usually 1 or 2 a year. These are some recent supplements, for example, that recently came in the journal. Here's some other supplements as well, the connectomic, endovascular treatment, and so on. And then we also publish review series of various kinds. As you can see here, we've had review series in neuroradiology, spinal surgery, radiation oncology, biostatistics, methodology, and so on and so on. So these are very important article series that you can access to gain good comprehensive knowledge of a particular subject area. And then the journal has been very proactive in using this format called visual abstracts, where we convey the essential findings of a study on 1 page. It's a graphic, very appealing and easily digestible way of distributing content. And last December, we published a series of these visual abstracts, and you can look at these online. We also publish articles in over 10 languages now, as you can see in the abstracts. And so even if English is not a first language, one can easily digest the abstract of the paper in any of the over 10 languages now. So for the residents and fellows and the young neurosurgeons, as you look at your research work, whether it's clinical research or translational research, you complete your research, and then it's time to prepare this manuscript to send it out to be submitted. And of course, when it gets submitted and it's accepted for review, it goes through the review process. You'll get a decision back from the editorial board, usually from the editor-in-chief. And the decision can either be a rejection, which people don't like to see, but it is a fact of life. If you're asked to revise, that's a good thing, because there's a chance that it will get published. And then you revise, resubmit, it will be re-reviewed, and then it could either be accepted and published, or if the reviews were not adequate, it could go into the rejection pile. We have a series of courses online that you can access on preparing a manuscript. So please use it. This is the website, and these are downloadable and readable freely. You don't have to be a subscriber to the journal. They're free articles. preparing the manuscript, the design of the study, statistical analysis, and so on and so on. So please use this for your training. Now, writing is not, there's no secret to it. If you follow some basic rules, you can produce a good art manuscript. And these are some tips that I've put in here. Even if the writing is good, it can't overcome the drawbacks of bad study design or bad science. So writing only becomes important after the science is good. And we do have English language services that are available for folks who need assistance. First thing is to choose the right journal to submit. Sometimes that is the first mistake that's made. An author may send the paper to a journal that is not appropriate for the particular article. So for example, if the subject is mostly important from the standpoint of your country or your region, then you're better off sending it to a national or regional journal if it doesn't have appeal for other parts of the world. If it's an important paper that does affect people across regions and across continents, then of course it deserves submission to an international journal. So this is one of the first, I think, decision points that an author has to make. We are inundated now, unfortunately, with a large number of what I call predatory publishing journals, excuse me. These are journals that invite you to submit for large amounts of money, open access money to pay, and they're not worth paying for. But unfortunately, a lot of people are sucked into this problem. These journals are of dubious academic value. Some of them are not ever even peer reviewed. And unfortunately, we are seeing more and more and more of these. So be careful about this, this type of invitations and solicitations to send a paper to pay, and then you wind up having to pay to publish. One good way of getting good at writing is to also participate in the academic peer review process. Even if you're a junior faculty or a fellow, you can do this in conjunction with your faculty person. Most of the invitations to review will go to faculty, and then you can pair up with your faculty to support their review and provide that assistance, and your name gets out there in the commentary and so on, and you get more familiar with the scientific writing. Here are some of the sources that I alluded to in terms of English language services. Some of these can be expensive, so you have to be careful to shop around. In terms of our submission site, this is very common with many other journals. They will ask you to adhere to certain rules of formatting. We, for example, also have rules regarding blinding. We are a double-blinded submission journal. Some journals are single-blinded. We also ask for conflicts of interest and disclosures. The conflicts of interest may be intellectual. Maybe you're part of designing a device or something like that. That may pose an intellectual conflict of interest. Some other conflicts are financial. If you have images, whether they're color images or otherwise, make sure you adhere to the image quality requirements. Citations must comply with the particular style of a journal. All permissions from patients and those kinds of things need to be included. And if they're copyright material, also permissions need to be included. And then cover art, if you are going to be considered for cover art and you make a request and so on. Here are some other important things that you will need to pay attention to. Make sure that the work satisfies the requirements of originality or novelty, except of course, if it's a review article. You need to adhere to certain ethical standards. an IRB. Most universities will have an IRB or hospitals. The patient's consent, if it's that type of material that requires privileged health information, all needs to be adhered to as well. And then, of course, in terms of the study design, and you have to adhere to the rules of the publications guidelines. The Equator Network is a very good source, and that's the one I recommend to most authors, to go to the Equator Network website and familiarize yourself with the types of guidelines for reporting that apply to your particular paper. So here's some guidelines that I was alluding to. Here's the consort, for example. This is for randomized trials, and then there are guidelines for literally every other paper type. The so-called do nots of publish and perish. Don't manipulate data, don't plagiarize, don't duplicate manuscripts that have been published elsewhere. Make sure your conflicts are declared and that you don't have or don't violate any human use or animal use concerns. The main reasons why papers don't get published and they get triaged are things such as what you might expect. Lack of novelty. In other words, you're just copying a previous study. There's nothing original or new. The design of the study is poor. It doesn't satisfy the rules of good study design. Or the paper is inappropriate for a journal. You don't want to send a cerebrovascular paper to a spine journal and vice versa. Or it's so poorly written that even though the content is there, the message is so poor that nobody can decipher what the story is. Be brief and short. We have rules about word counts. And one thing that I've found in the years I've been doing this is that authors fail to see that there's always a way to make a paper shorter. There is always a way. And so if you pay attention to making sure that the writing is brief and vigorous, it will go very far in making it more appealing to the journal. So here's a paper that I always like to allude to. This is the paper that was published by Watson and Crick in Letters to Nature on the molecular structure of nucleic acids, the structure of DNA in 1953. And they put everything about this basically on one page. This is the page and this is the reference. So if they can do it, I'm sure you can. So here are some examples of verbosity, excess words. These are examples, and you can see here 4 or 5 words can be condensed into just one word. And so pay attention to these kinds of examples. And if you have a 80% reductions in word, then there'll be an 80% reduction in the overall length of the paper. Hyperbolic statements, like you see, for example, here, these are not necessary. You can be a little bit more precise. And if you're more precise and the writing is tight, then it's going to be much more easier for the reviewers to read and the editor to read. These are the standard parts of a manuscript, starting with the title, abstract, introduction, methods, results, discussion, and then references. But this is not the way you necessarily need to start the paper. So the title, of course, can be the first thing you put in place, even before you have the paper set or the experiments or the study completed. The methods can be written also very, very early, even before results, because you know the methods. The methods are the ways in which you're going to execute the study or execute the experiments. So once you've decided how you're going to do that, you can write the methods long before the results are available. And then as the results get accumulated, then you start putting the results together in the paper. And then the introduction, which basically invites the reader into the actual background and the information and the findings, follows thereafter, and then the discussion. The last real part of the content is the abstract. That's the most important part. That's the part that will be read first by the editors. And so that part of it needs to be the last part, and it needs to be vigorously revised over and over until it's the best you can make it. And then finally, the references. In my experience, the title is so important that it may actually determine whether the paper gets read or not. And if the title basically is not worth looking at, then chances are the abstract will probably not be worth looking at, and so forth. So make sure the title tells the story as to what the paper is about, and that it really educates the reader or the editor as to what it is they're going to be looking at. As I mentioned already, the abstract is the most critical part of the paper because it contains all of the content in a very condensed, pithy manner. It is there that the title will be found. It is there that the main objective of the study will be found. It is there that the most important and salient results of the paper will be found. And the major significance of the paper will be that in that area as well. As much as possible, avoid acronyms, because unless they're very common acronyms like MRI or CT scan or that sort of thing, it's not worth confusing the editor and devising new acronyms that are only best known to you. The introduction really tells the story about why the study is important, the background behind this, what question is going to be asked and why, and then how that question is framed in the hypothesis. And then the summary of the findings will constitute the last couple of sentences in the introduction. The methods and materials, as I said, can be written whilst the research is still in progress. It should be detailed enough to provide information to someone else who wants to duplicate the study or repeat the study. And that's the nature of science. Many times studies have to be confirmed elsewhere in other countries or by other institutions. And then descriptive subheadings should be used in this area so that the reader can identify what it is that they're looking at. In the results sections, use as few words as possible, use lots of tables, lots of figures, lots of charts, lots of color, and very little words. And the less words, the better, and in the results section, in my opinion. And then the discussion, this is where a lot of people get lost in the weeds. They tend to ramble a lot in the discussion, and this is the way I would compose the discussion. The first thing about the discussion is to answer the question that was posed in the introduction. And that's why you start the discussion, or we have found the paper or the experiments confirm the finding. There should be statements that really direct one to the question that was posed. And then you want to relate your conclusions to the existing knowledge in the literature. Are your findings different? Are they confirmatory? Are they unexplained on the basis of existing literature? Do they raise other questions, and so on? And then, after your key results have been written about, you want to discuss your limitation or the limitations of the study. If it was a very small study, if it didn't examine previous treatments and so on, that needs to be made there. And if you address those limitations up front, then it's going to be easier for the reviewer to be less critical. And tell the reader what's new without really exaggerating your findings. And you do not need to rehash or repeat the results in the discussion section. A lot of authors spend a lot of time and words going over again in the discussion what has already been said in the results. That's not the place for that. The discussion should be focused really on the things I just mentioned. And then finally, the conclusion and summary should provide perspective and the implications of the study. Make sure that the references you use are relevant references. A lot of authors tend to just accumulate references. Some of them they didn't even read. You need to be selective and make sure that the references are truly, truly pertinent to the article and to the points that you're making in the discussion or in the introduction. And if you're referring to methods, also make sure that the references mirror those things that you want to raise attention to. And then make sure that, of course, that they're in the correct style for the journal. And then wait to get the results of the peer review process. If you're lucky, rarely, very rarely, it may be accepted right off the bat. That's very unusual. Most of the time you get a revise or a reject. If you get a reject, don't be discouraged. If you get a revise, circulate that amongst the authors, your authors, and answer every question that has been raised by the reviewers or the editors. Carefully prepare the responses. Each comment should be addressed. If you don't address a comment, they will send it back for your attention. Bear in mind that sometimes the reviewer may be wrong. They may not know some of the pertinent things in your paper that you didn't mention. And if it seems like the reviewer may be confused or wrong about their comments, try and clarify that. Don't get annoyed or displeased that they raised an issue. Be tactful and respond. I always tell folks to avoid calling the editor unless it's really necessary. The editor is very busy and cannot attend to everybody by phone. So send a note on email, but most importantly, answer the questions that have been raised first before you start calling. And make sure that all the authors that are included are also participants in the revision as well. And then send it back and wait again for the final decision. So I wish you all a glorious and successful career in neurosurgery, particularly in scholarship and publications, and send me some good papers and I'll be delighted to send you our opinions. So thank you very much. And thanks again to Nadia and Abdel Salam and all the other wonderful people in Rabat. We hope to visit with you shortly when this COVID nightmare is over. And thank you all our dear colleagues in the world. Thank you.
Super. So Adil, I'm not sure, Professor Najia, do we have time for some questions?
Maybe 5 minutes.
Okay, so maybe I'll ask Adil to start with the written question for people who submitted through the system, and then we go for the rest if we have time.
Professor Bakhti wanted to make a comment. Is she there?
Ed? She's here?
Yes, I'm here. Yes. Okay.
It's great to see you, Suad.
Thank you. But I can, the video doesn't work. It's fed.
It's coming.
Okay.
You can start, please.
I just want to make a comment about the presentation about the history of women in Germany. And I want to thank before the organizers and Professor Najia Al-Abadi and Professor Khamlishi for this outstanding meeting. But
excuse me, Professor Bakhti, hi.
Okay.
Can you turn on your video?
It's okay.
It's good.
It's good.
And I want to congratulate Professor Eisenberg for her presentation. I just want to give some remarks about women in neurosurgery and their contribution. I think that the principal problem is the lack of female mentorship around the world. And fortunately, we have women as Yoko Kato, as Najia Al-Abadi, as Nelson Zanan, and all these women are doing their best, but it is not enough. And I want to answer Professor Eisenberg that when I've been chairman of the WFNS, we try to contact some European colleagues to include them in the committee. but it was not possible. Currently, we are working only with the Italians. Fortunately, they accept to contribute with us. We are doing a lot of activity. And I just want to say something very particular is that in Africa, neurosurgery is very young. But paradoxically, women are going more and more toward this specialty. What is the explanation? Maybe the example of Morocco and Algeria, where women are numerous in these countries. If it is that, it's a good thing. But I emphasize also always about the female mentorship. That is my comments.
Oh, thank you very much, Professor Bhakti. That's very interesting. And of course, we would very much like to cooperate with the WFNS. And we are now, I think, in near future, founding a group of women organizing a mentorship program and connecting with other countries too. So yeah, would be nice to stay in contact.
Welcome.
Thank you very much, Suad, knowing that you are ill and you are here with us, and we wish you a speedy recovery, inshallah.
If you allow me just to say one word, in country like Saudi Arabia, in the last 3 years, female residents are more than male residents in neurosurgery training program. Just a small comment.
Yeah.
It's a good news.
Good news.
I don't know. We will be minority one day.
You know, when the woman is in neurosurgery win. This is one of the...
Yeah, I was very much astonished to hear that, to learn that in Algeria, for example, there are as many female neurosurgeons as male neurosurgeons almost. So that's a really, really nice role model for us.
Thank you very much, Eric. And really, it's a nice. We enjoy your talk and the history of not only women in neurosurgery in Germany, but also the history of the German neurosurgeon and what they did for the development of neurosurgery around the world. Thank you so much.
Thank you very much.
Adil, maybe there is some questions from the floor.
Yes, if we can take some questions from the floor. So all of them are for Professor Azevedo regarding the compressive craniectomy. From Saburi and Uday, they ask about the value of cysternostomy to add it to the compressive craniotomy. And Uday is asking also about where we should progress our ideology for practicing to develop a multimodality treatment for ICP management and evaluation and go for DC. So maybe you can, Professor Azevedo, a quick answer to the young.
Well, my quick answer to the cysternostomy and the hinge craniectomy, I've done a few times, dozens of times each one, but I never could have good results, so it had to turn up and to do the full craniectomy. So we no longer do cysternostomy or hinge craniotomies because for me they don't work. And also, if you have to monitor our patient, unfortunately now the department we had to send the patient back to the ITU, and I only can have a bed in ITU if I take from the OR. So my experience, we don't, when you do the craniectomy, you don't need to put a catheter. You spend a lot of money to put a catheter because my experience, the intracranial pressure is no longer high. We did a few cases and we had the experience that there is no need to monitor the intracranial pressure after the decompression. So what we do is just to maintain the clinically normality of the patient, but I think that it's good if you do a local hypothermia. If there is no longer bone, you can just put ice over without having the care for not pressing on the brain, but you can put ice and the lower temperature locally. They can help it might help the metabolism. I'm not sure, but that's what we do. Thank you.
Thank you, Professor Azevedo. My great thanks to all the speakers, Professor Khani, and I give back the words to Professor Abadi to introduce the next session. Thank you. Thank you all.
Thank you very much.
Thank you, Adil, and thank you, of course, our distinguished speakers for these outstanding talks, and of course, our friend Ahmed Al-Khani for his moderating this session, and to be with us always as moderator and as faculty. Thank you very much. So we move to the last session. And I will ask my friend, Professor Abd Samad Al-Azhari. I think you all the colleagues present today know him very well. He was one of the awarded Medal of Honor of WFNS, and he's a professor, of course, of neurosurgery. He's actually currently the chief of department of the neurosurgery in the Sheikh Zayed Hospital in Casablanca. Please, Abd Samad, and your co-moderator is our friend, great friend from Niger, Professor Samiola Sanusi. He is here, of course.
Yeah, he is here.
Sam, you are here?
Yes.
Sam, please.
Yes.
Yes. Of course. Thank you so much. Thank you so much for accepting our invitation to moderate in this session. And I know how much you are committed to of course developing our specialty in our continent, and also for the development of the education of young neurosurgeons, especially in this area on the sub-African region. Thank you. So you have the floor.
Thank you, Najia, and thank you for all my friend organizers of this very, very nice courses of masters. So I remember in my school when I started in childhood, the teacher tell us, just if you want to learn, just follow the mentors and the masters. And it's very, very nice to see all these masters here in these courses sharing their experience, and give all neurosurgeon some tricks and some tips, as we say. And it's a great pleasure for me to share this session with my friend Professor Sanusi, who is head of Department of Neurosurgery in Niamey, in Niger, and he's currently president of ANSA. And we are going to listen to 5 World Neurosurgery Summitis. Normally, we have to present them, but you know them very well. And it will take us a long time just to read their CV. So please, sorry, we haven't the time to read the CV for 5 summities, but shortly, we want to present them. Professor Majid Sami, everybody know him. He is last president of WFNS society, and he is ambassador of WFNS in Africa, and he is honorary president in WFNS. Professor Osman is also honorary president of WFNS, and Professor, my friend William Caldwell is the president of WANS, and he is going to organize a meeting of WANS and he is very active in the academy. And Professor Kenan is second president of WFNS, but currently he is in INS. And we discussed with our president of CANS, Qureshi Mahmoud, and Najia, perhaps if the sky is open, we will participate in August in the INS meeting. And the last one is André, good friend and the president, last president of European Association of Neurosurgery. We will start with the first speaker, who is the professor, our friend Professor Majid Sami, for optical neurological education. We learn a lot with you, Professor Majid Sami, in education, and it's always a great pleasure to listen to you. And every time we listen to you, we learn and we have some things more. Thank you very much, Professor Majid Sami.
I will share now my computer with you. Do you have my? Am I online? Yes. Okay.
Please, Professor Majid Sami, if you want to go to full screen mode.
Am I on the screen?
Not yet.
Yes.
Not
Yes.
yet. Not yet.
Not yours.
Not yet. Yes.
I am.
Jafarama
Just a moment.
is at the bottom.
Now.
Not yet, sir.
Dia-voorstelling on the right lower end. Yes, down,
Down, and right.
down, very
down. Yes.
Right is
No, just
close
little
one.
bit
There are four
on the left.
On the lower. Ja, das war's fast. Das war's fast.
That's what. Look, yeah, I go back just a moment.
Professor, you can just push F5. It can work.
Also, yeah.
F5.
Maybe Fad, you can help Professor.
Yes,
oh,
yes, it's okay.
No, I am.
It's wonderful.
okay.
It's okay.
Now I am online.
Yeah.
Yes.
It's okay. Yes.
Wonderful.
Yes.
Please.
Okay. So, first of all, of course, I would like to thank our moderator, Dr. El-Zahri, Dr. Azhari, whom I know for so many years, and he was also always in our team in every courses which we had in Rabat. And today I decided to speak about my experience over 50 years for education of neurosurgery, which I have seen in all over the world differently. And therefore I wanted to discuss with you and explain what are my thoughts about the optimal education for a young neurosurgeon. Hello?
Yes. Yes, it's okay.
Yes, but
Yes, everything good.
Yes, but I have not. Yeah, okay. But I cannot go to the next. Yeah, and I am online, but
maybe Professor Majid Sami, if you want,
yes,
wanna.
It's okay. It's okay.
It's okay. Okay.
Yes. And if you can perhaps to put our pictures just at the overline and not on the right side, then you can read also what I have I am presenting. Do you understand me what I said?
Mm-hmm.
Put on the top the pictures, because this cat, a part of the content which I am demonstrating now. Anyway, when we are talking about the education, we have to know that we have a different level of neurosurgery in different countries. And when we look, then because the different countries, even in the same country also, it is different because it is based on the different technical standards, different experiences of the teachers, and expertise existing in this country, in this department. The philosophy of education in neurosurgery in general is different. From one side, the people push in some departments the theory, study of textbooks, internet, guidelines. On the other side, there are departments that are pushing the practice as a learning by doing. And what is the ideal condition between theory and practice? I think it is very important that we have a balance between both sides. We need theoretical, but also at the same time, the practical education. What is a neurosurgeon? He knows everything, but he cannot do simple surgery. That is one of the main points that we never are talking about that, you know. And can every center provide the same program? This is almost impossible. Therefore, we need exchanges between the different departments in the same country or in all over the world. Therefore, is this a scholarship and changing the trainees from one country to country. I think it is very important because that opens the vision of the trainees. And the other thing is that with general guidelines, try to make to help to get a standard of the neurosurgery in every places. Only partially, but not completely. Guidelines is only one side of the story. What are the best criteria for optimal neurosurgical education? That is my question, that is my talk. First, which factors influencing neurosurgical education? I think there is no doubt that the ability of educators and the trainees, both are I would say fundamental precondition to create a wonderful neurosurgeon on the long run. It is, of course, important which program in the department is existing and which technical standard of the center. We know that when we are talking about different departments in Asia, in Africa, in Europe, in the States, and who can then provide every neurosurgeon in training all the technical standards? This is also almost impossible. The ability of the educator in education and in praxis. This is one of the most important parts. And of course, the educator knowledge and behavior is fundamental because all the trainees looking to the teacher and yeah, if the teacher had enough knowledge to discuss with the trainees, and his behavior is very, very fundamental, because they learn not only the neurosurgery, they learn also the behavior of the teacher to the residents, to the associate, to the patient. And this is also very, very important. The educators need to be aware of very important fact, moral, ethic, and demonstrates to the trainees their honesty in his personal behavior and to his also own patients. And the other thing is that the educator have to know the needs of the patient in all aspects. When you are in front of the patient, you must consider what is their expectation of the patient to you. And that is what their residents have to learn. I have to find out what is the expectation of my patient. Also, the professional educators need to be excellent and competent, but in the same time, have the ability, remain flexible and capable enough for changing demand. Neurosurgery is changing permanently. I know some neurosurgeons who have been in some other countries in Europe, and they went to Asia 30 years ago, learned something and goes there. And over 30 years, these educators are teaching to the poor young fellows in the department the same things what he has learned 30 years ago, but he has not been developed further in his knowledge. We know that the knowledge about biology and technology is rapidly growing, and that is an ongoing process which the educators has to follow that in all his time. Education is a dynamic problem, and the educators must have certain ability for acquisition and application of the knowledge which he has received or the developed knowledge in his society of neurosurgery. I believe the optimal educators of professional educators is someone who knows the way, who goes the way, and shows the way. And patient welfare must be in the center of any consideration. This is something that the young people are looking to the face of educators, how he behaves himself in front of. If the patient means nothing for they believe that that is the way, but we have to go. But if the educators is with all power and knowledge are behind the patient, is completely another education compared to the opposite. How we can select, that is a very important point. The trainees, what makes an application to be good candidate? I must tell you, after 50 years, I am exactly 50 years professor of neurosurgery, and I have trainees with me that not only from Germany, but from all over the world. This is really very difficult. You never know in the beginning, you get some impression, but it is not so easy. I have put here some aspects, best results at the school, motivation of neurosurgery, family background, social engagement, sport activity, ability to play a musical instrument, ability to speak different language, ability to write good scientific papers, as Nelson has in his talk described, ability to present paper. I must say, the best results of the school to my understanding, doesn't mean anything. If we take only this as a factor to select the people for education in neurosurgery, this is for me wrong. But motivation is a point that I want to explain. What is the motivation and what means motivation for the trainees? Motivation, what is the origin motivation? We have to think about that. I believe that motivation had two sides. Is a primary, a spontaneous motivation that you have seen a neurosurgeon or you have seen some neurosurgical operation and you spontaneously you say, I want to be that, or secondary motivation. The second primary motivation, as I said, is an internal drive, impetus. It is, I would say, that is love. If you fall in love in neurosurgery and say everything else is nothing for me, then that's the primary motivation is very, very important fact for further development. This primary motivation triggered by our subconsciousness very much. We can work 10 times more than anybody else when we have this primary spontaneous motivation. Its development is still a mystery. Do you know why you love somebody immediately and say, that is the person I want to live with him? And can you explain that? Nobody can explain the love. This is a mystery for all scientists. Nobody has described really what it happened. But when we go to the secondary, I would say, motivation, this is the question how we can create influence the motivation as a secondary motivation. But we know that by secondary motivation, there is no motivation without reward. So, and this has also two sides. One is the material, one is immaterial. The material is that somebody believes, oh, when somebody is neurosurgeon, has a good income and has a good position and so, and also I get a better life standard. That is the material. But immaterial is, oh, as a neurosurgeon, I am honored into society and I have recognition and here's also, and then I have satisfaction. Motivation, of course, increase the activity of the people. And what means activity if this increase? We have the activities in two sides. One is organized, the other is not organized. The organized is well structured with high efficacy. Non-organized is the artificial activity. I know from hundreds of my people working with me, I have people came at 7 o'clock in the clinic and then after 4 o'clock afternoon, he organized everything. He did everything what he had to do. And as we went home, you can write at least 10 pages what he has done. But we had on the other side, the artificial, the people came to the department earlier than everybody else, and they went late evening at home. But if you would evaluate his work, then you will see nothing effectively has been done by this person. And therefore, the activity must be organized on high concentration, must be directed to the goal, and then the people can, of course, achieve the best results. Looking at these aspects I have described here, and if somebody has all this, I must mention that all these parameters can predict a quality of a good trainees. I would say these parameters can help, but they cannot replace the personal character of the trainees, which is honesty and dedication to the patient, and which will determine the future outcome. And looking then to the skill, what is the skill does not, what does mean? It does not mean the manual ability, but skill has many aspects, and the aspects is related to the patients. The trainees, they must be always aware that he must know 100% the history of the patient, and perfect neurological evaluation, consideration of neurophysiology, indication for neuroradiological examination, evaluation of laboratory tests, social life and environment, and as included the expectation of the patient. And last but not least, mental power and health condition of the trainees. Neurosurgery is such a difficult and I would say complex of mental and also power of everybody, that if a trainee has some weakness in his ability, he cannot survive this hard life in many hours in operating theaters and many things that belongs to that. Therefore, the health condition is also very, very important for later success. What is the value of research? I think Nelson has described that, but I would say what type of research is important? Clinical or basic research during the education? It is very important, as Nelson described, to write a scientific paper. With this scientific paper, residents, they learn the state of the art of the neurosurgical topic. And I can remember, as I was a young assistant, my professor told me, if you want to learn something, write a paper on that topic, and then you learn everything, what belongs. And therefore, the scientific work is also very, very important for higher, I would say, education in neurosurgery. Basic research only for academic career, if it is only. And how we can evaluate then after all this, the training program. This is also very difficult, I would say, only by outcome. We can only at the end, it takes many years. And therefore, still after all this description I had, we cannot in every young trainee then predict what will happen with him. I think it takes many years, and they are always different. If you look at this picture, you see the formation of a neurosurgeon. I believe they should start as soon as possible. And I personally, I felt in love with neurosurgery as I was 11 years old. And the brain synapses and the motivation and all, they create a situation that you don't need to work hard to become a good neurosurgeon. You learn everything with love and with really interest. You see here one of my grandson. At that time, he liked sport, and I took him to the golf course, and he started to hit the ball, and he was enjoying that. The other one, a younger brother of him, he asked me all the time, can I come and do you operate on the microscope? I want to see how everything looks on the microscope. And he came in that age, you see, it is about 5, 6 years old, and came to and wanted to see What is he doing? He's now in the medical school and learning medicine and studying medicine. And I'm sure he wants to become neurosurgeon. And therefore, I think it is important that we, for education, we have really have all these parameters, consider all these parameters. And what about the continuing education is also very important, because when you have the board of neurosurgery, education is not over, as we have seen. And we spoke today about the Rabat Center, which started in 1998, as we had only 79 neurosurgeons in Sub-Sahara by 500 million people, as you remember, with the foundation. And this picture is very important because it's a historical picture, as at that time I was signing the contract between WFNS and the president of the university in Rabat with Professor Hamlishi, who started with that. And I was trying to speak in all courses. I think I have participated from beginning until today in every courses, and you can see people in the course coming, the best teachers, and we were continuing always this education by African colleagues. You see, this is from 2011 in the fourth Rabat course. You can see, I'm sure you know many of them are in this course, and the number was from year to year increasing. And that is what I have done. I have in 1971 started to, after 5-year experiences in microsurgery, started to organize microsurgical courses to teach other. 1979, as you see here, the first ever course on skull-based surgery I started in Hanover. They are the first people from neurosurgery, ENT, maxillofacial surgery who came to our course, and I did life surgery. And Professor Lang was one of famous anatomists, neuroanatomy. That was my late colleagues, Professor Wolfgang Graf in that time. And then we continued in the INI in Hanover, and I have tried also permanently every year, 1-2 years. Now we have a corona, to continue the education for all these people. Even they gone home, but they come every year to me, and we had the education in laboratory to give them opportunity to do it in cadaver. And I did always the surgery by a master microscope, and they could then do the same by themselves, and they're enjoying every time. And this education is so. And I did this in all continents. This is an example for China, as we started in China to do that. And here all teachers in China during this time, we have educated almost all Chinese colleagues in neurosurgery. And this is the China INI, where today the same people who have educated doing every day 25 neurosurgical cases. And this is something that I wish we achieve in everywhere, particularly in Africa, that perhaps in 10 years, we have not only 2,000, perhaps 20,000 neurosurgeons who are working there. And I think that if the educators and if the trainees are successful together, they can achieve much more. Thank you very much for your attention.
Thank you, Professor Majid Sami. Very, very nice talk. But it's first time I see that you make a baby with the skull. But he's thinking, what's that?
That is a symbolic picture that looking at the skull, and the baby want to see what is in the skull, and that's great, and it's wondering what is inside of the skull. And that is probably.
Thank you, Professor Majid Sami. We move on the second speaker, which is Professor James Osman. very known also for many works he did, and he will speak about how neurosurgeons learn and interactive discussion. Please, Professor Osman. Fed?
Yes, good afternoon, everybody. It's a pleasure to be here. Professor Kamlichi, I appreciate the opportunity to come, and I say hello to all my colleagues and to the young over 100 people in the audience. Welcome. My talk is going to be a little bit different than what you've heard. I'm going to talk to you about the most important lessons in medicine that I learned. First of all, I've been very grateful. My wife and I have been able to travel all over the world to many countries. We've been to countries that are low to middle income countries, the obviously high income countries. We've been with people who are farmers and poor people. We've been with very rich people. We've been in the cities. We've been in the small communities. And we've learned some very basic principles. And the basic principles are that people all over the world are the same. People are concerned about their family. They want to have independence in fulfilling their life dreams, in making their life dreams come true. And they want peace. But there are some rulers in the world, some leaders, who have different interests. Their interests are in power, in controlling the people, and in money. It happens all over the world. No country is immune to this. But the people are the same, and the people want some very simple things. There's a very simple rule in medicine. This is the most important rule in all of medicine. The patient comes first. The patient comes before any other consideration. If you travel around the world, as I have, you've been to hospitals, you've seen governments and organizations, you've seen different healthcare systems. You've seen personal issues that come ahead of the patient. I was taking care of a patient at 2 o'clock in the morning. I asked a colleague who was home to come in and see the patient. He didn't want to do that. He wanted to sleep. The patient wasn't important to him. We all know that there's politics in medicine. The patient needs to come first in all the considerations before the politics. There's politics in neurosurgery. The patient needs to come first. That is the central decision of everything. It takes precedence over every other decision in medicine. What is the truth? If a patient comes to you, the patient asks you to take care of him or her. At that moment, the patient is making a contract with you. And in that contract, although it's not written, it's not in any hospital document, the contract says that you, doctor, will do everything you can in your power to help me, my wife, my children, my family, and nothing will interfere. Not your personal life, not hospital committees, not any other consideration, because I'm giving you my life. I'm giving you my wife's life. And I want to know that you're 100% devoted to our lives. Nobody ever says that. It's what happens when the patient goes to the doctor. That's the unwritten contract. The patient looks at the doctor and asks the first question. He says, do I want this man or this woman to operate on me? And that depends upon how you look, how you act, what you say, how you dress, because that's the only impression the patient has. We're living in a time where there is no truth. We just wrote a book on the China virus. What is the truth? Scientific publications by journals across the world have published articles that are untrue. And they had to be retracted by Lancet, New England Journal of Medicine, JAMA. Major journals in the world have published lies. What is the truth? There is a truth. You know the truth. The patient knows the truth. If you operate on the patient, we had a patient came in, we took a angioplasty out of the posterior fossa. Patient was doing well for 7 days, had a ventricular catheter and went down to radiology. The radiologist injected dye into the catheter. The patient seized and died. Radiologist didn't go see the patient, we did. And I told the patient, we made a mistake. That was our fault. How many people do that? I've been to hospitals where the lawyers tell them not to tell the truth. That's not right. The truth is important. The patient expects the truth from you always. And right now, our profession has been damaged by people who have not spoken the truth. And people don't know if you're going to tell them the truth. You have to earn that. If you were a patient, your wife was a patient, would you want the truth? You want the truth always. If you've only done a few cases, are you going to say, well, I've done a whole series of the cases, or the literature says this? That's not the patient's question. How many have you done? I've done 3, or I've done 5. Well, do you think you're comfortable doing that? Well, if you want, I can find you another person who I think has more experience. That's the patient's decision. It's not yours. Or I'll get somebody to help. There are doctors who see the patient for the first time just before surgery. That's a travesty. That's a mistake. The truth. What is the truth? You are responsible for the truth, not what's politically correct, not what everybody wants to hear, but the truth. The patient, if you think about this, the patient is a member of your family. You have to treat the patient like they're your brother or your sister or your mother or your uncle. What would you want done? We read about all the randomized trials and all the studies done. I've been involved in a randomized trial as a patient. What is best for the family? What is best for the patient? I was taking care of a woman who's 62 years old, and I wanted to, every patient, I want to see and talk to the family, because I'm not operating on just a patient, I'm operating on a family. It turned out that this woman who had a large pituitary tumor was the head of the family. Her husband had died. She was what we call the matriarch. And the children all respected and were very, she was very important in their lives. Do I do an operation that leaves the patient with some deficit? Absolutely not. I do what is best for the patient and what's best for the family. I had a colleague who was operating on a patient from South America. And one of his colleagues said, well, why don't you take the whole piece of tumor out and everything? And he said, and he didn't understand. Patient did well after surgery, had a subtotal removal, sent him home. He could not send a patient home paralyzed. That would be a disaster for the family. So there may be randomized studies. There may be all kinds of new things. I had a patient come to me with a glioblastoma, and we took it out and for He would have to have radiation therapy, traveling 6 hours every day to come and get the radiation therapy after surgery. For 2 months of survival? That makes no sense. So there is a truth for every patient. There's common sense, there's judgment. That's what you learn. And remember, every patient is a member of your family. They should be treated like them. You're all worried about what is success. I'll tell you what I learned. If you take care of the patient, you will never, ever have to worry about getting more patients or money. If you care more about money, you will lose both. Money and the patient, and more patients. There is a simple rule in life. Do unto others as you would have done unto you. This is fundamental to every religion on earth. It has been the fundamental principle of civilization from the beginning of time. It's the fundamental rule when you interact with each other as colleagues or in the hospital. Do unto others as you would want done unto you. People who don't believe in that don't belong in a civilization. They belong by themselves someplace else. For us to live as a society, we must live by this rule. This is the rule of all history, all time, all religions. Even if you don't believe in God, even if you don't believe in Allah, you have to believe in this. It's fundamental. We're at a time when a word has come up called racism. Never thought about that word. Color, race, sexual preference, religion, country, politics, it means nothing. When I make the incision, I don't know anything about that. When the patient's under the drapes, I don't know what color they are. I don't know what religion they have. I don't know any of those things. It doesn't mean anything to you as a physician. The patient means everything. So those are the principles and the lessons I've learned. I hope they help you. I want to thank you for listening. I wish you good luck in your future. If you want to write me, my email address is down below. This talk was not about me. It's about you and your future. And I want to thank you all for listening.
Thank you, Professor Osman, for these extremely valuable advices. But it's amazing. People here, and in the United States, I think is the same, because people here tell us always, please treat the patient like your family. If it was your son, how do you do? Exactly the same reflection everywhere in the world. And very extremely very valuable advice, because in university we tell to the patient, to the students, please learn your job, but don't run after money, because the money will run after you after that. So thank you very much, and we go to the next speaker, Professor Sanusi. Do you hear me, Professor Sanusi?
Yes. Sam, you are here.
Yes.
Maybe you will
Could you
moderate.
continue the moderation of this session, please?
No problem.
Okay, please.
So thanks. I want to thank Nadia and also Professor Hamlishi for continuing education in Africa. And I'm very impressed by the learn from Professor Majid Sami, from Professor Osman. They are both very, very deep knowledge, very philosophical. I hope that many young Africans, young neurosurgeons in Africa are online. And I hope that, I'm sure that it will be very, very structural change for them. So now we are calling Professor William Cudwell from United States to listen him about career mentorship in neurosurgical residents and fellows. Thank you very much, Professor William Cudwell. We can talk now. Thank you.
Thank you very much. It's an honor to be here. It's a special honor to be in this session with Majid, Sami, and Jim Osman. And I want to thank Professor El Abadi and El Kamlichi and El Awabi and El Zahari for their kind hosting of this event. And this is a bit of a divergence for me because I usually talk about surgical technical issues, but the topic was really education for young neurosurgeons. And what I'd like to do is I'd like to talk about a historical vignette that's close to me and also weave it into a mentorship paradigm that we've adopted and to share some of the things that I've learned over the years. And I've been very fortunate. I actually am Canadian and I grew up in Canada. I went to medical school at McGill. And some years ago, Bill Findell, who was one of my mentors in medical school, who was one of the directors of the Montreal Neurological Institute, and I wrote a historical vignette on Osler and his impact on neurosurgery and our early neurosurgeons. And he was an amazing individual. He started his career, he went to medical school at McGill and then came back as a professor. And then when he died, after he died and he spent his final years at Oxford in England, and he left all of his library and his chair and everything to McGill University. And it's in this prominence at the bottom of the medical school. We used to call this the beer can on the hill, as this was our medical school building. But his Osler library is in this. And if you go to Montreal, I encourage you to go visit this. Bill Findell was the curator of the Osler collection before he died a few years ago. But Osler was born in Ontario, but he went to medical school at McGill and then came back barely 2 years after graduation. He traveled in Europe and then came back, and he was a pathologist. And he was appointed to a position at the university and at the Montreal General Hospital at that time. And his students, he was so young, his students referred to him as the baby professor. And this was the medical school when he returned following his trip to Europe. And here's a diagram from 1874. And here's a picture of him as a young man. And he started his career at McGill. And he spent 2 years after his graduation in Great Britain, Germany, and Austria, learning from all of the great academic masters at that time. And then he came back to a small position where they gave him 15 microscopes, and he started a practical course in microscopy and histology. And it was interesting. He did this at Saturday mornings. He developed this conference in the back of the Montreal General Hospital in a stove-heated shack. And he would meet with the students every Saturday morning, and they would go over clinical cases. And he did over 1,000 autopsies during that time, and he published an abstract at least on every one of them. It's remarkable. And we have that all bound in the collection, historical collection. And this is a picture of him doing a brain cutting on an autopsy patient, obviously. And he described many neurosurgical aspects of the patients that he studied. And here is an example of a cerebral aneurysm in a 40-year-old woman who died of an aneurysm. And he went on and described really many seminal observations of neurosurgical disease. And he carefully described all of these. And here he actually drew a picture of aneurysms of the cerebral arteries in a compilation of patients that he'd taken care of. And you can see they're all in the common places that we assume today. He made interesting observations as well. And some of the things he didn't understand what he was looking at. This is the first description of Aterson syndrome. It was in his autopsy studies when we looked, involving the hemorrhage involving the base of the brain and extended along the sheaths of the optic nerves to the eyeballs. So remarkable. Again, it didn't have his name, but he described the seminal observation. CC fistula, again, he didn't really understand what was happening, but a patient who had trauma and they had several attacks of epistaxis, and then patient died of epistaxis. He also described many brain tumors. Here's a thalamic glioma, and he drew all the cells himself, all the different cells, the histology that he reviewed, and a tumor in the brainstem involving the region of the olivary nucleus. Optic glioma in a young NF patient. And this was a fascinating one. At the time, there was a German description when in Vienna, actually in Austria, where Morris Benedict had described that he felt that the behavior of criminals was due to alteration of the gyral pattern that produced their aberrant behavior. And so he actually examined normal brains and found that some of the normal brains of people in Montreal had the same abnormality. So he concluded that Montreal either harbored a highly indigenous criminal population or that Benedict had failed to adequately examine normal brains. And so he actually sent medical students down to the jails after convicts had died and looked at the brains of convicts and found that they had had normal anatomy. It was amazing. So he had a huge impact on all of medicine, obviously, but neurosurgery at that time. He was a great American physician of that era. He was a pathologist, author, and humanist. Made many seminal observations of neurosurgical disease. And then I think a lot of these are interesting. If you dig through them, he made a lot of seminal observations of things that were later described and popularized by other authors. He published nearly 1,400 papers, and nearly 200 of them relate to this central nervous system. He started at McGill, but he was also a student and a friend of many of the early neurosurgeons at the time. He was a mentor and a friend of Keynes and a Cushing and Penfield, and I'll talk about that more because his relationship with Cushing was really important. He spread his influence through his students, and all of his students were promulgated his mentorship characteristics. There's a picture where they used Osler's head as a description of a surgical procedure. He was an important mentor of Penfield, who ended his career in Montreal and developed the Montreal Neurological Institute. So when we graduated from medical school at McGill, we got this Equanimitas, this small monograph that he published. And I took this quote out of the book. And I think this really embodies the spirit. And you can read this. So when a simple, earnest spirit animates a college, there's no appreciable interval between the teacher and the taught. Both are the same class, and one becomes a little more advanced than the other. So it's the students that stand on the shoulders of giants and take the field further. And that was his philosophy. Here's a picture at his desk, and this desk is sitting at the McGill Library now. And he was really one that, we should study the patients, listen to the patients, and let the disease be our teacher. He ended his career in Oxford, in England, and he called his house the Open Arms. Those students could come and visit anytime, unannounced, and he would welcome them and spend time with them. And I think that's really a key feature of his mentorship paradigm. So I'd just like to talk about mentoring and some of the things that I've learned over the years and some of the techniques that we use with our residents and junior attendings. So I think that these are important things. Tell me I forget, teach me and I may remember, involve me and I learn. The mediocre teacher tells, the good teacher explains, the superior teacher demonstrates, and the great teacher inspires. And I think this is the most important feature, is you have to inspire the young people. Leaders should influence others, but in such a way that it builds people up, encourages them, and edifies them so they can duplicate this attitude in others. So character begets character, and I think Jim Osman really emphasized that, and also Majid Sami. We need to learn from those with experience. We don't have a lot of class 1 and class 2 evidence in neurosurgery. A lot of the disease is variable between patients. It may be rare. We need to listen to the people that have the experience and build from their experience and not repeat the same mistakes that have been made by us all. So mentorship was the #1 request by millennials worldwide. Mentoring young colleagues provides a window into the mindset, challenges, pressures, and lifestyle of the younger workforce. The world is changing. They're changing. We now need to change, and as Majid explained, the world is changing. We need to find a way to connect with them and then allow them to better understand what they need. So we meet with all residents and faculty twice yearly, and John Kessel and I do that. We're the senior people in the department and the most developed academically. We talk about clinical development of both the resident and the junior faculty. We talked about educational efforts, and we get grades by their students so that we can see how they're doing as educators. And we talk about research productivity, publications, grants, and of course, H-index, the impact of their publications. So we need to give the young faculty time to develop their academic career. I don't want to see them become the busiest surgeon right out of the gates. We need to define their expectations for the academic development as well, if we're going to develop academic leaders. And we talk about funding and mechanisms to help them get funding. This is a problem that I see with a lot of young people in academics. There's a lot of Brownian motion that occurs in American neurosurgery, where young people start in programs or start in a department. They become busy clinically, and they say, well, my career is not being developed, so I could just do this in practice. And so that's a self-fulfilling prophecy. And it's up to the mentors to be able to define the imperatives in their career, help them develop their academic career so that they can sustain their academic career. Because this is what sustains us as we become more senior in our career, is the young people that come in, that challenge us, that learn from us, and then go on to become leaders themselves. I think these are a few things that I've learned over the years. All people want to succeed, but some people want to succeed so much they're willing to work to achieve it. And I think there's no way around this. It's really the work ethic that we must develop in the young people to realize that's what it's going to take. This is a field full of really smart and focused people. It's really, we get the choice of the medical students, and we really need to develop that aspect. This is something Charlie Wilson taught us. I never met a referring doctor I didn't like. It's no difference in private practice or academics. You have to treat your colleagues with respect. You have to be available and have great ability to take care of them safely. And this is one thing that I always remind our young colleagues of and our residents, that you're just beginning to learn how to be a neurosurgeon. We're learning every day of our life. And even as a senior neurosurgeon, we all get humbled on a daily basis because the outcomes are not perfect. And we need to learn from our mistakes and then move on. And I think Robert talked about that this morning. Behind every successful neurosurgeon, there are a lot of unsuccessful years, and be humble. I want to thank my own personal mentors, Marty Weiss in residency and Bill Findell in medical school. And also I was at McGill when Jules Hardy was at his heyday. And he really recognized the importance of Guillot. And I think Armando Basso talked about that earlier during the session. And actually, Jules and I wrote a historical contribution on Guillot just a few years ago. And Jules in his late 80s, and he's sharp as a tack and still very active. And this was a brilliant man. I think we've got a lot to acknowledge about his contributions, and this were discussed this morning by Professor Basso. So the mentoring principles that I personally impart to the younger people: be a leader at home first. You build your career like an onion. You start being a leader at your home with your team, with your colleagues, with your partners, with the nurses, with the medical students and the residents, and you build on that. Character influences character, and perpetual optimism is a force multiplier. I think, and Jim just referred to this, you can only lead as far as you've been yourself. So you have to demonstrate leadership every day, consistency. I'm still the hardest working person in our department. Organized neurosurgery is not a career in of itself. You have to focus on the core activity. Organized neurosurgery becomes a contribution you make as you've become established in your specialty, and then you can come and teach and have the honor of doing that. But it's not a career. You have to focus on your core activity with academic contribution, surgical expertise, and mentorship. Develop a culture of service to your workplace, serve on committees and the medical board, and be a community leader as well. And to your partners, step in and help. Serve our journals. They're the corn of the realm. They're this focus of truth for where we need to go. The boards for your specialty within your country, and organized neurosurgery in due time, as I mentioned. And be a mentor to all, at all levels. We occupy a very important nexus between clinical practice and basic science. And I focus that if you're going to do research and basic science focused research in neurosurgery, it has to be relevant to being a neurosurgeon. And I think that the most successful neurosurgeons that develop a research career focus their research on those aspects that neurosurgeons can only answer. The questions that arise from neurosurgeons, we should answer. And basic science that doesn't have application to clinical practice, I discourage for neurosurgeons, because why would you waste your time if you wanted to be a fundamental basic scientist, waste your time doing clinical work and spending all that time during the prime of your life training to be a clinical neurosurgeon, if this is your focus. So you need to make your research relevance to your practice. As far as women in neurosurgery, we've talked about that a little bit, and I really appreciated the talk earlier by the speaker talking about women in Germany. In America, we haven't done very well. We were 6% of board nurse certified surgeons in 2016, although we've got more women in training. Okay, so we're making progress. It's a heavy lift, and we need to improve upon that. We did look at amazing neurosurgical leaders in the world in neurosurgical focus recently, and I encourage you to read some of the articles there about the amazing people that have contributed all over the world. So academic productivity is an important one, and this is what we actually do in our department. We mentor all faculty and trainees on a research basis with regular meetings. We encourage grant funding for those young faculty that are tenure track. We have publication expectations and time management. And I think this is an important point that Majid mentioned earlier, is you need to teach people how to use their time effectively so they can be productive with clinical work and clinical write-ups during their clinical rotations, and then focus more on their science in their research year. And we emphasize being a physician leader in research. And then we have infrastructure as well to help residents and faculty get the papers published. And this works amazingly well in some people. This is one of our young faculty that's just come back, and during his residency, he published 130 papers. So if you develop an infrastructure and make it a priority, it can be very effective. So this is my personal pride. I want you to know that I'd like to see future leaders And we've been blessed that we've trained some amazing people, and we've just had our 9th department chair in America and around the world. And so, and academic recognition of several faculty. So as a footnote, I just want to get back to Osler and sort of give you a sad footnote, because he was 20 years older than Cushing, and Cushing considered him an amazing mentor. And as I said, this is Open Arms in Oxford. He married late in life. He married Grace Revere, who is a descendant of Paul Revere, and they named their son Revere. He had one child, and he married at age 40. And this is his son, was born in 1895. And his son grew up and then went into the First World War and was deployed in Europe, and in Belgium was shot and took a mortar fire. And the twisted irony in this whole thing is that Kreil was over there as a military surgeon, and Cushing was close by, and Cushing was called when Revere Osler was injured. And Brewer, Cushing, and I were in consultation. So Cushing came over and they helped operate on the young man, who was an extremist. And the boy's features were serene and a faint smile illuminated his face. Harvey held his pulse and I continued the transfusion. Large rents were found in the colon, much blood in the chest, and large wound in the thigh. Obviously all was lost. So it was a tragic ending. And Cushing, again, attended over the surgery of Osler's son, who ultimately died and is buried in Belgium. So in honor of Cushing, they've actually had commemorated a stamp in his name. He was a great person. He died at age 70 in England and was a great Canadian. And Cushing then went on and wrote the definitive biography of Osler and won the Pulitzer Prize. That people don't really understand. I think Cushing was a tremendous bibliophile and a great writer. And here's a picture of Cushing with Osler back in earlier times. So I thank you very much. I thank all of the young people and all of the organizers of this event, and it's an honor to contribute. Thank you.
Thank you. Thank you. Thank you very much, Professor Caldwell. We are very happy to listen to you. And as you said, tell me, I will forget, and teach me, I will remember. I'm sure that your talk was not only a talk, it was a teaching for every one of us. Thank you. Thank you very much.
Thank you.
We are going now to the next presentation. We are calling Professor Gretonius, who will talk on the future of neurosurgery training. He will talk on simulation and virtual reality in training of neurosurgery. Professor Gretonius, you have the floor.
Yes, thank you so much. I'm still a little bit speechless because of the last three presentations by Majid Sami, Jim Osman, Bill Caldwell. I think that should have ended this, this masterclass, because they were masterly presentations and so important for people proceeding with their career. So this is a little bit tough for me now to go into something more technical in the future of neurosurgical training. But I hope that everyone that have been present here will remember those three talks. Just amazing for me, and I'm at the end of my career, but still very much worthwhile. I have no disclosures, no conflict of interest in this talk. And what you see when I start with this talk, that I say this is the past, and I think that the majority, at least of the panelists who are present here, have been trained in that way that we call the master apprentice model. And some people even call it the master slave model, but it was the model that just meant that you followed somebody who was experienced. And an experienced person means that he was, as Bill Colwell was saying, already past the unsuccessful period and became successful. But it involved extensive clinical cases, operative exposure, more or less staying day and night in the hospital. If I think back to my very first years of residency, no more than 40 years ago, that was indeed the case, that you spent 80% of your hours in the hospital. And that was all that was present, but it was not really structured. That means it was just, you did this for an amount of years, 5, 6, 7 years, and then you were supposed to be ready doing it all by yourself. But nowadays, in at least in most countries, and I think that certainly now also in Africa, neurosurgical training is a structured program. It requires, let's say, around 6 or 7 years of training after graduating from medical school. And the minimum is that you have a certain amount of number of surgeries that you have performed. And also that somehow you are followed by developing your competencies that are necessary to perform this well. And that's not only doing the surgery well, but also treating your patients well. And this was actually also a Canadian model. The CanMeds were, at least in Europe, very much introduced to this. But this whole program that had been developed over 2 or 3 decades had some profound changes when initially in 2003, there was this introduction of the 80 hours work week limitation in the US, and thinking that they could, by that, decrease medical errors and increase safety for the patients, which actually at the end didn't turn out to be true. In Europe, where I have been in my career, in 2003 also, there was this 58-hour week, working week limit. And then 12 years ago, there was a 48-hour working week limit. But that inevitably meant that the residents, even if they wanted to stay, they had to be sent home and they could not see the cases. So they had less exposure to operative and clinical environment than in the previous generations. And this was a nice survey from Norway, where all the specialists were asked if they thought that 48-hour working week was right, or was that good to train them. And if you see that they say, well, blue means, yeah, 48 hours is about right. It's okay. Gray means it could even have been shorter than 48 hours. And red means, no. In 48 hours, we don't manage that. It needs to be longer. And you see that, except from thoracic surgery, but also neurosurgery, there was only a limited amount of people saying this is about right. And the majority saying, no, it must be longer for this specialty. If you compare that to all the other specialties, you see that many specialties think it's possible to do that. Why is that in neurosurgery? Why is that? We have to realize that the consequence of the working hour limits is that indeed the practical experience is less than it has been. And it was also concluded by some studies that it was less likely that residents could achieve competency in all the areas of neurosurgery to become a general neurosurgeon and practicing all facets of the specialty. But that in the same time, when this was going on, we have seen that patients are much more well informed due to the internet. Society demands that operations should be safer because they think there are a lot of mistakes over there. Outcomes should be optimized. And at the same time, that should be done by people who have less experience during their training. Then we have to look to the training and say it is not about how many hours you spend in the hospital, but it is about what you do in those hours that you spend in the hospital. So that means we have to look to a more earlier and also more goal-oriented training. The goal is having a well-trained and competent neurosurgeon, not just somebody who is always around, and it is about what you are doing in that time. So that meant that we have to also think about changing the thing of training. In my training, and I think in many others, in this master-apprentice model, it was just looking to the master, then assisting the master, then the master is assisting you, and then you are doing it. But it was always training on the job. That means in life surgery. And we started to realize that it is more important to adequately do this, maybe using other possibilities like models, and that is in simulation. I mean, pilots are trained, and we often look in safety with all the timeout procedures, briefings, debriefings, sign-outs to airline industry. They have simulators. It's more difficult to have real simulators. But we started to develop that and saying this should be, at least if we have this, have the intention to decrease the learning curve with these less clinical and operative exposure. And this was the hypothesis that simulation and also virtual reality will and can reduce the learning curve. And they should be able to improve the conceptual understanding of the whole complex anatomy that we have, and enhance the eye-hand coordination, the visual spatial skills that are needed for our specialty. And indeed, simulators would be an ideal way to do so, but developing those is not an easy task to really do something that is allowing to already make a step in the learning curve. And there are some models, and this one was described just about 6 years ago, but this is a model of a sheep brain, but you can dissect, there is a tumor inside, and you can do all the different steps from, let's say, the arachnoid dissection, doing the corticotomy, using the microinstruments, so under the microscope, using the CUSA to remove that. And this model even involves the 5-ALA possibility to show you possible remnants of that tumor that was implanted there. And you can rehearse this as often as you want. So you can look at specific technical skills, and you see the shortcomings and also the good parts of all the different residents. And that was indeed studied very well, and that you could say that it helped in building self-confidence for the trainee, but also they were absolutely happy with the handling, the learning of the handling of instruments, handling of microscopes. Well, also even with the comparability with human anatomy. So stepwise, you could say that this is valuable. And they don't always need to be very sophisticated types of models. For example, this model is developed for training endonasal endoscopic pituitary surgery. That means handling first with 2 hands, an endoscope and an instrument, then 3-hand surgery, 4-hand surgery. Do it in a team, and you can remove the middle part, and well, it is just a boiled egg. It could be half boiled or not boiled or soft boiled. You can place it there, but here it goes there that it's about the instrumental handling that you do in such a quite easy model that you open the cella, which is the shell of the egg, and then the resident should be able to remove all the yolk without damaging too much of the egg white, which is normal pituitary. And you can see how they do this step by step. And you can rehearse this as often as possible. And the costs are not that high. These are the costs of eggs that you will boil. So this is the possibility to do this and already start and allowing a trainee to have this eye-hand coordination and surgical manipulation before they even ever go into a live case, a real case of a patient. The same is with virtual reality. That's a completely different way, because there it is, and for the younger generation, that's more easier. We call it the Nintendo generation. They are much more used to computerized images. The big advantage is that you make 3D images of a real patient, so not general anatomy, but you then can rehearse the real case that is maybe scheduled the next day or in 2 days. Do that, and you can fly through the whole brain. And this adds to the conceptual understanding of the anatomy of that specific patient. You can immerse yourself, you're inside. That sounds so odd because in reality you don't. You are still in the outside. But now you have all the possibilities to practice the procedure and see all the different options. Because these virtual reality models doesn't need to, these are the images of the patient, but you make a model of it. They show you the whole pathology, but they show everything around it and allows you to play around with the tissue and see what would be the best way to do so. And especially for complex cases. And you all can do this without even opening a skull. And you can rehearse it again and again, just on a desk. And all this simulation and virtual reality will add to change the learning curve and to change the training of the future generation. Well, there are limitations, of course, and there is still a cost factor. If you want to have that for individual hospitals, it will be a major challenge to implement this, to have, for example, skill labs that will be not available everywhere around. And on the other hand, we also have to prove, but we see more and more publications that it has been proven that this technology indeed delivers what it promised. Shorter learning curves, less errors, better outcomes. And at the end, we have trainees that have a higher level of competency in neurosurgery. And this is what I wanted to tell you about these two facets, and I thank you for your attention.
Thank you very much. Professor Gretonius for this presentation. It was very nice presentation, and you show us what could resolve the problem of COVID-19, the problem of learning neurosurgery during this period of COVID-19. And the future is shown for all of us. Thank you very much. We're going now to listen to the last presentation from Professor Arnautovic, who will talk about international education in neurosurgery tips and experiences. Thank you, Professor Arnautovic.
Excuse me, Samuel,
sorry.
I just received information from organizer that said that Razulic is will present, so it will be the last presentation of the course.
Yeah, thank you, Abd Samad. We Lucas, he was in the second session, but for some commitment, he asked us to move him to the last one. So he will speak after Kenan. Thank you.
Okay.
Good morning, everybody, or good afternoon, or good evening, depends where you are in this world. You know, I'm really humbled, and I really appreciate the invitation by Professor Naja Al-Abadi and our teacher, Professor Al-Kamlichi, and also Professor Dakauri for this kind invitation to present my humble experiences in international education, neurosurgery. When I say humble, you know, what can I say about international education, about the giants who taught me about education, such as Professor Sami, Professor Osman, Professor Caldwell, a giant in United States education, and then, of course, my friend Grotenhaus. But I can talk about it because I'm one of you. I'm talking to the medical students, residents, and people, young neurosurgeons in the audience, about my experiences, about my unbelievable life story, which I'll partially present here, and talk to you about some of the techniques I use. So nothing to disclose. So as I said, I believe I'm really international person. I am born and raised in Sarajevo, Bosnia and Herzegovina. This is my hometown. I live in Memphis, Tennessee. I also, part of the year, I live in Washington, D.C. and Budva, Montenegro, where my family is. And I really understand the world as my home. I understand different cultures and different educational opportunities and perspectives. So as I said, I was born in one of the most beautiful cities in the world, host of Winter Olympic Games. And I finished my first education in neurosurgery there. And unfortunately, or fortunately, depend how you look to the twist, I was also imprisoned in the largest concentration camp after World War II, Sarajevo, during the war in Bosnia for about 1,425 days. So if you go through that experience, you really sharpen your life skills. What they say, what doesn't destroy you make you stronger, and kind of look at the life and education from completely different perspective. I then went to United States just to do some fellowship and ended up staying there, unplanned at the first, and ended up after my residency in Memphis in Tennessee. This is my city. They call it City of Three Kings: Martin Luther King, B.B. King, and Elvis the King. And as I said, I went to medical school in Sarajevo. I did my first residency in European style neurosurgical training at that time. And then these are some pictures. Probably nobody will be able to recognize me. And then I was fortunate to end up in UMS, University of Arkansas Medical Sciences, and be trained again full residency in neurosurgery. I'm currently in one of the powerhouses of American Neurosurgery, Sam's Murphy Clinic, for the past 19 years. And what they always say in the United States, it's there is no history. Well, when I looked, our university is 226 years old, and our medical school 170 years old. So this is our current lineup of our faculty, my colleagues. And I was really humbled and blessed to be trained by real masters and master teachers who taught me not only microsurgical technique, but out of all of them, I learned about this international education. I got early involved in it. So just to remind everybody, this is the definition of American Board of Neurosurgery about our beloved profession and all the things that we do in neurosurgery. And when I compare my old training and American training, I would really like to implement as much as I can what we do, how I teach now my residents, and put this curriculum of American neurosurgery as much as possible into the training. So it is about, it is 7 years training. This is all the competencies that my residents now need to go through, which end up with primary examination, which is a written board, about 88 passing score. And then about 3 years later, or 5 years, depending how long do you need to submit 150 major personal operative cases, you have to sit in front of the oral board. People who know you have to be excused from this examination. And then if you fail 3 times, hopefully it will never happen to anybody, you have to go back to primary written exam. So, and then you go through this grueling process of maintenance of certification. Every year I have to go through proving that I am not in any legal jeopardy, that I'm doing well in my hospital, that I passed all exams that year, submit my consecutive cases. And as a professor, full professor of neurosurgery, I have to go through this process as my junior colleague who just joined the practice. And then on the top, if that is not enough, then we need to go through medical stain licensure, license procedure, where we have to go through again every year to prove that we are not having legal problems, addiction issues, etc. And then these are the levels of educational teaching levels in neurosurgery, which we have to go through to become a full professor. So how do we evaluate the candidates for academic position in the United States? We do it through a very, very thorough and consequential analysis of their activities, from neurosurgical skills all the way from evaluation of patients, leadership skills, teaching in different lectures, etc. The ultimate goal also, which we are filtered through, is the one where we have eventually to end up, ideally, in some ideal world, without mortality, without morbidity in our patients' outcomes. The hospital stay should be as short as possible. Discharge home should be by noon. No surgery-related readmissions and no need for repeated surgeries. So, as I said, as a person who is being involved in education and international education in neurosurgery since I know about neurosurgery, I believe it's our obligation to teach the next generation of neurosurgeons. That means our own residents first, our own fellows, but also to decrease disparity of neurosurgical levels across the world. We have also to teach the young neurosurgeons from developing countries and to help provide better equipment and resources in those countries. So different teaching techniques, they are very complex, they are very, and I think we need to know all of them and utilize some of them on case-by-case basis, from learning the system and operative techniques to participating in courses, writing articles and book chapters, traveling to other countries, helping there with doing surgeries, lectures, providing equipment, bringing people to various neurosurgical courses, linking with them through social networks and video links, and encourage them to get into organized neurosurgery. So I think it's a true blessing when you bring this. When you bring these young patients to neurosurgery. I was honored to host 9 young medical students senior year in Memphis, and we provided them neurosurgical curriculum from Croatia. And after a course that we gave them for about 2 months, 6 of them ended in neurosurgery, 2 in interventional radiology, and 2 in some other, and 1 in other unrelated profession. And then what I also learned is that one of the most important ways to teach this young generation is this international courses, which we participated over the years in the United States all over the world, because that is one of the way when one-on-one, short of intraoperative instructions, you can teach young trainees how to do neurosurgical techniques. I was also blessed to be a member for the most part of this very well-known skull-base approach courses of Dr. Al-Mefti. And last year, I asked one of my fellows to put together a little historical vignette about it. And it was a blessing to teach all the people around the world and be a small part of this tremendous course. The other course I've been involved from the past 10 years is ANI course with my friend Ali Krisht in Little Rock, Arkansas. And that is another great course that and whenever I go to teach this course, is interesting. I learn much more than I teach. And I come every time with a new trick, with a new idea, with a new, and I benefit more than any of the participants there. I also was taught early on by Professors Sami and Al-Mefti and everybody who taught me that we need to publish in best possible journals, use good illustrations because they will illustrate our research better. Readership will be greater. And then when we show in our presentation, our outcomes, we need to honestly say good and bad outcomes and provide the audience with outcomes of our research and publication. One of these great, we saw it from Dr. Roton and then from Dr. Al-Mefti, was bringing this nice illustrations in the world of neurosurgery, which really enrich your paper and your quality of your presentation. And then when I said showing the outcomes, you have to show preoperative pictures, you have to show postoperative pictures, all the complications you encountered or good outcomes to the audience and to the readership. And as I said, when I publish, I quit publishing by myself. It's always a number, as Professor Caldwell said, and others, it's always a number of my residents and fellows who know much better how to put a good paper together. And I learn from them. I bring them idea, I bring them organization, but I learn from them much more than I teach them. Also, when you publish a book, by involving them in our work, they will really teach you a lot of different things in the process. And then lab training, not only during your training and during your education, but every day when you have time to go to the lab. I fought with these 2 guys in the lab in Little Rock for place around one computer, one microscope. And later we became great friends in the process. And later we really enjoy teaching around the world these different techniques. And one of the important thing is to stay in touch with your friends, with your fellows, with your residents, with your colleagues around the world. It's enormous pride, enormous sense of pride. It's enormous educational opportunity and also opportunity of great friendships. And then if you end up playing soccer like I do, and if you end up creating a team with Nelson Esiku, Ali Krish Mateo, and Mustafa Baskaya, you can even defeat your residents and fellows in a soccer match played in Little Rock a couple of years ago. So Professor Caldwell is one of my mentors, not directly trained under him, but I watch what he does and what he teaches us. And he said very important thing in his lecture a couple of lectures ago. Somebody, when I was training, said, "Oh, don't go in neurosurgery politics, you know, it's politics." And if you don't go to journals, if you don't become a reviewer, an editor, if you don't get organized, involved in organized neurosurgery in local, state, national, international level, other people will do it for you. So other people will be deciding about the outcomes and destiny of our beloved specialty. So you'll not become a president or secretary right away, but after 20 years you may, or 30 years, as our teachers taught us. So my advice to everybody, get involved early. It's a learning process. You need to learn a lot. You need to put a lot of your Saturday and Sunday and evening hours into the process. And then these are just some tips I'll go through before I end this presentation. I'll go quickly through them. You know, the thing that I learned in the process, always strive for excellence. Never take no as an answer, of course, for the right cause. Take a risk. Take a risk if it takes to go across the ocean to learn something, if it takes to sacrifice something, if you are in a life-threatening situation, don't worry, hopefully that will pass and you'll get opportunity. So never give up. Get the best possible training wherever you are. As Professor Grottenhaus showed, there are so many ways how to learn neurosurgery in addition to direct operative exposure. Be a mentor. Take care of your parents, family, and friends. This is one of the most important messages. Family and friends, kids, children, parents, one of the most important aspects of your life. Love your patients. As somebody mentioned before, I think Professor Osman, they are the most important part of your profession and one of the most important parts of your life. And then just a thing that I heard from my friend Jacques Marco some time ago, and I improved it, extended it a little bit. Predictable people behave on the basis of expected or known behavior. Responsible people are people who are reliable or dependable, expressing accountable or rational thought or actions. And rational people are people exercising reason, sound judgment, or good sense. So this world, the world that we live in, the world that you and I are talking from different parts, remote parts of it, rests on predictable, responsible, and rational individuals. But if you want to go to grow, if you want to go to higher education, if you want to build up better career, you have to go from the comfort zone to the past the fear zone, past the learning zone, and then go to the growth zone. Because that's the only way how you'll make the difference for yourself and for your patients. So the advancement of the world rests on individuals that were unpredictable, irrational, and irresponsible. At the end of my presentation, I would like, as a chair of International Programs Committee of American Association of Neurosurgery, to invite you to become members of American Association of Neurosurgery. This is I'm very proud that in my tenure, we have significantly increased the world participation in our membership. And you can see every year we update. I asked one of my ladies that I'm working with to update this table, and I'm proud of the growth we have done with international participation. There are great benefits, and I would like to invite all of you to the meeting that will be in Orlando, August 21 to 25th. We will break the barrier of no meetings in person. This will be in-person meeting with a Zoom option. So we'll meet in person. And I was honored and humbled to put together international symposium, which will take place August 21 and 22. Many of you in the audience are going to present, and I hope many of you will be participating in it. So I thank you very much, and I put you again in this great endeavor of international education.
Thank you very much, Professor Amno Tavi. Professor Al-Zahari.
Professor Sanusi, there is Luka Razulic. He has, I think he's ready, yeah? It's the last presentation. It's from the second session. He wasn't here before. So, Professor Razulic.
Continue, Al-Hadi. Continue.
Yeah, we continue the last presentation with Professor Razolic. Hi, Professor.
Good afternoon, good evening from Belgrade, from Serbia. Can you hear me? I believe that
Yeah.
everything is okay.
We hear you. It's okay.
I'm privileged and honored to be a part of this educational event. And my apologize for being late in accordance to the program due to some commitments, and I think organizers and especially to Nadia for understanding and giving me opportunity to give my presentation during this meeting, a part of the program as it was scheduled. I enjoyed very much these presentations from the Masters in Neurosurgery. And my presentation will be teaching perspectives in peripheral neurosurgery through internationalism. 7 days, exactly 8 days ago, it was a great joint venture webinar between Global Neurosurgery Committee and the Peripheral Neurosurgery Committee under the WFNS. And it was a great success. And I presented some of this presentation in this meeting. Since this is a very similar occasion, and I decided to present this presentation, which might be useful for a young neurosurgeon in especially in the low and middle income countries, and above that to the all other who are involved and participated in this wonderful meeting. So peripheral neurosurgery is very well known as an essential part of neurosurgery, but it is very well known that it used to be and still is abandoned and neglected by many neurosurgeons all over the world. On that circumstances, work of a committee of World Federation of Neurosurgical Studies for Peripheral Neurosurgery was strongly focused on the rebuilding the interest for peripheral neurosurgery within the neurosurgeons. Of course, with the primary, our activity is taking care about the patients with peripheral neurosurgery disorders. So I have no disclosures. Surgically treated peripheral nervous system lesions consider trauma, entrapment syndromes, tumors, and rare lesions. Cutting your nerve changes your brain. This is something which is more than evident and more than obvious. Comparing the situation about peripheral neurosurgery in a world of neurosurgery, this is something which might be compared with a phenomenon named quantum entanglement, which is physical phenomenon that occurs when a group of particles is generated, interact, and share special proximity in a way such that the quantum state of each particle of the group cannot be described independently of the state of the others, including when the particles are separated by a large distance. The topic of quantum entanglement is the heart of disparity between classical and quantum physics, which is not essentially essential meaning of peripheral neurosurgery within neurosurgery. So peripheral neurosurgery within neurosurgery obviously is not Einstein-Podolsky-Rosen paradox. It is something which is mandatory for helping the patient with a nervous system lesion, peripheral nervous system lesion. And multidisciplinarity and transdisciplinarity in peripheral neurosurgery is not quantum entanglement. And the nerve surgeon as a subspecialty might be a future of this activity. So peripheral neurosurgery and neurosurgeons, only 48.7% of the respondents believed that they had been given sufficient exposure to peripheral neurosurgery during residency training, according to WFNS member survey. And the overwhelming majority, 97.2% of respondents favored keeping peripheral neurosurgery as a part of the neurosurgical curriculum. These are reports on peripheral neurosurgery publications in major journals in 2020 and 2021, which is obviously a larger number of papers which is published in major journals of neurosurgery than it used to be 10 years ago. In PubMed, through additional filter with human specialists, only 67,550 articles are published related to the peripheral nerve surgery. But what are the criteria for class 1 evidence-based studies in these circumstances? There are many international multicentric double-blind randomized cohort studies which are very important for improving the knowledge, training, and efficiency in peripheral nerve surgery. But still, in peripheral nerve surgery, surgical treatment strategy and decision-making process is a matter of choice between class 1 evidence based on preoperative evaluation and coin flip based decision-making as a matter of intraoperative finding and surgical experience. This is a very famous photo from National Geography from the surgeon who operated the patient after heart transplantation and waiting after 23 hours vital signs of his patient. This is something, metaphorically speaking, how we are waiting our results in after nerve repair in peripheral nerve surgery, but it much more longer. It appears, it measured by months that we have to find results. So many of the neurosurgeons might not use this, might not take the peripheral nerve surgery as a choice of their practice. But if we are talking, when we are discussing about crisis versus opportunity or challenge versus opportunity, to change the big picture overview of this situation in the world, within the World Federation of Peripheral Neurosurgery Committee, we decide to take an opportunity to do that. There are biological challenges versus opportunities. Nerve regenerates, repair is possible, but the results are not better. Why results are not better? Results are good, but not good enough. Regeneration is slow, tough, and hazard. All nerve injuries are chronic, and reinnervation is misdirected. We are facing the challenges on peripheral neurosurgery in the 21st century in all aspects. Traveling through the road less travel and no man land in the so far practice. As we know, the global neurosurgical workforce, a mixed method assessment on density of growth appears that in the world there are approximately 49,000 neurosurgeons, with taking in account that in the standards are one neurosurgeons up to 100,000 population. This is a very difficult problem in peripheral neurosurgery, since in part of the world when there are not enough neurosurgeons according to any standards, there are extremely lack of the neurosurgeons who are doing peripheral neurosurgery. Learning pyramid in learning curve in general is something which was very well discussed through this excellent masterclass. And this is also in peripheral neurosurgery that we have to learn. We have a long process of learning. The true meaning of internationalism in peripheral neurosurgery is interdisciplinarity, and taking into account the geographical specificities in UK, France, China, Korea, Japan, orthopedic surgeons, plastic surgeons are doing predominantly this field of neurosurgery. In the United States, Germany, Spain, Italy, Europe, mostly neurosurgeons are who are doing peripheral neurosurgery. But true meaning of this internationalism is interdisciplinarity, taking in account geographical specificities with meticulous exam preoperatively and meticulous follow-up postoperatively by a surgeon. The peripheral nerve lesions are quite heterogeneous. There are no two lesions alike, and studying individual cases are more value, have more value, and cohort studies not reflective of real world, like according to the Heisenberg effect. So internationalism is tolerance towards the diversity, ability to look at things differently, accumulating experience by applying well thought over strategies, and exposure, surgery practice doing with our patients is conditio sine qua non. Another big issue is brain plasticity in following peripheral nerve system lesions, which appears obviously when you cut your nerve, you change your brain. And brain plasticity after brachial plexus injuries following different types of nerve transfers is one of the big impact factors for the final outcome, which can easily demonstrate through the following patients preoperatively and postoperatively using functional MRI. And these are some examples of brain plasticity following intercostal nerve transfer in reinnervation of the musculocutaneous nerve, also in treatment of the phantom limb pain. But talking about the future, my very close friend Karl-Heinz Land presents this book, Earth 5.0, Provoke the Future, in which he demonstrates what should we expect it, since we are all seeking the precision in our activities. This is something which we are facing right now in real life, in neurosurgery, in peripheral neurosurgery. Should the machine take primate according to comparing to the man, and is the machine more precise than a man, or vice versa? So is the peripheral neurosurgery as important as clipping an aneurysm or resecting a brain tumor or the spine stability? In a current standing, the art in the skill and the skill in the art, basic science, artificial grafts and conduits, augmentation of regeneration, phototherapy, electrical stimulation, quality of life is beyond useful functional recovery with some limitations, is something which we are facing in our activity. This is no master is born perfect. This is something which we all discussed today, and we have to learn and to improve our knowledge. This is courtesy by Jacques Morcos, some comparing how mentor and mentee are giving microsurgical sutures in different part of their lives. But frontal lessons with some hands-on cadaver lab stimulation, web access organized by ad hoc committees in classic format, as we used to do, leads us to the death by PowerPoint presentations. And interactive communication between faculty participants, discussion groups, breakout session, and hands-on activities are something which WFNS proclaimed a long time ago, and WFNS established foundation which might be a source for some, which is a source and might be even a stronger source for future perspectives in education, especially in low and middle income countries. WFNS training centers program continue with postgraduate training centers, full program training centers, and short period training centers. And the full program training centers, especially in Africa, are centers which might be used for increasing the level of knowledge of peripheral neurosurgery. And the WFNS Committee of Peripheral Neurosurgery discussed this issue very carefully and thoroughly. And we create a task force group of dedicated people all over the world who are ready to come in low and middle income country in coordination with the World Federation of Neurosurgical Society to spend some time and to give proper education according to the standards of the World Federation of Neurosurgical Societies in peripheral neurosurgery. So this is something which might be also interesting for future development in education. Communication is very important to inform the neurosurgical community, inform about neurosurgery. We heard about that in a presentation so far. Also, we heard about neurosurgical digital teaching in low and middle countries beyond the frontiers and traditional education. These are some of the examples how it looks like, how it works around the world with a possible solution education via web, with surgical theater, education via stimulation, and the role of mixed reality stimulation and upsurgeon platform for education, including neuroanatomy, 3D series. But the weakness of internet learning is no quality control in some sites, and every surgical approach can be posted even if it requires a long training curve and need for a place where to display approved guidelines and procedures. Use of web technologies is, of course, in everyday practice. Telemedicine can be given even by a phone for consultation, and this is something for responsibility and control for the referral of neurosurgical centers. But now a few slides of real life. This is some cases of neurolysis, and taking in account that there are no equal standards of education, there are no equal possibility of equipment, there are no equal funding resources for education. Our let's say policy in the World Federation of Neurosurgical Surgery Society's Committee for Peripheral Neurosurgery is so-called KISS strategy, keep it simple surgeon. This is direct suture cases, nerve grafting cases, which is now standard interfascicular grafting cases, which is something everyday practice in peripheral nerve surgery, in nerve repair, modified cable grafting in different nerve lesions. And of course, we have artificial nerve grafting in our armamentarium. This is a nerve transfer procedures, Oberlin procedure as an standard procedure. All these cases is from my practice. But now we are going to the robotic surgery, which shows us in a cadaver trial in peripheral nerve surgery that it is possible to do endoscopic exploration in the repair of brachial plexus with robotic manipulation. This is an experience from Brazilian group that they very clearly demonstrate brachial plexus elements. Even they performed nerve suture using robotic surgery. This was firstly cadaver trial, but then they go for patients, and they also use Da Vinci robot for Oberlin procedure in a few cases, and Somsak procedure also with Da Vinci procedure, with Da Vinci robot in few cases, with some fine outcome in this series published in respected journals, with usage of artificial intelligence in development of peripheral nerve surgery, going to the one goal which we have. This is a quality of life of our patients. These are the patients who are operated with peripheral nerve lesions coming back to the everyday life and their functional life. So education and transdisciplinarity is of outstanding importance. There are some examples of activity of peripheral nerve surgery through the World Federation courses. We, in 2015 and 16, performed online educational course with more than 400 registered neurosurgeons all around the world regarding peripheral nerve surgery, with certificate of this in the platform of Argentinian Society of Neurosurgery. We so far organized 4 theoretical, practical, and hands-on cadaver courses from 2016, especially devoted to the peripheral nerve surgery. And COVID-19 outbreak started from 2020 and still is ongoing. This is a courses from Leon, Spain, and then Belgrade, Serbia, and then Frankfurt, Germany, and then Buenos Aires, Argentina. Forthcoming courses which are planned are in Rio de Janeiro, Brazil, Rovigo, Italy, Dubai, United Arab Emirates, and we will gladly organize these courses in Africa and United States with support of local representatives, with some perspectives in development of nerve repair, which are devoted to the more efficient surgical techniques and application of non-suture techniques in nerve anastomosis or neurotubules, pharmacological activation and stimulation of nerve regeneration, expansion of knowledge of neurotropism and neurotrophism, concept of cell neurosurgery and non-neural tubulus. For the hand of the surgeon, in my opinion, hand of the surgeon will be irreplaceable impact factor, despite how the world would like in 21st century, especially in peripheral nerve surgery. So keep it simple, surgeon, and let's work on peripheral nerve surgery. This is some of our publications published by different publishers, international, very well-known publishers, but are written by members of the WFNS Committee of Peripheral Nerve Surgery. And we also need to help our colleagues to publish. This is also some of part of our educational process, as we heard today. So hands-on courses, on-site training with the financial support and foundation of the continental national societies and web-based activities should build up a bridge between countries with more and countries with less resources. So keep calm and raise awareness and love of brachial plexus surgery. And I would cordially like to invite a lot of you to confirm your participation in, and thank you for that, for our 7th annual meeting of Serbian Neurosurgical Society, which will be this year still online. But next year, our continental meeting, Congress of European Association of Neurosurgical Societies, will be hopefully opportunity to gain together in person and to refine the art of neurosurgery as we used to do it before the COVID times. Thank you very much for your attention.
Yes, Harry. Thank you. Thank you very much, Professor Al-Azhari.
Professor
Are you
Azhari, we
online?
can't hear you. Professor Azhari, we can't hear you. Will you turn on your mic, please?
Okay, thank you.
Unmute yourself.
Okay, thank you. Thank you, Luca, for this interesting topic. Is there some question for the panel, please? We have time for question, Najia.
I may.
Mahmoud, please.
To Andrea.
Yeah, Moody.
Yeah.
Yeah. I mean, exceedingly exciting talk about the future of how we should train and obviously get technically proficient for our future generation of neurosurgeons. It appears to me that it's a pendulum, really. Here we were in the past, mentor with mentee, direct teaching. And then in the future, because of various reasons, legislation about number of hours, et cetera, we want to go into the lab and use AI, things like that to Andre had to do something.
Yep, he had to.
So here is the pendulum. And the worry is, where will the pendulum stop? Because at the end, when you look at the past and the training that was there was a lot of empathetic contact with the patient. And you were a doctor. As the pendulum goes towards AI and technical proficiency and lab-related work, you become a technician and you become less of a doctor. And we do see that even now. There are residents who are trained in certain parts of the world. They come back and the patients rush back to us and say, I really don't want to go to that patient, to that doctor. I say, why? He is very well trained. He says, I walked in, he did not talk to me. He took my MRI, put it on the screen, and was contacting the operating room to book my surgery. He did not talk to me. He did not want to know me. It was just looking at what pathology there is and started describing to me how wonderfully he can take that tumor or disc out and fuse me. So we are in that danger of losing, becoming the doctor, as we were being explained by Jim Osman and by Professor Majid Sami, and becoming the technician where we will be very proficient. So I wonder how we are going to get that balance right and where that pendulum will stop. What are your thoughts on that?
Modi, I think that what you're pointing out, that is one of the dangers, but it is also a kind of mentality in the general population that it is all about techniques, and we forget about the human factors in it. To be honest, in these models, it is actually a very close one-to-one mentor-mentee thing you do. So it is. So there's still a possibility, and of course, this can never replace the role model that you have when you decide to have a training program in neurosurgery. So that means you take on the responsibility to train somebody who at the end will then do neurosurgery for 40 years. And that means treat fellow human beings. And if you are not the person who, I mean, this was what Bill Caldwell was saying in his fabulous talk on mentorship. And Osler was a great mentor. I read a lot of this, and also the book from Cushing about Osler is great, and he won the Pulitzer Prize for that, indeed. But it is the if you don't show the honesty, how should your trainee know what is honesty in science, in clinical practice? If they don't see how you treat your patients, you go there. Also, I mean, I always I visit my patients during the weekend. It doesn't matter if I have I'm on call or not. I'm not on call anymore because of my age, but I always visit them. Why? Because these patients expect to see me because they have questions. And if my residents see what I do, if they do it themselves, I can't influence. To be honest, if we take residents into training, they are adult people. They have been raised by their parents. They have went to school. They have already developed personality. So I can't really change them as a person. I only can show them how they should develop further as being a neurosurgeon. And that is what I really very much appreciated about my own mentor. He always said, I know you're residents, you want to do surgeries, but he said, surgery is about this. Neurosurgery is this. It's that much before and that much afterwards. You should do this very well. This little part, this 1 hour, this few hours of surgery, excellent. Of course, you are trained to do that well, but to be a surgeon, like John Garfield was saying, you can teach a baboon to operate. You can never teach a baboon not to operate, because it is not only operation. And that is what Majid Sami said,
yes.
Jim Osman, Bill Caldwell, everything, all three of them were exactly telling this. There is more in this specialty. And I think we have the obligation to bring this also into training. And it is an experience. To be honest, every trainee has to experience it herself or himself. And I know that the most difficult part for them is when they have their first complication. I had some of them crying in my room and wanted to stop with the specialty because they had a terrible complication. I said, you have now to go to the patient and to the family, because they had the tendency to avoid. They don't want to go inside. I said, no, now you have to be there for them. You have to be there in that period. And the interesting thing is that all our patients understand that our intentions are good, but the results are not always predictable. And they can understand it. But if you don't go to them, if they don't speak to them, that is the difficult part. Then you have problems. And we discussed it yesterday with Keki's conference on complications. That is the part. Because we all have complications. We all have. And the longer you work, the more you have. And when I was young, I thought when I become older and more experienced, it will be easier for me to deal with complications. I can tell you the reverse is true. It became more difficult to deal with complications because you don't accept it yourself, because you think this can't happen. After 30 years or after 40 years that this happens. This can't be true, but it is the reality. And we have to tell them on forehand, it's a lifelong experience. And I think the greatest joy that you have is indeed the contact with your patients. It's not the success of a surgery, that's a short-lived thing.
Thank you.
Relationship with patients, that is really what makes neurosurgery such a wonderful specialty. And we have to tell them. We have to say this, and this is a part of it. It's not a technicality. It's important, but not the essence.
Thank you, Andre. Is there some question?
Samad, may I say a word, please?
Professor Khamlichi.
You hear me?
Yeah.
Yeah. I think that the question of Mahmoud and the answer of our colleague Andre Greatness is summarizing all the topic of our course. When we decided to choose the topic of the course, challenges of education and training in neurosurgery, our goal was not only to emphasize the technique, the technology, but our goal was the other aspect. And I am very happy with what was said, and I am very happy also that the colleagues with great experience attended, participated, accepted to participate. I think this last session with the topic of our great mentor for African neurosurgery, Professor Sami, the topic of Professor Osman, the topic of all the others, Caldwell and Andre, were really a complement for this technological and technical aspect, because we have seen the training is not only is the motivation, is the mentor, is how and is the patience. The most important part is the patients. We learn from our patients. The priority is the patients. So I think that this was the reason why we have chosen this topic. And personally, I am very happy at the end of this course, and the organizers, Najia with FED, have chosen and organized the sessions in a way that we had 2 sessions for techniques and technology, and then one session for all the other aspects, which are the most important aspect we are facing today in the training and education of young generations. Thank you to all the speakers, and thank you for this comment.
Thank you, Professor Khamlichi. I should conclude if there is no question, Najia. Thank you for all speakers. Really, it was very, very interesting. I remember my dean, Professor Harouchi, was the pediatric surgery. Now he passed out, but he said always in the university committee, he said as there is no bad student, there is only bad teacher, and that is what I keep from him, and I found that it was very interesting phrase. So as Professor Majid Sami said, motivation, everything about followers. I all the time our resident, and when I was resident, I wanted to operate. So resident want to operate, and it's normal, because every brain have his age. So always I say to the resident, don't worry, you will operate all your life. So start to understand how to operate. I think it's a very interesting session. And today we have we are very lucky to have very good teachers. So I think we will have very good followers. Thank you very much for all the speakers. And thank you, Najia, Professor Khamlichi, and Fahd for organizing this very nice and very interesting. We see all the aspects of the education, the technical, the philosophical, and all the advices of the best, all the best neurosurgeons from all over the world. Thank you very much. Najia, you have the mic.
Thank you so much, dear friend Samad, and also thank you, Sam, you are here. Thank you for this excellent moderation, and to be in little bit in the time. And we have with us Professor Tito Perea. He asked to maybe a question or a comment. Tito, you have the floor. And after Kenan, after you can have you can speak.
I didn't see him. Hello, my dear Tito.
Hello, Professor Khamlichi. First of all,
it's a pleasure to see you.
And good evening, good morning, and good night for everyone. Really, I want to say that my congratulations, Professor Khamlichi and Naja, because this webinar and your Congress show the really importance to miss the experience of the master. And beginning of the name, when I saw the program, I see they are doing exactly the point for teaching young neurosurgeons and take the history and the experience of the master. Dr. Mahmoud Karachi made one important point after the talking of Dr. Andreas Grotenius, who was fantastic and maybe will be the future for teaching in neurosurgery. We cannot forget it, the history and the value as human beings. Because even at the time of Kuchin or Dandy, and later the personality of the big master, Dr. Yasser Gil, of Dr. Sami, or Dr. Basso, or many of you, in our memories will be take this balance between one real man who has been neurosurgeon, to have two parts. one will be the heart, the human being. We never can forget it, that the issue is we make everything for help the patients. And if we, in our life, we conduct it and work in that way, and teaching with the example. I know Dr. Grotenius says, I was in the weekends, for sure, all of us, for many years. First, we are looking the human beings and later the science. And congratulations for all panelists that give this nice example today. We wake up 5 in the morning to be 4 hours, 6 hours, listen each other. It's amazing and sad that we can see face to face. But even in this time, with your pictures and with your videos, we can share this essential part of me. All life will be neurosurgeons in the same style, and our responsibility is try to tend the near neurosurgeon and the future generation, that we will have another big technology that they can forget it a little bit, the human beings, that we have to take care of that part. And really from my heart, congratulations and thank you so much for this wonderful meeting. Thank you.
Thank you so much, dear Tito, for this relevant comments. And of course, you are welcome, and we are very, very happy to have you among us. And all of us knows that there's no future without history. You are definitely right with your comment. Thank you so much. And maybe there is another comment or question by my dear Kenan. You have the mic.
Yeah, thank you, Naja. I want to ask Professors Caldwell and Sami, and this is a thing that I think about very often leading the international program in American Association. You know, we are all enthusiasts of international training and go around the world and teach, give lectures, operate, etc. But how do we recruit people from our organizations, big, powerful neurosurgical organizations such as American Association of Neurosurgery, German, Japanese, the ones that have a lot of good qualified people, great resources, power, that we can elevate this education to the higher level, to the next level where we should go. Because I think that part is lacking. And do you have any tips or suggestions or ideas how to improve that? Because after all, we need also troops for education. We need professor troops that can come along and educate the younger generation. Thanks.
Thank you, Kenan. Maybe Bill or Professor, there are answers to the question of Kenan or the comment of Kenan. Bill,
Let
please.
me defer to Majid, and then I'll make a comment.
Yeah, Professor Sami maybe first. Yeah. Oh.
Unmute yourself, Majid. Yeah, yeah.
Yes, and now your question is a very, very broad, need a broad discussion, and therefore, please tell me exactly in which direction you mean for selecting people, or could you tell me a few words, then I can give straightforward the answer.
So how to motivate our partners, our colleagues from our associations to be more involved in international neurosurgery, to give their due contribution to the less privileged trainees in the world, and to privileged, doesn't matter. I see a lack. I don't see many neurosurgeons from Germany in this. I don't see. There are a lot of neurosurgeons from the United States, but I don't see enough based on the size of our organization.
It is most important question existing around the world, because I have unbelievable experience to this issue you just raised to discuss. As I started in, you must imagine, it is half a century before 1970, I started with the courses for microsurgery, 1970. Some of people were still at kindergarten, you know. And why? Because I had 5 years, about 5 years experiences, and I saw this is the future for neurosurgery. Without microscope, we cannot continue to develop neurosurgery. And then I started to ask people to join me. And that started at that time. Who is really ready to sacrifice his time, energy, and come and help? And this is the last 50 years of my experience. I can tell you, you are absolutely right that the number of the people who are sacrificing his best time. I tell you, I give you one example. In my age, a Saturday at today, all the day I'm sitting here listening and talking. This is unpayable. This is for my health, for my life, for my family, for all. I could take this day, but I enjoy to sit here. This is, I tell you, something character. If it is existing to share with the other people or not. Unfortunately, if you look around the world, I think in the talk of my friend Jim Ausman, just in some part, he said, if you talk around the world, who is ready to sacrifice his own for nothing, just for giving education to the other people? 1% is a high number. And therefore, I am not disappointed when I see the other people say, my God, it's my weekend. I want to enjoy my life and those these or others, or they refuse to travel. I tell you something. As I become president, you must imagine, everybody knows around the world, of China International Neuroscience Institute in Beijing, from government, officially, I am still the president in China. At that time, it was official certificate I become early 2000. My colleagues in the medical school, all professors, do you know what they asked me? Professor Sami, how many money are you receiving from China that you are doing this job for the Chinese people? Professor, well-educated on the toppest level in my faculty. This is, I think, the answer to you. Because we are all working voluntary and we are giving our energy, but we love it. And this love, what I am explaining, is not existing in the heart of everybody. And don't be disappointed. That was in the past, so it will be in future the same. There are only few people are ready to. When I remember the first course I had the first education in Sarajevo, that you were the person who motivated me to come to Sarajevo. It is 79. How? That is already more than 1 year, you know, that I came there to teach them microsurgery. You told me you have to talk and explain microsurgical techniques for, and still you are running it the same way. But look at many colleagues in the time you have seen what happened. And therefore, I am in an age that nothing can disappoint me. I say, I choose those people I see that they have DNA of giving, not only taking. you know, and these people we need it. And I think all speakers today here, we're talking, we're listening. They are those people you are asking for. Please ask them. They are all ready to support your idea. Thank you for this question. That is the most important question you have done. Not you. Today we have discussed about that. Thank you.
And I think that you know, Professor Sami's devoted his you know, latter part of his career to international education, and I think you exemplify. You're a citizen of the world, Kanan, and I think you understand it. And I think everybody on the call, or all the panelists today, understand this very well. I think, you know, I'm quite optimistic about this, to tell you the truth, because you know, comparatively, when we traveled a lot 20, 30 years ago, there was huge differences in the quality of care in different countries. But I'm amazed to see how some of the countries, I mean, I operated in China 25 years ago, and it was amazing to see the variability in the quality. And the world is flattening. Technology has helped, education has helped. And I'm quite optimistic, and I think we do have a cadre of people that are really devoted to it. So maybe I'm Pollyanna-ish about the whole thing, but I think the future is very bright. And I think that this technology, in part, that's been forced through with the pandemic, has actually helped with leveling and flattening of the world. And I look forward to start traveling again, obviously, but let's all pull together and try to recruit our young people and try to make education at all levels, both local, national, and international, a priority. And I think it's the leaders of the specialty in each country that need to promulgate that. So thanks for the question, Kanan. It's great to be involved, and thank you, everybody. It was a great session.
Thank you very much.
It was indeed.
Nadia, we have
I think
to thank you.
it's, yeah. Thank you so much, Professor Majid Sami and Bill, for this, for your answers. And we know we can't say anything after Professor Majid Sami, after he said he is always right. It's right. It's a character. When you want to, we need to be volunteer if you want to do something like this. This is, of course, obviously things that we need in our life. So before ending this master course, I have the hard task today to try to summarize this nice and wonderful course. So let me attempt to summarize this master course. It's not easy task, as you know, to speak after all these giant neurosurgeons. First of all, I would like to thank all attendees. And we are proud and glad to announce to you that we had more than 350 attendees only from Africa, but also around the world. We have to thank also all the neurosurgeons working on the Rabat Reference Center, which should be called Moroccan Reference Center, because it includes many centers. I think it's about today 11. In Rabat, we have 4 centers, the Department of Neurosurgery of Professor Khamrishi, and now led by Professor El-Wahabi. Thank you. Professor Maqili, he is the chief of the Department of Neurosurgery of Hospital Ibn Sina. He succeeded me in this department. Professor Gazez and Professor Mustarshad in the military hospital, and my team, of course, in my department. And in Casablanca, there is Professor Azhari, who is now the chief the department in the Sheikh Khalifa Hospital, and he was the chief department in the public hospital and the Department of Neurosurgery of Casablanca. And now Professor Al-Akhdar, he is the chief of the department, and at the same time, he is also our president of Moroccan Society. in Marrakesh, we have in Marrakesh we have two departments, and I would like also to thank Professor Ait Ben Ali. He is the first department head in Marrakesh, and Professor Aniba also. In Agadir, there is this young university with the Professor Mejati. In Oujda, it's in the east of Morocco, where the Professor Mofid. In Fez, there is a university for now. It's I think it's 20 years, and the head is Professor Shawi. And finally, the latest one is in the north of Morocco, and you know it very well. Many of you know for Tangiers with the Professor Agori. So thank you so much to all this team for this wonderful cooperation for our Rabat Reference Center. So we are thankful as well for the attendees today. Of our WFNS honorary president-elect, our president-elect, dear Nelson, all the committees participating to this master course, all the speakers, the moderators, without forgetting, of course, our sponsor. So after the opening of this masterclass, a message from the president of the WFNS, Professor Franco Cervedei, and the amazing message of the WFNS ambassador to Africa and the honorary WFNS president, Professor Majid Sami, the kind message of our president of CANS, Professor Mahmoud Qureshi, and obviously our mentor and teacher and the creator of the infamous WFNS Rabat Reference Center, Professor Abdsalam Al-Khamnish. We started the first masterclass, which was moderated by my friend, Professor Wahabi. I would like to thank our friend Yuko Kato for such a great communication in which she paid homage first to the late Professor Alexander Potapov. Her presentation emphasized the technological evolution, especially artificial intelligence and simulation. She also talked about the transfer of technological insight for not only neurosurgeons, but also nurses and all the medical staff. Great thanks to Professor Young too for this amazing talk and the management of complicated location aneurysm, which raised many questions among the attendees, as you remarked. Sorry. We are really impressed by Professor Spitzler technical skills and his ability to operate the skull base or even the brainstem without retractors. Professor Spitzler also talked about the importance of anatomy. He said anatomy, 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 which is the cornerstone of our practice. What can I say about my dear friend, Professor Armando Basso, who did such an amazing job of painting a beautiful picture of the history of skull-base surgery. Not to forget about what he did for the WFNS and the WFNS Foundation. Thank you, Armando. The discussion of the first session was very insightful with a great message from Professor Majid Sami, Armando Basso, Professor Spitzler concerning minimally invasive skull-base surgery, which is a skill we can only acquire through experience in the operating room, a long learning curve that we all have to go through. An important message to share with our young neurosurgeon is to respect neurovascular structure by starting by debulking the tumor, which allowed to create a corridor and more workspace. Dear Heldo, what I can say, you give us a wonderful talk about this controversial topic about the efficiency of the compressive craniectomy in severe TBI. And the questions raised from the attendees is a proof of its relevance. Thank you. We would like to express our gratitude toward my dear Ulrich Eisenberg, who made a great summary of this, the history of women in neurosurgery in Germany, and remind us of the contribution of the German society in developing neurosurgery on a global scale. And thanks also to my dear Moody for this very interesting talk and for reminding us about the numerous international cooperations and all the personality that contributed to the development of neurosurgery in Africa. Among them, most of them are here today. All the programs and all the work done during this last decade. Dear Nelson, I hope that you are here. Thank you again for accepting our invitation and sharing your valuable knowledge about manuscript preparation and all the advice that you give today to our young neurosurgeons. We greatly appreciate your conclusion, which was send your publication. Would be delighted to give our opinion. Thank you. This session was really stimulating in many ways, and the presence of the chairman of the WFNS Wing Committee, Professor Suad Bahti, really she shed a light on the discussion that emphasized the importance of women in neurosurgery network around the world. It's a tremendous honor to follow this talk. Professor Majid Sami, every slide is a take-home message in itself. It's just a phenomenal talk as always. And for young academic neurosurgeons, this talk should be listened to again and again, which you can do on our YouTube channel for perfecting your learning. As you wonderfully said, dear Professor Majid Sami, if educators and trainees are successful together, they can reach even more. Professor Osman, a great man, give us one of the major message, which is to truthful with the patient and also with yourself. Thank you very much for this wise advice. Professor Caldwell, our dear friend Bill, give us a speech about mentorship and what a mentorship should be. Mentorship comes from Homer's Odyssey, as you know all. He's a wise, trusted advisor, someone who gives knowledge. The protege or mentee is the person who receives it. This process can be both professional and personal. He also gave us his own experience. Thank you for this. And I personally greatly appreciate the quote, behind every successful neurosurgeon, there are many unsuccessful years. Stay humble and stumble. Thank you, Bill, for this quote. I would also like to thank my friend Andre for his amazing talk. And he always gives us the latest innovative techniques and cutting-edge tools, especially on simulation and virtual reality in neurosurgical training. Thank you, Andre, to being with us today. And we are really impressed by the courage and the resilience of our friend Kenan, who, despite all the difficulties he went through his life, managed to develop neurosurgery around the world and continue today to give more and more education in USA and around the world. And dear Lucas, thank you for being with us today, despite your busy schedule, to share with us your huge experience about international education and neurosurgery. So thank you so much for your attention and for your contribution. This is my team. This is the local when we organize this master course, and many thanks to our all the team of course Professor Khamnishi, Dr. Fahd Al-Qawi, Dr. Alas وعمه Dr. Reem Barodi. It's a really amazing team. I hope that everyone have a team like this. Thank you. Thank you. So thank you so much. Maybe the last word, I will give the last word to my master, Professor Hamlishi, to maybe to close this master course if there is no comment before. Thank you so much. I stop the sharing.
Thank you. You hear me? It's okay?
Okay.
Yeah. Thank
Professor
you.
Hamlishi?
Yes.
Are you here?
Yes, I'm here. Yeah, I think
We hear you very good.
I have a problem with my okay.
Now he's muted.
Yes. Professor Hamlishi, can you
okay?
unmute yourself? Yes. Yes.
It's okay now?
Okay.
Oh, thank
yes,
you. Thank you very much, Najia. My word is to tell you how I'm so happy today. First, all what you have mentioned among the colleagues taking care today of the WFNS Rabat Training Center and the way you have organized this course and the way you have followed the presentation and summarized the course makes me very, very happy for the future of neurosurgery in Morocco, for the continuing contribution of Moroccan neurosurgery in the African neurosurgery and its duty with this training and education started now more than 2 or 3 decades ago. And also what I hope more is, as I said this morning, to see the Moroccan neurosurgery continuing and having the place it deserves at the continental and at the international level. And the second thing why I am also so happy is, of course, to see these outstanding, worldwide known and masters of neurosurgery. And the first one, of course, is Professor Majid Sami and Armando, James Osman, all the others who are supporting the Moroccan neurosurgery and African neurosurgery, but especially to see Professor Sami, who was since now 14 years, when we started the first course in Rabat, he was always here. He attended every time, although we all of us know how he's busy with one institute in Hanover, the second one in Beijing, following everything. Why he's doing that? And I was so happy to listen to him. But I knew that. I mean, this I have heard from him many times. The way he's committed to the neurosurgery and to the patients and to educate people worldwide. And I would like also to tell him that my contact with him and the long time we have passed together every time, either when I was visited him, when he visited Morocco, when we were in the meeting, had a great influence also on my own self and on what was done, I think, in my country. In 1978, when I came back from my second training, because after having trained in Morocco, I went to France, to Switzerland, and then when I came back, I have witnessed the difficulties we have in our hospitals, in public hospitals, and also I witnessed how the private practice was so easy and can allow you to earn a lot of money. But thanks to what I have seen and what I have learned from Majid, earlier in the 80s, we thought that we have to create foundation. We have to take another way to help and to support neurosurgery in the public hospital. And I think that this work, since now exactly 33 years, we create a foundation which allowed us to finance the promotion of Marrakesh to organize the World Congress, which allowed us, very, very important, to create the National Center for Neurosciences in Rabat, since now 15 years, to be able to ensure a worldwide class training for African young neurosurgeon. I think for all what I have mentioned, Najia, you have given me the opportunity today to express my happiness. And thank you to all of you, either all these colleagues who were with us and supporting every time, and today this center supporting African neurosurgery, and also especially locally for all of you who are giving me the insurance that this will be continued for future. Thank you so much.
Thank you, Professor Khamnishi, and thank you to all of you to support this course. And we are very happy and glad to see you. And we wish that we can see each other physically in very, very soon. Thank you so much. And I hope that you enjoy your afternoon. And so sorry, Professor Majid Sami, for all the day, such a day is spent with us. It's an honor for us. So thank you so much.
Yeah,
thank you
but
for
what
all
was
the
necessary?
speakers.
Sorry, what was necessary to have for Majid is to have all of them here in Rabat, and to have with Majid a golf party in Dar es Salaam. He knows very well the golf course in Dar es Salaam. We played many times. And this, I hope we can do it next year, my dear Majid, and my all dear friends. Next year, I hope we will have you in person, really.
All the speakers, all the attendees here are invited, of course, for a party of golf. Even if for those that not playing golf, we can find another
maybe a good dinner. Maybe a good dinner. I don't play golf, but
the good dinner. It's the basic thing from Morocco.
But Nadia, you have.
Thank you so much for everyone. Thank you.
Nadia, you must be sure that all these ladies and gentlemen are attending. They are all your fan, and of course the fan of Morocco, and the Morocco country has started to open everything to Africa, and you never ever will be forgotten. And I have really to thank also all colleagues who were talking. I could really say that every of them has contributed a lot. I spoke about Mahmoud, his contribution to Africa, and he is really supporting so much that I am convinced everything is good in good hand in Morocco, also in Africa, also that the team is growing and growing. And this is wonderful to see that even from distance. We were talking about DNA of the people. The Bill from United States is one of the exceptional people that attending so much to many different congresses. I told him once, you cannot imagine your participation in the congresses, and wherever I went, I saw him. And there are people, they have to be recognized. We should not forget the Yoko Kato. Her life is dedicated to neurosurgery, to the world, particularly to other. And I must say, Canon, And I have seen also our friend from Latin America, the Tito, and many other. And I am sure that Africa is on the right way. And I am sure we will have in 10 years, please, if I am not alive, please remind you, you will see Africa become a golden continent in neurosurgery, and everybody should but remember.
Thank you.
Thank
you so much.
Great time
Thank you so much,
I
Professor
spent with
Sami.
you all. Thank you very much.
Thank you, really. Thank you for all.
Bye-bye.
Bye-bye. See you
Bye-bye,
soon.
everybody.
See you soon. Bye-bye, everybody. Thank you
Gracias.
again, and
Thank you.
wish you a nice weekend.
was a